design of the tool starts initially with a scoping review of mainly of this convergence between value-based healthcare and integrated care. In this review, we identified the key concepts behind the convergence of these two concepts previously said. And with these main concepts, the core research group, we designed a first version of the questionnaire. Later, we performed external validation with 10 experts, and we have done the pilot tests. So at this stage, we have using 4 regional systems in Spain and in 10 hospitals. More than 250 professionals have been involved, and in the implementation process of this tool, the satisfaction has been high, and particularly for us, it has been said by the managers the use of the questionnaire has catalyzed real strategy shifts in these organizations. This is the questionnaire. It still is not in the public domain. It's based on 40 items and 9 dimensions, but by the end of the year, it's going to be publicly available. So what we have learned in this process, that organization at this moment needs to have tools that generate fruitful conversations and dialogue inside. This multi-stakeholder dialogue is essential for driving change. Benchmarking between the organization and how they are dealing with change is also important. Culture and leadership are critical levels. And just to finish, in this evaluative process, we have seen that internal communication and funding schemes receive the lowest scores in the self-assessment. So we have to work a lot in these parts, in internal communication, and to develop better funding schemes to achieve this value-based integrated care paradigm. And this is all. Thank you very much. I finish with this quote by Fridtjof Nansen: "The difficult is what takes a little time, the impossible is what takes a little longer." Thank you very much.
Thank you so much, Roberto. For those who are online, please feel free to add your questions to the live Q&A. And for those who are here, we're going to be having the questions at the very end. Thank you. Nurses has been always a very integral piece of any integrated care system. And today we have a very interesting presentation by Louis Obrador about the role of nurse case managers as a key component in an integrated care system that looks at chronic disease for elderly. Louis?
Good morning. My name is Luis. I'm coming from Mallorca, Spain, and I'm a nurse. It's a pleasure to share our experience and approach with you today. In Spain, we have a national health system which provides a universal health care, and primary care is the pillar of our health system. Since 2017, I've been involved on a project for patients with complex and advanced chronic condition as a nurse case manager. Our current situation: aging, longer life expectancy, chronic disease prevalence, and social changes contribute to declining health and increased demand for health and social resources. In Spain, data from National Institute of Statistics in 2023 show that 20.34% of the population was age 64 or older. Life expectancy was 83 years, and the dependency ratio for this group was 31.35%. Chronic diseases are the leading cause of dependency, and most of these conditions require ongoing monitoring and treatment to prevent the progression of dependency. Decompensations, multiple pathologies, and polypharmacy are common, making care management more challenging and necessitating the activation of additional social resources. That's why in 2017, a new model was established in our community to address issues related to chronic conditions. Objectives are to improve quality of life, to reduce adverse events and hospitalizations, optimizing healthcare resources, to ensure, that's very important, to ensure dignified care during end-of-life stages, and to enhance the care of complex and advanced chronic patients through a comprehensive, continuous, and coordinated care. When we talk about chronicity, we have patients with common traits. We have a complex chronic patients, that's patients with multiple chronic conditions, patients with COPD, heart failure, renal failure, dementia. They present a high vulnerability, functional or cognitive decline, and a high healthcare research utilization. When these diseases progresses over time, we have an advanced chronic patients. These patients present an irreversible clinical condition, high frailty, and need for palliative care. These populations consume a significant amount of resources, and we need to identify them in order to provide the best care while ensuring responsible resources use. Both patient groups require an integrated care involving multiple levels of care and various professionals, such as social workers, very important, nurses, specialist physicians, physiotherapists, pharmacists, and others. What's the key elements of the program? As I said, we need a population stratification using our information systems that enable anticipation of complications. What is the best place for our patients? Obviously, at home, with their families, where they feel safe and settled. So that's why we need a strong, proactive home care to improve quality of life and prevent unnecessary hospitalizations. However, if they need to be attended in a hospital, we need a specialized hospital units for complex and advanced chronic patients, and a cross-level coordination across all healthcare and social care services. Now we're going to see what's the competencies or functions about nurse case manager. We coordinate the individualized care plan with general practitioner and in the referring nurse, if we have a nurse case manager in health centers, or with the doctor if we have or with a specialist if we have the nurse case manager at hospitals. Ensure continuity of care across transition, home or nursing home and hospital. Empower both the patient and caregiver. We can't forget the caregiver in our treatment plan. Optimize the use of healthcare and social resources and identify potential risks and prevent clinical decompensations. Let's see how can we manage decompensation in this kind of patients. About complex chronic patients, first of all, we need a medical assessment, including diagnosis and treatment. If it's possible, for example, if that patient has a mild decompensation, doctors contact with us, and we establish a coordination with units dedicated to CCPS, specialized wards for chronic patients, or chronic care consult. Also, we have the hospital at home service. If the situation requires an urgent intervention, for example, if patients present a severe decompensation, he is going to be transferred to emergency services. In our advanced chronic patients, the process it will be similar, but we have a difference for them. First of all, they also need a medical assessment with diagnosis and treatment, and doctors contact with us, with the nurse case manager, for a coordinated care with ACP units, intermediate care hospital, and palliative services. We have palliative service in hospital and also palliative services at home. And I would like to explain you about our intermediate care hospitals. Intermediate care hospitals are non-acute hospitals. They are focused on rehabilitation, recovery, and palliative care. It's for patients who no longer need acute hospitalization, but still require clinical support before returning home. And with these patients, we are going to try to avoid the A&E visits, accidental emergency visits, and unnecessary invasive procedures. How to approach hospital discharge in these patients? Hospital discharge is a key moment in the care of complex chronic patients and advanced chronic patients. It requires close coordination through integrated care across different levels of the healthcare systems, hospital and primary care, basically, and among the professionals involved in the patient's care. The nurse case manager works in coordination with the teams to ensure effective continuity of care at home or nursing home. I would like to show you the evolution in the identification of patients with complex and advanced chronic conditions. 2 years ago, we had less than 25,000 complex chronic patients, and now we have near to 30,000. Fortunately, we have less patients with palliative needs. And, well, we have 61 nurse case managers in Mallorca between hospitals and health centers. We have 7 in Menorca, 7 in Ibiza, and 1 in Formentera. And finally, conclusions about nurse case manager: ensures care continuity for complex chronic patients, improves quality of life through integrated care, reduces avoidable hospitalizations and optimizes resources, plays a key role in multidisciplinary teams with clinical leadership. And about our patients, they require a proactive, person-centered integrated approach. Early identifications enable timely intervention, advanced care planning and coordination improve outcomes, and primary care and home or nursing home support are essential pillars. That's all. Thank you so much for your attention.
Thank you so much, Louis. Chronic pain is a worldwide problem, and I think we've all lived or know one who's living with chronic pain. And today we have 2 presentations about chronic pain. Both are from Canada, my home country, so I love that. The first one is from Alberta, Calgary, and Elena Lapatina is going to be speaking about transforming chronic pain care, co-designing the Alberta Virtual Pain Program with people with lived experience.
Good morning. It is a pleasure to be here and to talk about what we're trying to do in Alberta, Canada, to help people living with chronic pain. And first of all, I would like to acknowledge that in Alberta, we work provincially and we work on the traditional territories of the Treaty 6, Treaty 7, Treaty 8, and the homeland of the Métis Nation of Alberta and 8 Métis settlements. And I would also like to acknowledge the funding that we received from the Ministry of Mental Health and Addictions, support from Primary Care Alberta, and also support from the Canadian Institutes of Health Services Research that has been funding my embedded research. Chronic pain destroys lives, families, relationships, careers, economic well-being. These are the words of Miriam Novlan, who has been an active advocate for changes in chronic pain management in Alberta and who is a patient living with chronic pain for years. In Canada and in Alberta, 1 in 5 individuals live with chronic pain, pain that lasts for 3 months or longer. In many patients, pain is a symptom and it is reaction of an organism and a body, but once it starts continuing, it actually leads to huge changes in people's lives and the huge burden on the healthcare system and our society. However, in Canada and Alberta specifically, for many, many years, patients had to fight to get what they need, and that is a quote from patients. And it's not that there was no services at all. There were some, but they were inaccessible and they were not meeting patients' needs, unfortunately. So there was a lot of advocacy to make a change in how chronic pain is treated in Alberta. And we received funding for Alberta Virtual Pain Program, and why is it different is because it is following learning health system approach and also embraces the pillars of integrated care to actually meet the needs of patients. It is the first in Canada provincially publicly funded program that offers access to interdisciplinary care and evidence-based non-pharmacological management of chronic pain. And it all started with leadership, patient and family partners, health workforce engagement, and learning networks. It takes a team to actually make the change, to advocate for that change. So patient partners were part of that advocacy, and they even provided a letter of support that was submitted to the government with a proposal for the provincial pain program. They met with the government, with ministry, to advocate for change, to actually explain what chronic pain does to patients and why the change is needed. And I think that was one of the major factors that actually led to success, to getting the funding to launch the virtual pain program. And the model itself, and the model that we proposed, has been informed by patient-to-patient research. Patient and community engagement researchers are people who are caregivers, who are patients, citizens, who have been formally trained to conduct research with patients. So they're acting as a bridge between other patients and traditional academic researchers to actually tease out what patients need, what they think, how they feel, because often patients feel unsupported and they don't feel comfortable talking to traditional academics or even healthcare providers, and that is particularly relevant for patients with chronic pain who have been stigmatized for years. So this research actually helped to identify priorities for the healthcare system that wants to address the needs of patients. And some of the aspects that came out is that doctors should be encouraging patients to seek help. There should be multidisciplinary care and support for primary care providers. Care should be holistic. There should be peer-to-peer support. Grief that patients go through should be accounted for in that model of care. So we took all those recommendations to propose the virtual pain program. Once we received funding, we not only leveraged those fundings from patient-to-patient research, we also continuously engaged patients and people with lived experience and providers to co-design the program itself. So more than 90 people with lived experience and providers, decision makers, and health system leaders have been engaged in the system design. And continuously, patients have also been engaged in all stages of design, development of all materials, all processes, and everything what happens within the virtual pain program, not only to provide feedback on what is needed and how services should be organized, but also get together as a group of patients and validate whether what health system leaders and researchers heard has been actually implemented in practice, to validate that input, that it has been meaningfully accommodated and integrated. And also they review all the materials to make sure that the language that is used is actually patient-centered, is trauma-informed, and is considerate of the needs of patients. So what does Alberta Virtual Pain Program offers is a mix of services with a centralized intake line where patients can actually be either referred by a provider or just call themselves. And that removes a huge barrier for many patients. They don't need a formal diagnosis of chronic pain. They don't need to wait for a referral. They can just call, and as long as they are willing to participate, they're 18 years or older, they are welcome to join the virtual pain program. It is also virtual. In Alberta, we live in a large territory with largely remote communities. Most of the services are centered in urban centers, and many people don't have access to care. So that virtual delivery also removes barriers for many patients. And then once they're in the program, they have a choice of either joining an interdisciplinary group program or self-led programming. And then in addition to that, they have access to topic-specific programming. They're followed in the program for 12 months and have access to all the resources that are available. We're also developing a health channel, which will be a repository of information. And we also offer webinars for healthcare providers, because that was one of the items highly recommended by patient-to-patient research. Providers need education too. Another element that makes the virtual pain program different is engagement of peer support workers. Trained peer support workers are part of the interdisciplinary team. They're working with other healthcare providers to support patients. In the virtual group program, there are 2 sessions per week. One is led by clinician facilitators, another one is led by peer support workers. And again, that was one of the needs that have been identified by patient-to-patient research. They advocated for including peer support workers as part of the team because that is one of the needs of the patients. And this is Melanie Vernon, one of our leading peer support workers. And as she says, peer support workers are a beacon of hope for others because they see people who went through this experience and now are trying to help others. They help people build connections, they help them being heard, and they also help them to integrate what they heard and learned in the facilitator-led sessions and apply it to the individual lives of patients. So far, the feedback on having access to that peer support and being able to connect with other patients has been absolutely amazing, and patients really like that opportunity. Also, what makes the program different is that evaluation, feedback, and adaptation are embedded in every stage of what the virtual pain program does, starting from design, implementation, and ongoing changes. Having an embedded research capacity and access to provincial EMR, provincial administrative data, and also thinking proactively how we can integrate evaluation and quality improvement in our work actually makes all the change and makes the program very flexible to the needs of the patient. So some of the data collection that happens includes patient-reported outcomes, but we also collect patients' feedback on sessions, on content, on the format of how the session has been developed. And because there is embedded research and willingness to change and to make sure that we're meeting the needs of patients, some of the feedback that we're hearing from patients can be integrated in the way how the program works as soon as tomorrow. So for example, we're asking feedback on the sessions, and if it is something technical and can be implemented for the same group, for the same individuals for the next session, providers are happy to do that. If we can't do that for the same session or the next session, it will be definitely incorporated for the next cohort. So by doing that change and having that regular review and integrating the feedback in the way how the program works, we're really trying to meet the needs of the patients. And here are some of the early successes. The program was launched in 2024, and we're just getting to 12 months follow-up for the first patients who joined the program last year. There's been 280 self-referrals, 216 provider referrals, and 26 cohorts started the virtual pain program. I think what is remarkable, so far we're seeing higher than average attendance rates, over 70% for most of the sessions. And also participant feedback is saying that they enjoyed the session, they enjoyed the content, and they're also willing to do the at-home practices, which I think is particularly important and facilitates that change in people's lives. And one of the most rewarding is to actually read patients' feedback. So we're asking them, what do you want to change about the program? And they're saying, I wouldn't want to change the program because I've learned so much. They're saying that they're feeling heard, they're feeling respected, they feel that they were met where they were. And these are the patients that have been dealing with healthcare system for years. Many of them have had chronic pain for decades. And finally, now they're getting the care that they hope to get earlier on. And one of the testament of the change and the impact on people's lives is the recent Patient Experience Award that the program received. So what are the next steps? Hopefully, over time, we're collecting a lot of data, and we will actually evaluate the impact of the program on outcomes. We also are looking at conducting economic evaluation and building a business case for continuous funding for the program. And hopefully, we can show that co-design, learning health systems, and integrated care actually improve people's lives. I think we're already showing that it is improving patients' experience with care. Now we're going to the next step and hoping to show that there is effect on clinical outcomes, on system outcomes, and provider outcomes as well. So hopefully we will be able to prove that we're reaching that quintuple aim. Thank you.
Thank you so much, Elena. Our last presenters of this session are Regina Visca and June Lituski from Montreal, Canada, and they're going to be talking about implementing a remote patient monitoring in an integrated trajectory of care for patients living with chronic pain.
So good morning, everyone. Regina and myself will be presenting implementing the remote patient monitoring as an integrated trajectory of care for patients with chronic pain. The presentation objectives will describe the needs and the outline of the co-design process to develop an integrated solution. We'll summarize the implementation approach and strategies and discuss specific barriers and facilitators and the preliminary effectiveness of the platform. Let's start with a few statistics. 20% of Canadians live with chronic pain. This amounts to $60 billion per year in the total economic costs for direct and indirect care. $1,462 per month as an economic cost to the individual directly. As we know, chronic pain has a huge impact on the quality of life and a tremendous strain on the healthcare system. This project aimed to understand the gaps in the care trajectory and propose solutions to address them.
So in 2019, just before the pandemic, we ran focus groups that involved patient providers, managers, and decision makers. We used a nominal group technique to look at our trajectory of care from primary to specialized care and prioritized gaps in access to integrated care. And these are the 5 main gaps that were identified. So first, our referral structures do not allow access to specialized care. Oftentimes, primary care providers don't know who to send, what types of patients to send where. In addition, we don't offer access to the right care at the right time at the right provider. So there's a huge gap in primary care regarding team-based care, which is the gold standard for chronic pain. In addition, oftentimes patients outside their clinical encounters have chronic pain flare-ups and are not sure what to do when these flare-ups occur, and may turn to alcohol or opioids to alleviate their pain, which then leads them to the emergency clinic. In addition, as I mentioned, chronic pain is multidimensional and requires a multimodal approach to care. So we need services that are team-based across all levels of care. However, the approach to care is siloed both within and across establishments. In addition, care needs to be continuous, both in terms of information and a relationship between the provider and patients. So there's a huge gap in making information available at the point of decision making, and patients are often left to their own to manage their own care outside clinical encounters. And we don't have a multidisciplinary approach to coordinating care across the levels of care. The care is not patient-centered and is not does not also meet the needs, the preferences and values of patients. So the next phase, we had a co-construction workshop where we identified what the solutions to these gaps would be. Some of the solutions were implementing interdisciplinary teams in primary care, but others were to offer an integrated approach to technology. So I've grayed out what we will present tomorrow, which is our virtual care platform, and today we will focus on remote patient monitoring platform, which we co-designed with patients and is now going to be scaled up provincially. The platform allows patients to monitor their symptoms in their home, and we offer timely, actionable advice based on their symptoms. And in addition, there's a care team that follows alerts generated by the symptom monitoring, and clinicians can act in a timely manner to intervene if a patient needs clinician intervention. And all of this also adheres to the principles of learning health system, so we're generating data within the context of patients' home to improve practice and knowledge around chronic pain. And our roadmap to transformation really includes design and systems thinking. So we are continually assessing needs using a technological approach and mapping out actual and ideal clinical and organizational workflows, as well as accelerators and breaks to adoption. Then we co-design with patients what prototypes can be. We plan their implementation and implement using small pilots, which are then scaled up across other sites. And what helps us is the monitoring, the ongoing monitoring, using a rapid cycle approach at macro, meso, and micro levels throughout the planning, implementation, and sustainability phase. So the co-design specifically for the remote patient monitoring involved an environmental scan of best practices in terms of self-management, but also ecological momentary assessment, which allows us to follow temporal and dynamic evolution of symptoms. We worked with patients and providers where we conducted focus groups to identify what should be included in the platform, and we'll show those slides afterwards. And then we worked with our patients to co-design the platform, and currently we're at the impact and implementation phase. And all of this was based on the philosophy of putting patient partners at the heart of healthcare transformation.
So co-design focus groups with patients and providers were held in order to identify the themes that needed to be addressed when talking about self-management. Both clinicians and patients agreed that all these were contributing factors to barriers to care. For example, the fact that patients don't understand their condition and don't know what to expect from interventions lead to a high program dropout, and that a paternalistic approach to care made patients feel that they weren't quite understood. Secondly, in order to monitor the right symptoms, we needed to identify the domains affected by pain in order to integrate them in the self-monitoring phase. The third theme identified was obstacles to self-management. There exist many online programs that address self-management, but they all seem to fall short after some period of time. The focus groups identified that if patients don't develop partnerships and connections with resources, or if they didn't have the proper support system, self-management platforms would not be successful in a crisis situation. The other focus group addressed the perceived benefits of remote patient monitoring. Some of the key elements identified were that the remote patient monitoring would enhance communication by providing a common language to express what they're going through. And it would also enhance motivation by having to write down the objectives enables actionable actions. Patients expressed that knowing that I can communicate with my care team makes me feel that I am part of it. So they felt it brought in an element of self-compassion. It's also expected that providing timely advice when patients are deteriorating avoids further exacerbation and unnecessary visits to the ER. So as Regina mentioned, the platform was designed to monitor, it was personalized monitoring of symptoms, treatment adherence, effectiveness, and medication side effects. Then, according to the scores, the platform suggests coping strategies to explore and invites them to consult the health library. From the dashboards, clinicians can monitor patients in between sessions, and from the alerts, can decide to intervene on a need-to basis. They can also assign activities in the platform that will lead to self-reflection, goal setting, identifying a flare-up plan, and working along with your values. It also allows for an asynchronous communications and shared decision-making. The articles and videos in the health library are based on neuroscience and neuroplasticity. And we took a lot of information, or there was already a platform making sense of pain that existed in Canada, and with their authorization, we included them in the platform. Our implementation roadmap, we did a co-design and workflow workshops They were held to map out the clinical pathway because it's important to establish optimal workflow to facilitate adherence. And we involved two key players in these workshops, the clinical coordinator and the administrative agent who would be involved in the initial data entry of patients on the platform. For the training aspect, the whole team was trained simultaneously on all of the features of a platform to assure a mutual understanding. Super users were then identified following the training to support clinicians during the deployment phase. The remote patient monitoring was presented to patients as a standard of care. And although they had a right to refuse or consent to being on the platform, it was strongly recommended that they integrate it in their plan. Regular check-ins with clinicians were planned in advance to address in a timely manner any issues encountered during the launch phase. A rapid evaluation of anticipated barriers was done in order to adopt the workflow to minimize risk and non-adherence and facilitate implementation. In order to ensure sustainability, the remote patient monitoring needed to make sense for clinicians and for patients, and it shouldn't be perceived as an extra burden on clinicians. Some of the implementation barriers that we encountered were the complexity of the chronic pain condition, especially the psychosocial aspects. How can we promote behavior change without triggering any symptoms while the patient wasn't in the clinical setting? As we know, innovation takes time to conceive and implement, and with limited resources, competing priorities, clinicians can feel overwhelmed trying to meet performance targets, all the while learning a new technological tool. We needed to address practice change and change management, and with the technology evolving at a tremendous pace, new apps and platforms that were popping up all the time, we couldn't afford to wait for a perfect situation. We needed to jump on the bandwagon, and we had to assure that the different systems needed to be interoperable to assure sustainability.
Well, just quickly, in the interest of time, so the main facilitators are really using embedded research and making sure that we're transparent with the progress and results and impact. And in terms of the infrastructure, it's to ensure that we're aligned with social political environment, which enabled us to secure recurrent and provincial funding, and as well a really big focus on social capital, ensuring that there's system-wide leadership that's engaged, that we engage patient partners across the roadmap to transformation, and that we embed a learning collaborative so that we're always aware of what's working, what's not working, in order to continuously improve, and making sure that the workforce is trained on digital health. And in terms of preliminary impact, we've shown that using cognitive walkthroughs with patients and focus groups with providers, that we're optimizing time with patient, we're improving shared decision-making, we're shifting to proactive, personalized, value-based care, and we're improving access to patients with mobility and transportation needs, and we've also improved efficiency of workflows, and we're decreasing the number and duration and optimizing the relevance of visits. And finally, it's been reported that we're optimizing clinical relevance and appropriateness and improving self-efficacy and quality of life. So the lessons learned is to continually define the value proposition, continually support organizational and clinical change. It's to reconceptualize trajectories at all levels of care, so really embedding team with technology, engaging partners, continuous evaluation, and supporting integration into existing technological systems, as well as investing in digital literacy and aligning with our social political environment. Thank you.
Thank you. Okay, any questions from the audience? Okay, I have some. Before I start with my questions, any of the presenters have questions for their fellow presenters? Okay. My first question is to Elena. Virtual care and access. This has been like a very debateful topic for a very long time because you can use virtual care to enhance access, but also if you want to provide access for people who don't have access to virtual means, then you're not doing anything. So can you expand more about this and your perspective given the work that you've done?
Yes, thank you so much for the question. Absolutely realizing that virtual care is not panacea for everything. The virtual pain program has been trying to meet the patient where they are. So we did very deep engagement with communities and heard a lot from many people from the rural areas that rural areas still have internet, have connection to care. So that reinforced that virtual care proposition. Having said that, there's still some patients who can't access it. So the team, especially the nurses on the phone line, are trying to work with patients to identify if there is no safe environment at home or no internet, they try to find a remote health telehealth facility at a hospital or at a community center where patients can actually join the program in a safe and welcoming environment. We've had some patients who received mail packages with all the printed materials. So we're really trying to find the place where patients can actually make the program work as long as they want to participate. Does it solve all the problems? No. It is a particularly big challenge for Indigenous communities across Alberta. There's also just a preference for in-person care for many, many patients. We know that we can't be everything for everyone, but as long as the patient is willing to work, the program is really willing to work with the patient to find that common ground and make it comfortable for them. Unfortunately, again, this will not meet all patients' needs, but we're trying as much as possible to meet as many patients as we can.
Perfect, thank you so much. My next question is for Roberto. Value-based integrated care, what a topic. How do you see this? How do you define value-based integrated care from your perspective?
For us, it's a concept that is still emerging, so I think there is not still a unified concept around it. But for us, the main interest is in the potential of the combination of two management trends that are very influential. Of course, integrated care is needed. We have seen the evidence. We are in a congress on integrated care. But value-based healthcare also has potential, but particularly with this focus on the outcomes that are relevant to patients, the outcomes that matter to patients. And this is opportunity of measuring real impact at the patient level. And we need this kind of metrics in the system because we still rely on activity metrics in number of days of hospitalization and consultation visits, but this not, we cannot realize the real impact only measuring activity. We need to measure with patient-reported outcomes, with patient-reported experience measures, and this kind of indicators.
Thank you so much. Regina and June, remote care management. Lots of work has been done on remote care management that I know of, especially in Canada. Scale and spread is always the problem, just because the technology is very expensive. Have you thought about scaling and spreading? How are you going to be doing this in your project?
Yes, so absolutely. So I sit on a provincial advisory board with the Ministry of Health. So our initial, this project is actually funded, the technology is funded by the Ministry of Health. And of course, it's the scale up and spread depends on the success of our initial pilot. So by co-designing with clinicians, managers, decision makers, and patients, we've ensured that the needs of these stakeholders are met. But we also, in our co-design approach, really think of the provincial scale up. So is this going to meet the needs of the larger community? And I keep presenting at the provincial table and obtaining feedback on ongoing bases. So integrating that feedback in our development work. And there is a bottom-up approach where we identify sites that are ready to implement digital technology, because it does require a lot of effort on the part of clinicians to do things differently. So we start with where we know we can influence, well, not influence is not the right word, but where we can have some success in implementation. And then that's shared with the broader community, and we spread that way. Also looking at as a top-down approach, where the ministry did come out with a provincial action plan, which we worked on. We made sure that digital health was embedded within the action plan. The CEOs of all the local health networks were invited to complete a 3-year action plan, and the ministry did prompt them to integrate remote patient monitoring as one of their deliverables at the end of the 3 years. It's not obligatory, but the prompt was there, and so there's been receptivity in looking at that.
Perfect.
And the idea is to create an implementation blueprint to share with everyone.
Perfect. Thank you so much. I have a very small question for you, Louis. So, nurses who are doing navigation or case manager, have you spoke with them, or was there any attempt to explore their experiences? Because I'm expecting that there is like an increased scope now for them, that they're doing still their clinical practice, but also adding to this the case managing thing. So has been any work about that? Like, have you asked them any experience from a provider perspective? Are they happy? Is it like more work for them? Is it everything that they have been doing day in, day out, but now it's formalized?
Yes, it's sometimes it's difficult, but it's a very good job to develop their career, and we have another perspective about patients. Sometimes we miss the assistential care because we collaborate more with teams, but it's an interesting job.
Perfect. Thank you so much. Any last thoughts about giving a question? No? Okay. Thank you so much.
So for us, programs that work with art and health and also civic engagement and emotional resilience are very important to the museum. And we currently have more than 3 or 4 programs that are only focused on this. Of course, they all work with our current exhibitions and also with the architectural heritage of the museum and history. But I will emphasize the Alzheimer Set the Place Encounters at the Museum program. It's a partnership with the Alzheimer Portugal organization. Dialogue tours and conversations with people experience dementia and Alzheimer, and also their carriers. So, and it's person-centered. We have a practical exercise focused on different artistic techniques. It's more focused on the emotional connection of people, either with their peers, and also with the spaces. Usually they feel more at ease, more emotional available, happier. And one of the things that it's also very important, they feel more connected with their carriers. Usually the people that come to the museum bringing a family or a friend that is struggling with the dementia diagnosis, they discover other things about that person, and also other topics of conversation and engaging that are not only centered on the disease itself or on the diagnosis itself. So that is very important. And also another part that is very important is that the program is developed by people that have experience in art and creative thinking, but also people that are experienced in healthcare. So I think that exchange when we are preparing the programs is very, very important. And sometimes we have this clash of, methodologies and how we think that things should be or work. And it's very important to work together and to find new perspectives. So that has been a very rich experience, I would say.
Good morning and welcome to day 2, everybody. I hope you are well rested and ready for your next marathon of integrated care today. My name is Niamh Lennox-Tugani. I'm the Chief Executive of the International Foundation for Integrated Care, and I'm delighted to be co-chairing this session on collaboration for integrated care. We've got a fantastic panel with us this morning, and I'm now going to hand over to my co-chair, Roy, who's going to help us to think a little bit differently about collaboration this morning.
And that's it. Thank you so much, Niamh. And I would like just to address some words, but firstly, let me present. My name is Rui Patricio, and I serve on the board of directors of Shared Patient Experience, and I'm also a professor at the University of Aveiro. And I would like basically to start this conversation to let you know that throughout basically my journey in healthcare, I had the privilege of coordinating projects across different areas, from maternity care and electronic platforms to experience measurement and clinical trials. And all these initiatives have been driven by human-centered design and have led to the creation of innovative product, service, and educational content. And this very much like the tone that we are really struggling to involve people in our organization, Shared Patient Experience, because we focus on practical and on hands-on approach for creating impact for people. And it's truly a pleasure to be here today with such a brilliant set of speakers. And to open this debate, as Niamh was saying, I would like to elaborate a bit on the need for breaking down silos, and basically to foster what we could say true partnerships in integrated care. And this is like a huge topic for everyone, and I hope that today we can also engage with our speakers to go deeper in this topic and understand different points of view. But imagine this scenario where in a hospital, instead of doctors, social workers, and information system teams working separately behind closed doors, those doors are open and information flows freely. Decisions happen faster and patients move smoothly throughout their care. And that's the power of breaking down silos. It's not really an easy task. Here in Portugal, we are making progress in the area. We have the ULS model, and think of ULS as bringing together all the different parts of your healthcare. Your family doctor, the hospital, and long-term care, all under one roof in your local area. And seems very interesting. But research in the International Journal of International Care shows that great integrated care isn't just about rules and structures. It's really about people building great relationships and real relationships, not just between different organizations, as we are doing now with ULS model, but also within the same organization. And collaboration is not just about coordination tasks. It's about creating environment where trust grows. Respect is automatic, and everyone shares the same goals. And this is quite difficult. And think about it. When doctors, social workers, tech experts, and patient advocates and community leaders work together, their different viewpoints lead to better, more creative solutions. And that means more complete care for people. But let's be honest, getting this kind of teamwork isn't easy. Many places still have those silos, and people work in their own bubbles. Sometimes it's difficult because of rigid rules. Sometimes it's because people are afraid of change and there are power differences. These things can stop new ideas and limit what we can achieve together. So, how do we break down these walls? We have to build trust, firstly, intentionally. And this means creating safe places for honest conversations. It means openly sharing what works and what doesn't. And it means setting up ways to make decisions together. And it seems clear, but it's really hard to put in place. Now, let's start with our speakers, and I will hand it over to Michaela. Thank you.
Do I introduce myself? So, good morning, everybody. It's a pleasure to be here. Thank you, Neve. Thank you, Adelaide, for bringing this great conference to Lisbon. My name is Michaela Zeman Monteiro. I'm a physician. My current role is the of Chief Medical Officer for Digital Transformation at CUF. CUF is Portugal's largest private healthcare provider. Previously, I worked for the Digital Health Agency of the Portuguese Ministry of Health. And yes, so let's start. So how can technology help to leverage partnerships and enable integration of care? So first of all, I would like to invite you, just with me, to answer these questions. Please raise your hand if you have ever repeated your medical history multiple times. Okay, please raise your hands if you have ever carried physical tests results between clinics. And please raise your hands if you really felt unsure who was coordinating your care. So, all right. So, I think we are here in the right Congress. So, and yeah, these are the challenges that we face, and this is nothing new for you. Actually, we already spoke about it. So we very often provide care in our care silos. We face fragmented care processes. We all struggle with a workforce shortage. In Europe, for instance, there are estimates that by 2030 we will have a lack of almost 3 million healthcare providers, so this is really frightening. And obviously, healthcare costs are rising steadily. So what we all want is connected ecosystems, our end-to-end processes, and we want care, not only for a few, but for all who need care. So we need to have means to scale care. Okay, this is where technology can be a big and very powerful opportunity. As a connector, obviously, but there are much more opportunities that technology can provide. So this is a bit conceptual. I will walk you through, and then we will see some tangible examples of that. So technology can be a very powerful information manager. It can become a predictor of who needs care, a personalizer who needs which care, and it can give remote access to care. It can enable that. It can be, and this is important, an automation enabler and a self-service enabler. So now I would like to share, and it can be a big accelerator and scaler for healthcare. So now I would like to provide you some examples. So what you see here is a symptom checker. So what is this symptom checker? It is a digital app. It's actually a medical device. And it is integrated to COOF's client app, the organization for which I work at the moment. So it is available to more than 1 million patients. And what does it do? And what does it? It is a chatbot. And as a patient, I can tell 24/7, wherever I be, wherever I feel the need, I can tell this application my symptoms. And what will the application do? It will take a thorough medical history, as a doctor would do in this situation, and then it will generate recommendations to what care level is adequate, probable diagnosis, and explain it to you. And it will, and this is important, connect you, give you the opportunity to connect right away to the best care and the most adequate care in this situation. And then all this information won't stay just in this app. It will go into your electronic health record. So whenever you get in touch then with the health system, with the healthcare provider, this information will already be there to be used. So basically, thinking of these previous principles, it is hugely empowering patients by giving them the opportunity to start the journey by themselves, so by self-service. It guides and connects, it's managed information, and it does it at scale. So this is the next example that I have brought. This is vaccination in community pharmacies. So this is a partnership between the Portuguese National Health Service and private-owned community pharmacies. So Portugal has a national vaccination plan, and within this vaccination plan, for instance, in the winter time or before the winter time, there are certain populations groups that are highly recommended to become vaccinated against the flu and against COVID. So, and there is a partnership between these entities, the national health system, and all the community pharmacies to provide these vaccinations in proximity within the pharmacy. And of course, as you may imagine, this all is supported by IT tools, logistics, reimbursement. So this only is possible through technologies. And you can see the results. 2,500 community pharmacies participate, and in 2024, almost 70% of all vaccinations against flu and COVID, against COVID, were done in proximity in the pharmacy of your neighborhood. And then finally, this vaccination goes into the NHS patient app, a citizen app, sorry, not patient. First we are citizens, we can become patients eventually, but the NHS citizen app, where you find your electronic vaccination bulletin, and all your vaccinations are there, and the flu and the COVID vaccination as well. And now, my last example, as you see, it's a more complex one, so don't be scared about all this, about the icons there and the arrows. I will walk you through. So what these examples will show you is other principles of how technology really is a big enabler of information sharing and information management, of care automation, of care personalization, of remote access to care, and to do this all at scale. So the screening of the diabetic retinopathy in Portugal starts, as you all know, diabetes is a very prevalent and increasingly prevalent disease. One of its complications is to become blind, but you can prevent this blindness if it is detected timely and if things are done. So what happens here is everything starts at the family doctor, who obviously in the EHR is going to insert the diagnosis. So then there is an information system with business intelligence where protocols are inserted that will generate a list of those patients that are eligible for the screening. These patients then, I don't know if this has so these patients then are notified and are invited to go to their primary care unit, where a technician will come with the needed equipment, and they will do an image of their retina. So this image then goes again into the technology cloud, where it first is analyzed by AI. What does this AI? It automates the process of analyzing it, and what it can do is to sort out all those that are normal. So all those that are normal will get a notification and will continue their screening circle. Those images that are not normal, they are seen and evaluated by a specialist in a diagnostic center. So then what happens is that those patients that really have diabetic retinopathy, that need special care, that may need a laser treatment, these are then notified, and an appointment is scheduled in a specialized center. And when we look at 100 diabetic patients, this only happens in 20%. So every other, they can stay in their community and continue to be followed there. So technology can really be a huge, huge enabler, but it's not a silver bullet. It won't do it by itself. So it needs, of course, people, it needs processes, and then there is technology to support it. Thank you very much.
Thank you so much, Michaela, for waking us up this morning. Fantastic. And next we have Antoine.
Bom dia, bonjour, hello. I would like to start by telling you a story, and it's the story of Jane. Jane was my ghost patient. She had been registered to my primary care practice for 3 years, and I had never seen her. Every couple of weeks, I would get reports from the emergency room, from the hospital, diabetes, heart failure, hospitalization, emergency room visit. I called her. I offered her to visit her at home, to see the nurse, the social worker, the pharmacist. She refused everything. One day, she came to the clinic for the first time, and I offered her to meet a person that I trust, who was not a nurse, not a doctor, but just a patient like her, my colleague Ghislaine. I opened the door, introduced Ghislaine, let the two women talk for 1 hour. At the end of the meeting, Jane asked Ghislaine if she would accept to accompany her back to her home. And then we understood what was going on. Jane was living in poverty, alone. She was struggling to put food on the table. She had had issue with childcare services in the past. So for her, as social worker, it wasn't help, it was a threat. And healthcare professionals, she was worried about them. So Ghislaine became the first person that she started trusting. And they built this relationship and eventually extended the conversation to her children. And we started understanding then a little bit more what mattered to Jane, what were actually her goals. That her goal wasn't to get her blood sugar perfect, but to see her granddaughter being born. That was the goal. And once we knew this, we could re-anchor care around what mattered most to her. Everything that was not aligned with this, we put aside. Everything that could help, we provided. So we connected with community organizations for food stamps, for clothes for her children, and then to organize a meeting with her children to understand a little bit her condition, but also that we could understand a little bit more who she was and what she wanted. Jane, in medical language, was a bad patient. You know, she wasn't showing up, she wasn't taking pills. Within weeks, she became my best patient. She started texting me when she had questions. She stopped going to the emergency room altogether. We calculated that through the interaction with Ghislaine over a few weeks, Ghislaine had saved the healthcare system about $15,000 a year for a single person. I had done a PhD, I had a decade of experience as a physician. I had never seen an intervention that was so powerful with such large impact, and it shifted the direction of my whole medical and research career. So for the next 10 years, I asked a single question: how is this miracle possible? How is it possible that a patient without a university degree succeeds where a whole team of academic healthcare professionals have failed? So this is a journey about caring that I would like to share with you. First caring alone, then caring together, and finally caring with others. I was trained over 20 years ago as a physician, and I was taught that I was in charge of patient care. It was my responsibility to diagnose the problem, identify a plan, and find solutions. And for a while, it worked really well. I started my practice in a rural community in the north of Canada, was working in the emergency room, the intensive care unit, the hospital. I thought I was great, you know, diagnosing heart attacks, cancer, saving lives. It felt amazing. And then I moved to Centre-South Montreal, one of the most disadvantaged neighborhoods of Canada, and suddenly I felt very powerless. Where was the pill to treat poverty and loneliness? I tried to change the system. You know, how could we make this better? How could I make this better? And over time, I just felt like I was hitting a wall. I was running toward burnout and despair. How can we solve these problems? 10 years ago, I met Ghislaine. Ghislaine was born with 2 genetic diseases. She survived 3 cancers. In a medical textbook, she would be described as a vulnerable elderly patient with multiple chronic conditions. That's not how I met her. I met her, she was standing up in the front of medical students, and she was the teacher. And I was back listening and observing. I was struck with this woman, and let me introduce you, Ghislaine.
Hi everyone, my name is Ghislaine Roulier. I'm a patient. I was born with two orphan diseases. I survived 3 cancers. So obviously I was always in the hospital. And with the personality that I have, I don't mind my own business. I take care of other people, meaning by that the patient who is next to me in the bed, this is how I start to help the patient, to make him comfortable, to answer questions when he doesn't understand, and so on. So for the last 50 years or so, I take care of other people, and quite frankly, it's something that has a lot of meaning for me. And I think this is natural to help someone who's feeling less well than ourselves, to be able to have a better relationship. In fact, it's all about relationship. I am really caring and curious about other people. I love people. I'm curious about them, trying to help them. And then I had the opportunity and the great privilege of meeting Antoine, and we started discussing maybe to find a different way of caring. Him as a professional doctor and myself just a person caring for others and discovering together what little miracles we can do together. So now for the last 10 years, this is what we're doing.
So I don't know if you have the same emotion as I did back then, but I sort of fell in love professionally with Ghislaine. I took her on a date for a coffee. We started talking. We became friends, and we had a dream. You know, what if we cared together? It felt like it was the right hand meeting the left hand. Ghislaine had been doing this for 50 years on her own, and I had been doing this for years on my own. What would happen if we cared together? So we didn't ask permission to anybody, we just did it. The first person that we cared for together was George. George was a 60-year-old patient. I had diagnosed with lung cancer, and I had nothing to offer. He didn't have pain. There was no treatment available. He was going to die within 1 year. He was really angry and really sad. I offered him to meet with Ghislaine, and she sat not on the other side of the table, but by his side. And after he shared, he asked, "Well, you're not saying anything." I said, "Well, yeah, I understand you're angry. I was angry also when I got my third cancer." And she said, "Now, what are you going to do with your life?" And George started thinking, and he decided to live his life. And he got back in touch with one of his friends. They went fishing. He got back in touch with his family. He had cut connection for 30 years. He took his daughter to a trip to his home village to visit his home and where he would be buried. He lived the most fullest year of his life. Ghislaine and I, we saw him 2 weeks before he died. He was glowing, beaming, smiling, really happy. That meeting had not extended his life. It had added lots of life to his later year. I thought this was a miracle, but my colleagues thought this was crazy, and it was dangerous. Soon after, we had to create a protective space to try to continue caring together, and we did this through research. Research offered that opportunity. Oh, there's an ethic approval, and Ghislaine is sort of an experimental treatment. That's fine. They can keep on doing their thing. And then we started doing actual research because we wanted to convince other people. You know, we started getting the data, proving the outcomes, trying to understand what was happening inside that magical black box. What is Ghislaine doing? How is that making a difference? We learned that Ghislaine is not doing things. She is being there. And part of her power is looking at the person as a person with strength, with dreams, and helping them rediscover themselves, not just as patients with illnesses and deficits, but with dreams and hopes, to realign care towards life goals, to recreate relationships with caregivers in the broadest sense, starting with the caregiver in ourselves, the family, the friends, the community, all of it. And I thought, obviously would convince everybody. I had a meeting with the health minister, and nothing changed. After 5 years of that experiment, the only funding we could get for Ghislaine was only coming from research grants. Ghislaine was getting older, and I was getting worried. Is this going to die with us? Is this going to be stuck at the pilot project stage? The opportunity to move further came from a crisis, a global crisis, the pandemic. So in 2020, we had an opportunity to expand this at a slightly larger scale. At the height of the pandemic, we were approached by a colleague who was working in homelessness, who said, this is pretty cool. What if we did this with somebody who's experienced homelessness? Can you help us? And so we found Danielle, who had lived in the streets of Toronto, had struggled with addiction and schizophrenia, and wanted to give back. He'd been off work for 10 years, did a course in peer support. We had an interview, and Ghislaine recognized that he had it, what it takes. I couldn't see it, but she could see it. And Danielle's first day of work was December 1st, 2020, which was the height of the second wave of the pandemic in Montreal. Shelters were closed down, teams were exhausted, people were actually dying in the streets of Montreal during the winter, and people in the team were really worried about Daniel. He's been off work for so long. What about him? He's had issues with mental health issues and all of that. After a month, we followed up, and Daniel was beaming with joy. He was accomplishing miracle just like Ghislaine did. And he was doing cross-country skiing, and he was just having a great time. And beside him, the medical director of the clinic was green, exhausted. He'd been working all throughout the holiday season. And at the end of the meeting, Daniel said, Mathieu, why don't you take your weekend off? So then I realized that the vulnerable people are not always those that we think. That people who have survived real challenges have developed this sense of resilience and ability to care for themselves, which is not what we learn in medical school. And then we found others in our communities. We found a team at Doctors of the World Canada who have designed the dream team, the team that I was dreaming about that already existed in my community that I didn't know about. So they had a team with Indigenous navigators, peers with migrants, in mental health, in substance use, all of it. Almost as many people with lived experience as health professionals with diplomas. And so our role as a research team just became to shed light on these incredible experiments that were already happening in our community and that we didn't see. And then we realized that we didn't invent anything. This had existed for decades throughout the world. Recently, I had the chance of connecting with people in Thailand and Brazil. In Brazil, there are 400,000 community health workers trusted by the community, identified by communities, working with primary healthcare teams, funded by the public system. In Thailand, it's 1 million community health volunteers. So I realized that maybe in the global north, we have a lot to learn from the global south in terms of these approaches. And that this is really happening and we need to connect what already exists. Because still at this stage, system change remains difficult. When I hear about new innovations in my province and country, it's AI, tele-stuff, telemedicine and all of this. Like, what about the power of human relationships and care? So I believe that one of the things we learn is to transform the way we care. We need caring structures caring cultures, and caring relationships. It means sharing power about how we govern our health ecosystems, co-funding mechanism, changing policies to allow partnership and recognize people, an extended view of the caregivers that already exist in our communities. It also means changing our professional cultures. Who is a caregiver? Is it just somebody with a diploma, or is it somebody who cares? And changing our relationships, connecting what is already happening to build strength and transformation. So I have learned in this past decade that changing the world is difficult and changing the system is difficult, but changing our minds is possible. And that's where it starts, just looking at care differently. And that it all begins simply by listening to discover the power within. Thank you.
Thank you very much, Antoine. And next we have Hong Chun from Singapore.
Hello, good morning, everyone. I'm going to share a little bit about our journey in Singapore. And let me begin first by greeting you, a warm greeting from Singapore. For those of you who are not so familiar, we are a small country, an island country in Southeast Asia. We are very small. Our total land size is about 730 square kilometers. That is about the size of New York City. But we pack in about 6 million people living in Singapore altogether. And we are sometimes called the little red dot because if you look at the map of the world and you look for Singapore, this country is so small that it's covered by the little red dot that says Singapore. And you can't see it, it's just a dot which covers the whole. We are a multi-ethnic community. We have diverse cultures and we live together and we love food. We're quite famous for chili crab, satay, and it's an open invitation to many of you, all of you, to come and visit us to experience the Singapore culture. I am HC, Hong Chun, as Neve introduced me. I am a Chief Executive Officer of 2 hospitals, Khoo Teck Puat Hospital and Yishun Community Hospital. KTP Hospital is an acute hospital in north of Singapore. I'll show you where it is in a while. We have about 780 beds, and we are next to the community hospital that looks after subacute care as well as rehabilitation. That's another 200 beds. We also operate an ambulatory medical center called Admiralty. I am also a physician. I am a psychiatrist by training, and I still see patients. That keeps me very grounded in some sense to understanding that as a hospital administrator, it's not about managing a system. It's more than that. It's about caring for people, as our speakers have just mentioned just now so beautifully. So what does public healthcare look like in Singapore? This is that little red dot in expanded version. You can see that despite our size, we've managed to reorganize ourselves into 3 public health clusters. There is one that looks after the west of Singapore called the National University Health System, and another health cluster that looks after the east and south of Singapore called Sing Health. Now, my hospital, Khoo Teck Puat Hospital, as well as Yishun Community Hospitals, we belong to the National Healthcare Group, responsible for the central and northern part of Singapore. And we are the population health manager of about 1.5 million people. Now, I wanted to just show you this slide because my talk is really about trying to understand the role of the acute hospital in an integrated care system or a population health system. So when you look at this first slide, it looks like, these are our assets and these are the hospitals. But you look at this expanded area, this is the area we look after in Singapore. So we have 3 acute hospitals. So we do have 5 community hospitals and 3 national centers. What's important is that it's an integration of 9 public health primary care clinics. But that's just us. To look after this 1.5 million people that live in the center and north of Singapore, look, we have another 90 community health posts run by nurses, some of us from our organizations, but also from NGOs, non-governmental organizations, that are located in the community. We have another 400 private primary care practitioners. There are 44 community centers that serve this population. These are social centers where populations can come in to get their municipal requirements done, but it's also opportunities for them to mix and learn new skills in life. There are 93 active aging centers. Isn't that a lot for 1.5 million? I'll tell you why. There are family service centers. These are centers that look at social supports for families, largely led by counselors, medical social workers, helping families who encounter difficulties in their lives, and 66 day rehabilitation centers. So, if you count the number of organizations that need to be integrated to look after or to provide care that the population needs, the hospital is just but one of the many, many players in this system. So, what is Singapore's imperative to move from hospital-based care to integrated care? I think you've heard this many times throughout this conference, but let me just highlight 3 key areas which are relevant to us, but I'm sure to all of you as well. The first is our aging population. Unfortunately, many of our countries are facing this challenge. That accounts for the 66 active aging centers. And the reality is that for us, by 2030, which is just around the corner, 1 in 4 Singaporean citizens will be aged 65 and above. And we also have a problem of a shrinking population. We're not replacing ourselves. Our birth rate, unfortunately, fertility rate is below 1, or just very close to 1. And that's not enough for population replacement. And this means that for every older person, the number of working adults supporting them is going to get smaller and smaller. There will be 83,000 seniors living alone by 2030, and more than 100,000 seniors with some level of disability. That's one challenge that we have. As a small country, we also have to be very careful about how much we spend in the different areas of our economy. And we can clearly see that because of the rising costs of healthcare, the technologies that are rising, the different kinds of services that we as healthcare providers can provide to our patients, the cost is rising exponentially. Our health minister has told us that we need to manage this spend. It could hit $30 billion by 2030. And this is something that may not be sustainable at the country level. The third area, of course, is us, the healthcare workforce. We knew this during COVID, how fragile we are, and how we are humans too, and we can get burnt out. And the complexity and the increasing demands of healthcare that we need to provide today is taking its toll on the healthcare workforce. So these are the 3 key reasons why we really need to think about a different way of providing healthcare. We really need to move away from the concept of the hospital in the center of care for a community. We're fortunate in Singapore that our government has taken very proactive approaches to redefining the approach to healthcare. Before 2020, really the focus was on some very fundamental basics, which are non-negotiable. As a healthcare provider, we are responsible for making sure that the care is safe and has high quality. We need to make sure accessibility is always there, as well as affordability. This was what we worked very hard for as a public health system before 2020. But look, as we started to move beyond that period, there was a realization that we need to go beyond. We cannot leave accessibility, affordability, and quality behind, but we need to go beyond them. We need to go beyond hospital to the community. I think it's easy to say that. Actually, how do you do that? we need to move beyond quality to value. I don't think we have had much time to talk about value at this conference, but quality comes at a cost or a price. And I think all of you understand this when you buy a pair of shoes or buy a shirt, and that is the value of healthcare. What does the value mean to the patient, the provider, and the country? And the last one really is a shift beyond healthcare to health. And I think this marks a big shift in the mindset of the country in terms of providing healthcare, that this is not just about illness care, it's about health. The latest iteration really is clearly articulated in these 3 big campaigns that we launched in the last couple of years. Big one really is Healthier SG. This essentially are the 3 big logos that define Singapore's healthcare system today. Healthier SG wants everyone in the population, 40 years and above, to register with a primary care provider and to make sure that that provider is anchoring your health throughout the rest of your life, doing the basic screening, coordinating healthcare as you require it, and making sure you have opportunities to maintain your health. Age Well is a similar program targeted at the elderly, and the latest health forward-looking program is Grow Well. We realize that the next generation needs to be onboarded a health program. It's not an illness program, it's about health throughout life. So you can see that really, if this is our health policy, there's nothing about illness in there. As a health practitioner, you wonder, but I'm the doctor, I'm the nurse, where is the illness in this? Let me show you. So this is what integrated population health, it's an aspiration that we have articulated for ourselves, and it's how do we design it? This is what it looks like. What do you think? Can you understand this? Can you read the words? No, it's intentionally designed to look this way because if it works, it's very pretty. It's a good life. As one of the speakers yesterday from New Zealand talked about the good life. And that's what healthcare should be. It's not about illness, it's about life, and it's about a good life. At NHG, we have conceptualized the shift to population health in this river of life story, shaping our new model of care together. It's a model of care. We see everyone flowing through that river of life. You, me, our patients, our family members, our friends. There's a whole part of life where we live well, but unfortunately, because of certain conditions and medical conditions, you might end up having an illness and you might have crisis and complex, you might have a need for crisis and complex care. But then, as the population ages, we also have to learn to live with frailty. And what's very important at the end of life is for us to leave well. So we have mapped out life throughout, and we're trying to put in and integrate where the providers of life are. And it's intentional that, where is the acute hospital in this picture? Hard to find, right? There we are, hospital care. And again, this emphasizes that the acute hospital has an important role, but it is far from the only role. It is not the center of care of our healthcare system. Just wanted to show you this number at the top, 15 million. It's 15M, and it stands for 15 million, and I have a pin on my lapel that says 15 million, and I thought I'd explain that to you because this population that we look after and manage, the 1.5 million, we have studied their health span versus their lifespan. We do know from prevalence studies that the average lifespan of the person living in this area is good. It's about 81 or 82 years old. Unfortunately, the years of life lost to illness is about 10 years per person. So there's a gap between the health, the lifespan, and the health span of 10 years. So if we are trying to recover 10 years for every one of the 1.5 million people we're looking after, what does that come to? 15 million. There you are. So this is our lofty target. We're trying to achieve that. Let me just quickly go through with you what this means for the acute hospital. This is our strategy map. It's a house. We see us as a family of healthcare workers working together. And at the foundation, really, what I call non-negotiables, is a commitment to quality and patient safety. Learning from COVID and health crisis that we must stay operationally resilient and sustainable and affordable. And of course, a commitment to staff well-being. Now, we have defined 4 strategies that we need to work on towards 2026. And they look like hospital strategies, but they are really focused around our role to the community, to the healthcare system. First, really, is about assigning patients into care streams. And this is about understanding the population we serve. Even before the end of COVID, our team had looked very carefully at the kinds of patients that we were treating in the hospital. We looked at the patient's lifelong care needs as well as episodic care needs. We stratified them into different groups. So for example, patients with early disease and early disease with psychosocial issues. And we realized that just between these 2 groups, the medical condition stays the same, but because there is a layering of psychological as well as social issues, the consumption of healthcare is vastly different. And it's similar again with advanced disease, again, differentiated from individuals with advanced disease with psychosocial issues. The demands, the additional care requirements are different. And so we are able to predict with the arrival of such patients into the ED that we might have the opportunity to develop different streams of care for these populations. This has resulted really in our medical and surgical short stay or FAST units led by our Chief Medical Officer. We have designed specific wards to identify lighter need patients without the additional psychosocial complications. We have streamlined the care, put up investigations, diagnostics very early on, and discharge planning right up front at the point of admission. This has resulted in significant reduction in ALOS. This has been able to help the staff to feel much better about providing the care. And of course, the most important, the patients are happier that they were in a fast stream ward, they were able to go home much quicker. Now, what does this have to do with the integration and population health? Well, if our patients are able to go back earlier, this frees up beds for us. And this allows us then to work on what we call anticipatory and elective care. We don't want to be an acute hospital just attending to emergency patients whose care is delayed to the point that there's a medical crisis or an emergency. We want to attend to cardiac problems, cancers, surgical issues, in an anticipatory elective way. We had difficulty doing this, of course, if our beds are filled with patients that are having urgent care and we cannot discharge them because we don't know them well. So the segmentation allows us to streamline care, inpatient care. This allows us to free up beds, and this allows us to then bring in elective patients. And that's very important for us. We have, well, I'm pleased to say that been able to reduce the waiting time for first appointments. We've been able to increase our day surgeries and inpatient electives by 20% and 8% over the last year. This is not easy because understanding, and I think Roy mentioned just now about integration, it's not just between the hospital and its partners. Really, sometimes it's integration between the units of the hospital. To be able to organize yourselves to get the elective care and anticipatory care done, you need to make sure that your outpatient appointments are ready, referrals are met in a timely way, they get the right appointments. That is met with a quick diagnostic set of tests so that patients can come back and have their surgeries in a very short waiting time. That's integration within an organization. So again, being able to reduce the MRI waiting time and CT scan waiting times have been very significant progress for us. On top of trying to keep patients' length of stay short by putting them into fast streams of care and returning them as soon as possible, we have also developed, like many of your organizations, a stream of care that avoids hospitalization in hospitals altogether. This is our Hospital at Home program. We currently are able to run 30 beds, and I've listened very intensely to many of you who have organized hospital care services, and we are on that same trajectory. My advice is let's continue in this area. It's so important to free up the beds and be able to provide care in patients' own homes where they feel comfortable and safe. We have shown that with the right selection criteria for patients, with the right training, and with the involvement of patients and their families, we are able to run 30 beds at any one point in time. This has allowed us to avoid 650 admissions and almost 4,000 bed days without any compromise in care. And the last area, this is our last strategic priority, really is the one that focuses back into the community. We need to invest in the health of our aging populations. This is the work that we've been doing for many years, even before COVID. It's trying to build healthy communities. We take an asset-based community development approach. Just one little program I want to share with you really is this community wellness program in this picture here. This is our, we call it a Share a Pot program, where we bring, these are not people with illness, this is just members of the community. We set ourselves up and we organize a cooking session. We share a pot. We ask people in the neighborhood, especially the older individuals, to come down, share a pot. Essentially, it's the community act of eating together. And then after we eat together, we do a bit of exercise together. And most importantly, there's a lot of building of bonds, social bonds. People get to know each other in the neighborhood. They realize that there are needs that they can help each other with. And it seems a little bit distant from healthcare, but really it is linked to good health and preventing people from aging in a poor and a frail way. So I just wanted to highlight these 4 programs. Let me just end by talking about what have we learned so far and what is the role of healthcare leaders. I think we'll discuss some of this in the panel session. Just 3 things which are extremely difficult to accomplish. The first one really is thinking differently, strategizing differently. And you've seen what I've shown you, how our country has tried to shift the philosophy and the understanding and the model of healthcare from illness care to health. And then is the people. It's the mindset and the cultural changes that we have to take. For every individual in the healthcare system, the healthcare providers, that's all of us, the healthcare workers, but also the population, our patients and their families. It's a huge mindset change around not just coming to a clinic or a hospital when you're ill, but really engaging in health for the rest of your life. And then, of course, if you have the will to do this, then the operational shifts are really important. We need to understand processes and people, as we mentioned, and how do we reorganize that? Because it just doesn't happen naturally. So just, for example, trying to get the patients in earlier to get elective care means a referral system has to be more accurate. We need to create spaces for first appointments. We need to subsequently have MRIs and CTs available and labs. And then we need to make sure the operating theaters are available and the doctors are there to do this work. Everything has to come together. And that's the operational shift. The role of leaders, many of you here are leaders in your systems and organizations. Well, I think that we need to lead at all levels. Our corporate planning director has talked about 7, 8 levels of leadership. And every micro team in the ward and in the unit has a leader. And people lead in different ways. But we have to understand the same philosophy and the same shifts that we are trying to achieve. We need to be brave, and I think we're trying to use that word more, brave spaces, and we must be ready to embrace failure along the way. Our journey continues, and we hope to come and tell you more. Thank you very much. Thank you.
There was so much in all of those presentations. Thank you, everybody. I want to, and there's probably less time for us to chat than we all would like, and we know because we've had the chance to have this conversation already and rehearse it a bit. And if we had another hour, I think we'd probably still all be here. But I want to bring us back to that notion of collaboration and partnership. And all of you in different ways talked about the importance of mindset change, cultural change, a mention of power. And I think you particularly talked, Antoine, about power imbalances as well. I'd like to hear from each of you how do you practically get over the challenge moving from the talk of collaboration and partnership, because it is everywhere on all the strategies and all the policies, but going to the walk is not straightforward. So who would like to start us off?
I can start. Changing minds. That's what people call in social innovation scaling deep, and that means getting through the heart. In my experience, what has changed me and what has changed my colleagues is the experience of caring with Ghislaine, Mathieu, Farron, all the people in our team. You believe it when you see it and when you experience it. Yeah, that's the simple answer. For example, during the pandemic, people looked at Ghislaine when she arrived in the clinic as, who is that? You know, a patient seeing other patients. And then Ghislaine slowly started joining our interprofessional team session to discuss complex cases. And then realized that she was not just a patient, that she was providing a really radically different viewpoint that none of us had. Bringing things like, maybe you've done enough here as a health professional. Maybe the resources are elsewhere in the patient, in their families and all of this. And that created also trust. And saying, oh, well, can I talk to you about one of my patients that I'm struggling with, and oh, could you see her? That takes time, and it's a bit of adaptation and trust. You know, for us, a lot of what we're experiencing is trust building. Yeah.
Yeah, let's see.
I like to think that we should have a pull and push system when we are trying to make a mindset change. Of course, the pull is to a better system, to better care, being able to do more as healthcare professionals. Everyone wants to do that. So you tell them if we try and make these changes, we can see more patients, we can see them before they are so ill. So that's the inspiring bit. As a mental health worker, I realize there's also some value of working with dissatisfaction and unhappiness. So I'm sure you're familiar that we often hear complaints from our patients, from our family members, but also from us. I don't like the system, it's too slow, I'm taking too long, I can't get things I want done. So I call this healthy dissatisfaction. Let's not try to ignore them. If we are unhappy about the situation, why don't we do something about it? Why don't we change it? Why don't we? And a lot of the times, it's about relationships, it's about that coordination of care and that integration. So, you know, I think you can use both the inspiration as well as the dissatisfaction to kick off that.
And I love that idea of healthy conflict, and I'm sure, Michaela, you have a lot of that when you're trying to develop digital technology that enables integration and coordination. Does that healthy conflict, is that your experience?
Yes, conflicts can be healthy. Sometimes they can be toxic. But stepping back, I think one very important starting point is to acknowledge all the stakeholders that are involved, because we sometimes forget that there are stakeholders that are very important and crucial to the success. And then it is important to build a common vision about what are we going to do and why, and start from that. Then we can also agree on goals, and then we can build trust, and finally we can align, and this is important, we can align value propositions for each of the stakeholders, because the interest of being in solutions very often are different. It's good, and it's very important to have, you know, a dream together. But then there is every stakeholder has his or her own dream within this dream, and it's important that these are aligned, because otherwise, yeah, it becomes much more difficult to build something together and to work.
And I suppose that alignment is where the leadership piece comes in. It's not always possible to have the same dream. And I think, Antoine, sometimes our dreams as health and care professionals are just not, they're just not relevant to people we're there to serve. And it's that sort of tension that it sounds like you're constantly trying to manage to make this work. I guess my question now is, how do we move to that at scale? So you're doing it where you are, Antoine. How would you get to doing that across the province, across Canada? HC, you're doing it, there's a sort of top-line ambition to do it in Singapore, but the reality is probably much more incremental, and the same here in Portugal, Michaela. How do we move to doing it differently everywhere?
Yeah. It's a tough one. I have a lot of hope about this, actually. Maybe coming back to your issue of power, first, for me, it starts with recognizing that we all have different powers here. Policymakers certainly do have powers, people have powers, professionals do have power, researchers, all of this. I believe a lot in the power of alliances. In my domain, one of the things at the higher level that has been very potentially transformative is the unanimous adoption of a WHO resolution on social participation in health last year by all country members in the world, recognizing that connecting with people, communities, and civil society is not just a nice to have, it's a core function of high-performing health systems. And it should be embedded at every level of care and policy making, including resources for policymakers to understand what this means for them and how to work with people at the grassroots level. So there is change coming, and I see also an emergent global collaboration of people working with communities, with people in different cultures, different regions of the world. I was extremely inspired to see what was happening in Asia, in South America, in Africa, in Europe, in North America, and we're starting to connect these things and think of what is it that we need at the policy level to support these kinds of connection at the grassroots level. So the picture is becoming clearer. I have hope.
Maybe I want to just reference a slide that you had just now about you were afraid of being stuck in a pilot cage. Yeah, and this is one thing I've learned in my time working in quality and safety. We are able to do pilots or new projects and demonstrate certain things, but do have difficulty in terms of spreading and scaling. We call this a spread and scale. In the area of quality and safety, there are quite a few methodologies on adapting and spreading and scaling successful pilots, because it doesn't mean just because a new service or a new system works in one area, it could immediately spread in exactly the same. So there's a methodology around this. So I think we need to, first of all, appreciate that spreading and scaling and sustaining does not happen naturally. There needs to be a defined methodology which we could use, and we could develop this together. And the other thing, maybe I'll make a plug for the ICIC, the 9 pillars, about if you are trying to really work on an integrated project. We reviewed the 9 pillars yesterday, and they are very good markers to ask yourself whether your project or your service actually has the 9 pillars involved in them. Possibly, if you don't have some of the pillars as strong as you need, that's a sign that perhaps your project is going to fall apart or it's not going to be sustainable. That's a technical solution to it.
Thank you. Yeah. Michaela, any last thoughts?
Right. Yeah, not an easy question to answer. Well, I think especially in complex environments, it is important to be very clear what's the task to be done, not have 100 understandings of what's to be done, that everybody is aligned what's to be done. And then there is, then you need strong leadership. You need strong leadership. And in order, why do I say that? Because we all have in our organizations and in our roles so many things to do. And if there is not a clear sign that this is a priority, and therefore you need clear leadership, so that for everyone is clear that going ahead, this project with this partnership is a priority. It will simply go under in the tsunami of things that you do, no?
Yeah.
Because you need focus then, and
so that leadership commitment that gives people permission then to do things how they need to be done to succeed.
Yeah. Can I add a little nuance about spread and scale? I think there's a potential danger also there. A lot of our thinking about healthcare system is shaped by thinking about industry, machine, marketing, all of this. And if what we care about is caring and caring relationships, you don't scale this in the same way as you scale smartphones.
Yeah.
You know, it's not about reproducing and replicating. You know, we were asked early on, how do you clone Ghislaine? Well, you don't.
Yeah.
You know, we're all different. And we were approached by a team in Japan 5 years ago. They said, this is wonderful what you do in Montreal. Can you implement this in Japan? And we're like, no, I don't know Japan. I don't know you. And then what we did, and that's a paper we're going to publish in your journal now about that 5-year conversation with this team in Japan, is to learn, basically learn from one another. What is already happening in your community in terms of connection between people, community members? We learned wonderful things about what was happening in Japan. And so what we learned was the process of scaling across, building roots and connection of mutual learning and inspiration across different communities. So that's another way of strengthening the connection and what we do locally.
Absolutely. HC, final words.
At the end of the day, I think you mentioned that it's the people that need to come to the table. And we mustn't forget healthcare is about the people that we serve, we care for, our patients and their families and the communities. We need to get them into our system. And you talked about the power. We need to rebalance that. Now, I'm saying this to myself because I don't think we do this enough. It's co-designing and co-producing systems. And if it's what the patient really wants and they're demanding for it, the population demands for it, I think that helps us to move forward and sustain the work that we do. Yeah.
Thank you. And I would like to, on behalf of everybody, thank each and every one of you, my co-chair, Roy, Michaela, Antoine, and HC for such wonderful presentations. And I wish we could have stayed longer to talk. And with that, I'm going to hand over, with that inspiration, to Professor Robin Miller, who's going to tell us about where we're going to be next year.
Thank you, thank you. What an amazing panel that was. And in many ways, it may seem a little bit early to thinking about next year because we're only in day 2 of this fantastic conference. But in other ways, that was the perfect panel, I think, to set up what we want to focus on in Birmingham. You know, we heard about digital innovations. We heard about patient-led peer support. We heard about creative population-level health management. And that diversity of approaches and of what integrated care means is what we're going to be thinking about at next year's conference. And I'm going to very briefly now just set out the main themes for the event and show you why we feel that Birmingham is the perfect place to host this conference. So our overall theme is going to be promoting health and well-being through diversity. And there's 3 sorts of diversity that we'll be considering next year. The first is diversity of population. We know that populations are changing through migration, through changing family patterns, through different employment opportunities, and through different cultural exchanges. And if integrated care is going to stay relevant, if it's going to stay responsive to the needs of the people it's here to support, it has to adopt those changes. It has to understand how populations require integrated care to be shaped and to be flexible around their needs. And not only to see that as an issue or a problem, but also to see it as an opportunity, because through those changes, there'll be new connections and new assets that we can build upon. And we want to think about integrated care a lot across the life course, to think about integrated care in times of transition, and how integrated care can address and respond to the needs of those who are often marginalised and excluded from society. So, diversity of population. Our second diversity pillar we want to think about is diversity of workforce. And quite rightly, in integrated care, we thought about the role and the contribution of our traditional health professionals and those who work in social work and related social care disciplines. But we sometimes miss out those who work on the front line of health and social care services, those who have the most contact with the people who require their support, people working in domiciliary care, residential care, those who work in voluntary and community organisations. And we heard in this panel the vital role of peer support and how that can make a real difference to people feeling valued and their care being coordinated. So at the conference next year, we want to think about the role and the contributions of our health and care professionals, but we also want to think about that broader health and care workforce, including those working in the voluntary and community sector. And our third aspect of diversity we want to think about is diversity of intervention. And again, it's important that we continue to understand how care coordination, care pathways, multidisciplinary teams can be used most efficiently and effectively in different settings and contexts. But it's also important that we think about new ways of approaching health and social care, that we embrace digital innovations, but we do that in a way that includes, not excludes others. We think about community-led interventions, and we think about some of those peer support and patient experienced approaches that we can develop. And really important in terms of diversity of interventions is how do we bring those together? Sometimes we understand how a single intervention can make some difference, but how do we best coordinate that to meet the complex and changing needs of our population? And we really believe that Birmingham, West Midlands, England and UK as a whole has got much learning to share with integrated care colleagues across the world, and also much to learn. So now we're going to play a short video which will hopefully whet your appetite to coming to Birmingham and give you an idea of what you will be able to gain if you do come. And this is where you play the video. Thank you. Over the past 20 years, we have learned much about integrated care. What matters to people and families, what are the facilitators and the barriers to collaboration, and how we can work together better with communities and neighbourhoods to address health inequalities.
But there is still much that remains uncertain. How do we best scale up and learn from local innovations? Will best practice be sustained long-term in difficult times? Will AI be a game changer or a distraction?
Birmingham and the West Midlands is home to a diverse and vibrant set of health and care organisations, places, communities and professionals. This provides a really unique context to develop new approaches and also to test existing innovative practice in integrated care.
Integration to me means developing shared values, developing a shared understanding of what we're doing through working and practicing together. So how are we doing that? So some of the ways we're doing that are, for example, integrated neighbourhood teams, developing shared learning together through leadership programs that enable a different and revitalised professional shared culture.
In the UK, we have looked to embed integrated care using a number of mechanisms, such as legislation, performance frameworks and financial incentives.
Integrated care must be based on the interests, experiences and aspirations of people who access health and social care services and their families. At the ICIC26, we're putting co-production at the centre.
We have been working with our local communities to enable them to access their local assets and networks and ensure their support through the primary and social care.
Evidence can explain the barriers to integration and how we can use scarce resources and capacity. Our research collaborations tell us about what methods to apply and how to translate that into real-world impact.
We've been exploring ways of using data imaginatively and creatively to help inform decision-making to improve integrated care. At ICIC26, we're not going to avoid the difficult questions.
Instead, we'll look to discuss, challenge and think about solutions.
We look forward to welcoming you to Birmingham and the West Midlands
to learn of your experiences and design new solutions together.
So that'll give you a taste of what to expect. Well, thank you. And for the next 2 days, our main focus should be this amazing conference and the rich set of activities and presentations which we can enjoy and participate and contribute to. But if you do have any ideas for ICIC26, no matter how wacky or how off the wall they may be, that can bring our dream of bringing a diverse and enriched conference into Birmingham, then please do come and see me. And I look forward to hearing from you and welcoming you to our region next year. Thank you very much.
Thank you, everybody.
Now it's time for pastry.
Tea.
check that they've got everybody's slides. Sure. Can I come back to you? It's quite easy. You'll see it on the screen with your notes and things. There isn't. Oh, actually, he said there was one out here, but there isn't. Let me just go and get that from him. Hello. Oh, nice to meet you. Great, super. I'm just going to get the clicker so that you can have a look at it. Your presentation is there, so we're good on that front. I'll just be 1 second. Oh, it may well be. Super, thank you. Yeah, I'm Donna. Sorry, I didn't introduce myself. I think we might have met somewhere before, but thank you so much.
Maybe in some ethic congress?
Could well be, yeah. Yeah. So forward is the big green button, back is the red, and this is the laser pointer. And it worked very easy yesterday. So I was just saying that we're all sit here in order of speakers. So the first speakers will be at this end. You'll sit there, and then as I'm introducing you, you can come up and do your bit. There doesn't seem to be any time for questions today. I am just going to check, though. I thought we had 6 presentations, but our colleagues from Denmark look as if they're only doing 1. So I just want to check with them if they're only going to have 15 minutes. If so, we will have 15 minutes extra.
Oh, wonderful.
So it would be nice to get a little bit of questions. Yeah, because otherwise it's a bit like, okay. So when they arrive, we'll check with them if they... Yeah. So we might be good. We might be good.
Yes, we could do with a couple more minutes. Always, you know.
And I'll give you 1 minute to go. If you are approaching the end of your 15, I'll give you a minute. Together. Perfect. Okay. Right. Well, that is good then. If that's the case, we do have 10 minutes at the end for questions for all of you. I think so. If it looks like you've got time in your 15-minute slot and you finish early, I'll take a couple. But I will keep us to time, and then we'll save them at the end.
5 to 10 minutes. Are we?
You can take questions. Do you have a little bit longer? Yeah. We can have a couple of questions.
We don't have to talk so quickly.
Well, if they only take 10 or 11, yes. So I'm going to give you your slightly longer because you've got 20 minutes. I'm going to give you your 15-minute slot. So if we finish earlier, I'll take questions immediately after. If not, we'll save that bit at the end. Yeah. You will see your notes.
Okay.
And also, just for the clicker, so it's for forward, it's the green button. Don't panic if it doesn't change immediately. There is a little bit of a delay.
Okay.
Back is the red button, that one there. And if you want to do a laser pointer, it's that big green thing.
Is it possible to me? I just have some papers if everything goes down, because I've tried it before where all technique didn't work. So I have the papers with me. So I'm speaking notes. Is this water? So
There should be water out there. There usually is for everybody. Oh yes, look here.
This is for us, I guess.
Yeah. So,
Hello.
do you want one? Super.
Yes.
I think the easiest way is that they'll come up here, but can I have one mic? In fact, can I have 2 mics? Perfect. Same as yesterday.
Yeah.
Worked very well.
Yeah. So you're that side, I'll be this side. Yeah, and I can hold mine because this will be distracting.
No, because come up here, do your presentation, take any questions if we have time, and then at the end we'll have the roving.
So are we okay to sit down there and then come up, or do we come up on stage?
To be honest, it's just a bit easier if you can sit on stage, but
Yeah,
we'll need
that's
to just check how many, because we've got more than we thought, I think. So we might need an extra couple of chairs. How many have we got there? 1, 2, 3.
Vi sidder altså også lige min side. Ser den der, så kan jeg sætte bagefter. Vi skal lige have et billede fra den her side af, ikke? Ja, men mine notes her, vil du have dine ovenpå? Ja. Det er lidt imponerende at stå i sådan en stor, flot sal. Ja. Vi håber, der kommer til at være nogen, der kommer og følger os. Ja, det er nemlig det. Det vil vi gerne. Helt imponerende. Ja. Virkelig imponerende. Men hvad skal I præsentere? Du sagde lige kort noget med noget... Ja, men intervention, ikke? Ja, så jo, vi har afprøvet en intervention, inden vi går i gang. Ja. Så co-creation ja, altså og arbejde. Det er jeg også spændt på, hvad I så måler på, fordi det er også super svært, synes jeg, fordi når man går ind, hvad er det de her relationer og kontekster, og hvordan kan I det?
Så vi har repræsentanter med, som også har været med til at vælge outcome, og det har så været kombination. Vi måler det på genel.
Kom, vi skal med den nu.
Vil du have en vand med?
Nej, jeg skal bare tage en med. Man ved aldrig, man ved. Nej, man ved ikke. Så heller, du fik en også der. Ja, tak. Kom nu, så er den.
Good morning, everybody. If you're going to be joining us for session 8A, please do take your seats. We're just about to start. Good morning, everybody, and welcome to this session 8A on optimizing care pathways for older adults with frailty, from prevention to hospital and home-based support. So I'm Donna Henderson, and I'm Head of International Engagement with the Digital Health and Care Division in the Scottish Government. And I'm absolutely delighted to be here today to moderate this session with a fantastic panel. And how lucky are we? We've run out of seats. That's how great we are this morning. So welcome, ladies. We're going to be having 6 presentations today. We're hoping to have a little bit of time for Q&A. So if we stick on time, we'll manage to squash a couple in. If not, we'll take some at the very end if we can. If we do run out of time and you don't get a chance to speak to the person that you wanted to ask your question, please do approach the ladies at the end when they leave. So just to kick off, I'm going to invite our colleagues Dr. Grace Park and Margaret Lynn to take the stand, and they're going to tell us about social prescribing and the frailty pathway to support the ageing population health journey in Fraser Health Authority, Canada. Thanks very much, ladies.
Hello, everyone. Thank you for joining us. We're here from Fraser Health Authority, which is in British Columbia in Canada. And we'll be talking to you about some work we've been doing on integrating health and social services in our region. So Canada, like many places in the world, has a growing population. And very much like Singapore, by 2031, almost 25% of our population will be over the age of 65. And in the community that I live, we're already 49% of our community is over the age of 65. So we do have the challenge of caring for our aging population. So Fraser Health Authority is one of 5 regional health authorities in our British Columbia province, and we're at the bottom left corner there, you see by the arrow. And we do have Fraser Health that cares for about 2 million people, and of that we have about 300,000 seniors over the age of 65 already. So when we look at the aging population, we do have to consider trying to provide care in a holistic way as much as possible. So we ventured on this journey of integration of health and community services. So on the left-hand side, we have a common picture in our hospitals, many places in British Columbia and in Fraser Health. These are what we call hallway beds. We're inundated with a lot of demand for care and limited resources. So we have aging population with their complexity, their comorbidities, we have declining resources, and we have a limited number of health professionals to care for our population. On the right-hand side, we have our community organizations that provide social services, and this one is in our community, my community, called Seniors Come Share, now they're called Brella, but what they do is they have community supports, they have a program called Better at Home to support people in the communities, and they have day programs for older adults and a lot of other social supports. But they're also challenged because they traditionally have been funded by grants on a yearly basis. So there are a lot of competitions in the communities of these nonprofit organizations trying to do the work that they want to do, but with limited resources as well. But in 2016, they did come together and banded and they're now called community-based senior service organizations, and they can speak with one voice with the funding body of the government and run multiple programs. So back to the health authority, we were looking at our population and looking at how do we address the aging population and make them a little bit healthier so that they can actually not depend on the healthcare system as much. So we addressed frailty. And frailty, as you know, can be measured now and is measured in multiple different ways. We have phenotype traditionally where you looked at a person who's slowing, maybe has some weight loss and weakness, easy fatigue, low physical activity. And then it went on to a functional assessment. And so that was looking at whether they're mild or moderate or severely frail on a scale of 1 to 9. And then most lately, we're looking at the frailty index, which is accumulation of health deficits. So that is a model of comprehensive geriatric assessment where we look at their cognitive, physical, psychological, functional, and social health. And accumulation of problems in any of those areas will increase the frailty index. And when we look at the social vulnerabilities, we were really struck with the importance of social isolation and loneliness and social vulnerabilities, because at any stage of frailty, if you're socially isolated or socially vulnerable, you suffer more as an older person. And so the Canadian Coalition for Seniors Mental Health came up with a clinical guideline for social isolation and loneliness just last year, and we're in the process of implementing these guidelines. And the first one is to identify risk factors for social isolation. And so certain things, major life transitions like loss of a partner, employment loss, financial stresses, etc., are isolated and living in rural settings, all are risk factors for social isolation, or if there are health risks as well, like chronic disabilities. So identifying the risk for social isolation is number one, and number two is to implement social prescribing. So they very much emphasize the importance of connection in the community and through social prescribing, which is what we had endeavored to do. So in 2019, Fraser Health partnered with United Way BC, which is sort of the backbone organization that supports all these nonprofit organizations in British Columbia. And they receive funding from the government and distribute grants to multiple programs throughout the province. So we partnered with them and ventured on a 3-year demonstration project to develop a social prescribing scheme that was integrated from the health sector to the community sector, because these are two separate streams funded differently and never really did communicate in the past. So this was a demonstration project, and we were successful, so that by 2024 we received more funding, and now we're venturing into 100 community connector positions from the 19 that we started with back in 2016. So when we developed the social prescribing scheme, we worked with various stakeholder groups, and these are the human infrastructure sort of backbone that we had to look at in the health system along with the community. So we have divisions of family practice that represent community primary care practitioners and primary care networks that are team-based care places for primary care, along with United Way, and there are hundreds of nonprofit organizations throughout the province. And within Fraser Health, we also had to work within our organization with all the different multidisciplinary staff, like the home care nurses, the allied health professionals, emergency nurses, as well as the preoperative clinics where they were looking at seniors coming in for elective surgery, for hip and knee joint replacement surgery, and implementing social prescribing in those populations as well. So that moved us to the actual integration process. So signposting is a form of social prescribing, and this has been going on for quite a long time. If anybody as a healthcare provider identifies an older adult with a social vulnerability, they were able to refer them to a phone number, BC211, and a website where they have a repository of community services. If the person is able to do that, that's signposting, and that's really great. But if a person is not able to navigate a phone tree, not able to access websites, they go through to the social prescribing, to the social prescribing community connector, or the link worker, as in the UK. And so we call them community connectors. So when they're seen by the community connector through the referral, then they're able to access the community resources, and I'll talk a little bit more about that in a minute. So within Fraser Health, which is a very acute care focused health organization, much like other hospitals type settings, we had to work to develop a change management team to be able to implement social prescribing within the health authority. And we wanted to do this health authority wide. It's a large organization with 12 different hospitals, 45,000 healthcare professionals, and so we had to work really hard to spread this and make sure that it gets embedded into practice. So we have 2 change leads, an operations, a program director, nursing and allied health educators, clinical nurse specialists, as well as people in IT and communications, along with the leadership structure that allowed us to have their sponsorship and access other regional resources. And we were able to reach many clinical service areas during those demonstration years and have had over 2,000 referrals to date. So the integration really is when a person is requiring community social services, they can self-refer, but usually a healthcare professional identifies a person, maybe in a hospital setting or in the community, receiving home health services and struggling because of some social issues. They can get a referral to social prescribing directly from the EMRs, wherever they're working, either the community or the hospital. So they can fill out an electronic referral form, which goes to the central blue box, the home health service line. And that's the place where all community referrals are sent. And so if a person needs health authority services like personal care or nursing care, they provide that. But now they also provide care for the social prescribing scheme. So after an bit of a triaging process at home health, they'll go on to referral to the communities where the patients live, and they will be connected to a community connector who will access all the resources in the community for that individual. So the seniors community connectors are much like the link workers in the UK model. They're not just system navigators, they're actually a community of practice. We meet regularly with them, both health authority staff and the community connectors meet to troubleshoot, address barriers, bring in education, because these are usually non-healthcare people that are working as community connectors. So we're bringing health information to them so that they can actually address the needs of the patients that we're sending them. And through the community connectors, they can provide transportation to medical appointments, support them with any financial applications. If they have housing difficulties, they can apply for subsidies. And they can also find primary care connections back to them if they're having troubles finding a doctor, which is quite a big problem back where we work. And like many places where they've been implementing social prescribing, through our programs, we're able to increase quality of life. And we're hoping to show this, but other jurisdictions have shown this. There is decrease in healthcare utilization, such as emergency room visits and lengths of stay in the hospital. And we're certainly keeping people home and independent longer and promoting healthy aging. And through the success of our integration, we were able to get the approval from the Health Authority to develop a frailty pathway, which is something that we've been wanting to do for a long time, recognizing that aging is variable and that people age differently despite their chronological age. And so we do need to do an assessment. And so according to the clinical frailty scale, they're designated to be healthy or pre-frail or mild, moderate, severely frail, etc. And depending on where they are on that spectrum, they get a whole host of resources made available to them, starting with the low end where there's community services, municipal resources, and then on to health authority services like home care, caregiver support, and then when they get more in need of nursing care or palliative care, that's at the other end of the spectrum. And Margaret's going to talk a little bit more about the frailty pathway.
Thank you. So just as Grace said, we've come really far, bringing a lot of intersectoral partnership, and now with Frailty Pathway, we're going to look into a little bit more on interdisciplinary partnerships plus intersectoral. So this is an example of a pilot that we're currently doing. This is the original care model in one of the community called Rich Meadows. And we know that if we bring that whole Venn diagram or model that you saw on the previous page and just say top-down approach, everyone does this, it's never going to work. We know that it doesn't stick that way. So we decided to go to each community and do it from the ground up in collaboration with all the local partners. So for example, we have the primary care team, primary care network teams, we're primary care providers. We have home health nurses and managers, their directors. We also have community organization staff there. And divisions of family practice who supports a lot of primary care providers. We bring everyone together, we meet bi-weekly, and we say, here is the idea, here's the principle, do we align, and how would we like to approach? And this graph is actually more of an environmental scan that the diverse team members come up together. So they have realized that this is currently, well, originally the referral pathway, and it's more one-directional. There's not much connection, and most importantly, the pre-frail clients are often missed. So those who are perhaps between the 3 to 6 on clinical frailty scale and those who don't really need a lot of support, but if we don't catch them early, then maybe one day something will happen. So who are they? And that was a question mark before. So after the continuous co-designing process, which started about last year in March, we developed this model. So the community has mentioned that, you know, we love the principle, but what we currently need is a designated role to support this, and we want to see how this goes. So hence we hired a healthy aging nurse, and this healthy aging nurse is quite interesting because we keep talking about silos these few days, and the fundings are also usually very siloed. And this healthy aging nurse actually is trained in primary care and sits in primary care network, but meet with home health very regularly and talk with community organizations quite regularly, and also directly supports the family physicians. So they kind of sit in that liaisoning role. And you kind of see the role of the nurse on the bottom left, but they basically do comprehensive geriatric assessment with each client and then meet with them, tailor care plans together, and then share a care plan with back to all of the care providers or community organization staff involved. So this has built a much smoother pathway where people are speaking with each other, building on existing resources and teams. And here are just a few quotes from our first cycle of evaluation, showing that the clients really appreciated the support. They feel that they were able to learn a lot of resources they didn't know about before through meeting with the nurse. They also feel a lot of empathy and support, kindness from the nurse, and because right now it's quite ideal that the nurse gets to spend maybe 30 minutes to an hour with them at each sessions. And we also conducted surveys asking about their confidence, and all of them said they're very confident in caring for self with the information they're provided. They do find it helpful, so it's not going to just be a pamphlet lying around on the table that no one looks at. They are also aware of who to reach out to when something happens and when they need any support. They feel very contributed to their care plan, and they find the resources helpful for their daily life or for their loved ones. So overall, we had a lot of very good success for this pilot, and right now we're looking into sustainment and further integration and looking into the clients who are maybe don't currently have a family doctor in the community.
And just to conclude, we are thinking, as the speaker from Singapore also said, that a good healthcare system that promotes healthy aging must be based in the community. And it is the supporting wellness that's so important rather than reacting to illness. And so in this scheme, we've put in the municipal resources like the rec centers, the culturally appropriate programs, the clinics, community services, jobs, schools, libraries, clean environment, transportation. All these things contribute 80% of health and wellness. And then we have the hospital and the acute care system in the corner, which is really necessary when necessary, but only have a small role to play in the wellness of a healthy, aging, older adult. And so we're going to conclude there. Thank you for your attention.
Thank you so much. Thank you very much, Margaret and Lynn. And sadly, we don't have any time for questions, but yeah, I'm incredibly impressed with how you've integrated social prescribing, so amongst everything else, so well done. So our next speaker today is Mette Elkjær, who's going to, well, she's coming from the University of Southern Denmark, and she's going to tell us about emergency department admissions among older people with frailty. Thank you.
Hello. Thank you very much for the opportunity to present my study. It's not only my study, we have a broad group of researchers. I'm Mette, and I'm from Denmark. I'm a nurse in the emergency department. I'm a postdoctoral researcher, and I'm the head of the Research Center of Integrated Care in the region of Southern Denmark. Today, I will present results from the study, Emergency Department Admission among older patients with frailty, a root cause analysis. I'll try if it's work. Okay, let's start by briefly introducing the Danish healthcare system. In Denmark, healthcare is free of charge because of taxes funded. There are different sectors providing healthcare. The 5 regions control the hospitals, ambulance services, and the GPs, and the municipalities offer service like home nursing, home care, and rehabilitation. When a person gets sick, the options are 1, to see the GP or outside of business hours. You can speak to a GP on call, or you can call 911. I would like you to meet John. John is a constructed case, a patient I might meet in the emergency department. You might have met John too. His case illustrates some of the challenges we face when delivering coordinated care across sectors. I return to John's story throughout the presentation to highlight some key points. Let me introduce John. John is a 73-year-old man who lives alone in his own home. John received municipal home care services both at morning and evening. An emergency call system has been installed in his home to enhance safety. He suffers from chronic back pain due to previous injury. He has COPD, which require oxygen therapy at home. Additionally, he has undergone prior bypass surgery. His physical function is reduced, and he experiences daily limitation in activities such as walking and personal care. Despite this, he manages his own medication and has not requested for additional help before his admission. He strongly prefers to maintain his autonomy. Socially, John lives alone, but his son supports him with grocery, shopping, and other practical tasks. So, what do we know about acute hospital admission among older adults? First of all, we know this admission can be both traumatic and stressful. For many older people, a hospital stay increased the risk of complication, like delirium, infection, functional decline, and in some cases even led to higher mortality within a year. Interesting, research shows that somewhere between 75 and 25% of the emergency department visits in this group may actually be preventable. But the challenge is the perception of what counts as a preventable admission. It varies quite a lot. A mixed method study from the Netherlands looked at 200 patients aged 70 or older visiting the emergency department, and it found that patients themselves felt about 12% of their admission were preventable. The relatives thought it was about 9%, the general practitioners said 21%, and the ED physician had the highest of them all and believed that 31% of the admission could have been avoided. So clearly, there's no single definition, and different perspectives really shape how we understand preventability. Let me take a moment to examine how older adults perceived emergency department visits. Many of them are driven to seek care at the ED due to ongoing existing health issues. These might be chronic conditions or difficulties with daily functioning that make it harder to manage them in their own place. From their perspective, the ED often feels like it's the right place to go to when the health concerns escalate at home. There are several key motivators behind their decision to visit the emergency department. One major factor is the severity of their symptoms. They may feel they can't afford to wait. Another is lack of trust in the general practitioner, or frustration with how long it takes to get a primary care appointment. The promise of immediate action, often the same day, makes the ED a more attractive option in their eyes. In short, many of older adults, the emergency department present accessibility, timely, and perhaps the most truth-worthy care when faced with complex health challenges. So that's how the older adults look at emergency department admissions. That's why it's so important to understand what actually drives these admissions. If we want to prevent unnecessary hospitalizations among older adults, we need to identify key factors behind them. In this study, we aim to get to the root causes of why frail older patients end up being acute admitted in the hospital. We conducted semi-structured interviews with patients aged 65 or older during their acute admission. By interviewing the patient during the admission, we succeed in include frail older patients who might not participate in an interview at home. We also interviewed their relatives, their GPs, and the home nurse to elaborate the care pathway. To analyze the factors behind each hospitalization, we used an incident analysis tool originally developed for the medical field. We applied the Eindhoven classifications model, which helps identify and categorize root causes of incidents. The model divides causes into 4 main categories: technical, organizationally, human factors, and patient-related factors. We expanded the patient-related factors also to include disease-related factors to capture a situation where the progress and severity of the illness itself led to admission. We included 10 care pathways. In total, we spoke with 10 patients, 8 relatives, 7 GPs, and 7 nurses. Let me take you through an example from the narrative data by reading the interviews, seen from all 4 perspectives. I think you all remember John. In the emergency journal, it says that John was admitted to an on-call doctor due to acute exacerbation of his COPD. But in the interviews, the story became more complex. John himself said he was admitted after a fall at home. His son explained that the admission was due to general decline in his father's health. The general petitioner referred to a note from the on-call doctor which mentioned chest pain and a fall. And finally, the home nurse reported shortness of breath and chest pain as the reasons for admission. So depending on who you ask, the reason for admission changed. This illustrates the fragmented understanding of a patient's trajectory and communication gaps between the key actors. I'll try to take you through the analysis of the root causes. 3 of the authors individually reviewed and identified all root causes of acute hospitalization, drawing on the perspectives from the patient, the relatives, general practitioners, and the municipal care staff. Root causes were identified by the researchers' interpretation of the data by constantly asking why an event had taken place. Relevant causes was systematic exposed. Among others, we identified that John's home care staff has doubt about John's medication compliance, but they didn't take any action to this observation. We coded this as failure in human monitoring. A former friend and doctor is consulted about the oxygen therapy. We coded that as an external human referring to failures beyond control of the organization. In total, we identified 102 root causes for acute hospital admission within these 10 patients' pathways. Nearly half of these root causes was directly related to the patient or medical condition. 14% was attributed to organization factors, including lack of follow-up and poor coordination. And a significant portion, about 36%, involved human-related issues, such as communication breakdowns, inaction, or insufficient competence with healthcare professionals. Interesting, we didn't find any technical failures. So, perspective and further work. These cases clearly illustrate a lack of shared preparation and decision-making. The system tends to rely heavily on a biomedical perspective, often neglected the broader context of the patient's condition, like the social and mental condition, and the functional decline at home. General practitioners face a difficult task. They typically only see a snapshot of the patient's situation and rely on others to fill in the rest. Because of this fragmentation, the emergency department ends up with being the fallback solution. We work together helping the patient, but we are not working together effectively. To address this, we need to strengthen coordination and knowledge sharing across profession and sectors, including the patient and relatives' history and knowledge. Importantly, these complex chronic cases that suddenly turn acute, we must come better to recognizing the early signs of the illness, to act sooner and consider outpatient alternatives to admission. So, thank you to you for listening to this presentation. Thank to John, and thank to patient, relatives, and healthcare professionals for their time and efforts in contributing in data collection. That's all.
I think we'll carry on if that's okay, Mette, and just pick up on any questions if we have time at the end. But I mean, those statistics are really quite staggering, actually, the percentage, that are around organizational issues. So fascinating. I'm definitely going to look into that more. Thank you for sharing. Okay, so next up we have 2 speakers. We have Dawn March and Bhavani Harshini Akhtamakar, who are from Central and Northwest London NHS Foundation Trust. and they're going to be sharing with us rethinking discharge destinations for cognitively impaired patients. So thank you very much.
Hello, good morning all, and my good morning to all respected delegates here and delegates on the dais. As introduced, I'm from Central Northwest London NHS Foundation Trust. We are from the Home First Therapy team, CCOL in Milton Keynes. I'm Bhavani Atmakur, team lead physiotherapist for the CCOL therapy, and I'm standing with my lovely colleague Dawn March, who is pursuing her health psychology PhD currently with the university. We are here to discuss rethinking discharge destinations. As I said, we are the CCOL community hospital. We have 52 beds, which works under partnership. We have our own 19 beds for CNWL, and we hire some beds with partnership with the care homes. So before I get you to the journey of my QI project, I just want to ask you, how many of you share a chat with a coffee or a tea with your colleagues here, going off from the screen time, please? Can you raise your hands if you do that? Only couple, but brilliant. Why I'm emphasizing this is our journey started with a brewing conversation, caffeine and a conversation between a physiotherapist and a psychologist, discussing on all the patients who are admitting into our CCOL hospitals who has cognitive impairment or diagnosis of dementia coming to us and discharging to care homes. This started like a brief conversation during a coffee break, and we were like looking, and we both felt everyone is going to care homes. What is happening here? How to address on it? Is there anything we are missing from the therapy side which can stop this happening? So this conversation, we needed data to prove whether what we are thinking is correct or not. So we contacted our CNWL data team, and we got data just like some 1 year data from September 22 to September 23. Of them, there are like 23%, that is 546 admission that year. Of them, 126 were cognitively impaired or dementia diagnosed patients who came to our CCOL community hospitals. Of them, just make a note, only one patient got discharged to own home. Rest all 122 patients got discharged to care homes. So we reflected on this. This not only has caused longer stays, which was like 56 on average for the patient to discharge to care homes, and complex patient needing more than 100 days to go to care homes appropriately as a safe discharge planning. It made patient to get deconditioned and demotivated, so they lack interest in participating with therapy because patient will come in a mindset, oh, I'm here, anyway my discharge destination may be care home, why have to do therapy? So there was lack of motivation, that leading to deconditioning, lot of funding for NHS and social care to get appropriate placement. This not only caused for patient lack of motivation, but it caused our therapy team doing lot of paperwork because we have to do like referral to social care, referral to other agencies, referral to telehealth, all the services available across the trust to make sure we are planning a safe discharge for our patients. So this all workload, everything has caused lot of funding for NHS and also for social care. So we rethink this approach, we reframe this, and we thought, why can't we focus on to see whether we can stop these discharges happening to care home? So our QI journey started with a cup of coffee to start with.
So following on from that cup of coffee, we started with an aim to reduce discharges to care homes by 25% from December 2023 to December 2024. We used a quality improvement methodology to structure our approach, and to inform the intervention, we used the COM-B model from health psychology. This model helps to create health psychology interventions by identifying factors that affect behaviour, capability, opportunity, and motivation, and guides the development of strategies to improve these factors for behaviour change. The model provided us with an understanding of the difficulties and ways to overcome them. Discussions with staff, patients and caregivers indicated a need for meaningful activities and social interactions that would increase engagement with therapy and improve outcomes. We developed an activity pack including caregiver resources that was informed by feedback from patients and caregivers. We provided staff training on cognitive impairment and developed group activities that were designed using both psychological and physiotherapy approaches to improve physical capabilities and also provide opportunities for social interaction and cognitive stimulation. We also provided education to the patients and caregivers on things such as falls, nutrition and diabetes. Our fundamental change was to reimagine the way we deliver therapy to this patient group, integrating key aspects of psychological and physiotherapy into one patient-focused approach. Communication with patients and caregivers has been a key part of our approach and has reassured caregivers that their loved ones would be able to manage at home. Since April 2024, with all elements of the project in place, we have seen a fantastic 87% increase in eligible patients being discharged to their own homes. This stabilised in the months that followed, indicating a new system was in place. The average length of stay for eligible patients was 40 days, down from 54 days pre-project, and now in line with the wider patient group without cognitive impairment. Longer stays were due to complexity of presenting health conditions, again in line with the wider patient group and not related to discharge destinations. The reduced length of stay resulted in a cost saving of more than £390,000 on occupied bed days.
Yeah, we captured few feedbacks. We captured a feedback from a patient, caregiver, and from our staff, and also from our lovely patient who participated in the group. You can clearly see in the picture, it's not like a design physiotherapy where you will ask like lift your arms, bend your knees, no regular exercises. It should be like making a meaningful activity combined for a patient. So we have included a lot of activities to make cognitive stimulation therapy, which was our main thing to establish meaningful patient-centered activity here. So the patients who came to CCall, who are like not steady on mobility and all, they also gained really good mobility because of good participation in group therapy and one-to-one therapy. And caregivers were very happy because they imagine their loved ones has become better after coming to CCall. And our staff took a pride to conduct all the group exercises along with cognitive stimulation therapy. And they feel like patients are getting socially included. Social isolation was prevented because they are admitted to subacute units or step-down hospitals. And patients thoroughly enjoyed the group activities. So just to emphasize what Dawn said about Combi model, I will give two examples, two stories. I have to use like Bob name, which is very common in UK. So if I say Bob got admitted to us, because we are step-down hospitals, community hospitals, we not only get patients for rehab, but also we get patients who are on discharge to assess pathway, where patient will come to us to know the assessment for their care needs more than therapy needs. So they come to us, if they know the care needs, they can choose what type of care home they can go into. So we had Bob who came to us. Previous history, Bob was falling frequently, he had fracture of a femur and he had surgery. Then his falls were continuous in hospital, he was non-compliant with therapy, very aggressive in behavior. He came to us, all these behaviors continued. So Combi model, I'm stressing on behavior now. All behaviors continued. Then we looked into Bob in detail, what is causing all this. We spoke with his caregivers and known carers. We came to know Bob likes to be in quiet environment after his retirement. Then we moved to one of our partnership unit in CCall, where it is slightly quieter than our regular subacute units. So there was not much settling with Bob's behavior.
Then we looked into ongoing infections. Then we had a long conversation with GP, why can't we start prophylactic antibiotics? Once prophylactic antibiotics started, Bob responded really well, but still not engaging much with therapy. Then we thought, what is Bob? What he likes to do? Then we dig more into his background. He's a retired military officer, so his whole regime was very systematic, very well planned for the day. So first thing we observed, he can't use a call bell. That's why he feel like he can't get any attention. Instead of call bell completely taken out of Bob room, we introduced a manual bell, because in military that time they use a bell to get attention. So once I gave him bell, he became like a different Bob. All of a sudden, military Bob, sitting upright, who doesn't have sitting balance, sitting upright in a chair, and he will press the bell to see if we are coming in to check him on him. That gave him a bit confidence that he's not alone in his room. So he started using bell, hoisting out regularly to build the sitting tolerance, sitting abilities, participation in group. Then all his exercises even though I'm not military trained, it was like right, left, up, go straight, turn around, everything. What made him to be fascinated to come to exercise group. All the questions when we are doing reminiscence therapy with cognitive stimulation was World War, all the things which will stimulate him to participate more, which made Bob to like really interact, do well. Then finally, who was supposed to go to care home, discharged to his own flat, walking with a frame almost independently, having like AM and PM care. That was one good story we got with Bob. The other one is Sally, the other common name I can use. She came in again with multiple falls, neck or femur fracture, very aggressive. This time she is not aggressive verbally, but physically. Carers were like really scared to go near to her because we don't know where we will get nice punch with a red cherry on our cheeks. So we were okay, we went there, we spoke to her. After long discussions, I felt like it took me a week to understand why her behavior is like that. Then I need to get her capabilities to get motivation, like a combi thing. So after observing, we felt like pain was not managed in her case because she was on PRN medications. Patient who has diagnosis of Alzheimer's dementia, not sure like how many can ask medication when they are in pain. So we spoke with GP, got a regime for her pain medication. So once pain was there, her behavior settled, she calmed down really, really well. And then we started looking at her, again, history with caregivers. She was ex-postal employee. She always wore pretty trousers to her work and never wore hospital gowns or any dresses which expose her legs. So we got her trousers from home, started like dressing her how she prefers. And as a part of cognitive stimulation therapy, we collected stamps and printouts of old stamps and everything, and also newspaper cuttings on postal stamps, everything, which made her to engage in cognitive stimulation along with group exercises. So she participated well. Who was not at all compliant for 2 months in hospital setting, came to us, and again she got discharged to own home with only morning package of care, walking with a frame back to her bungalow. So this is lovely feedback we got because we are looking into the patients. 3 things to take home today will be, not home, in Portugal and flying back to your home will be, importance of listening. We all spoke about listening. Listening is not someone actively speaks. Behavior itself has a lot of volume to it. So behavior, in dementia or cognitive impairment, behavior says a lot of words. We need to observe behavior and understand what they are trying to tell from that behavior. So listening not only to patient behaviors, but also to caregivers to know the patients who can't verbalize themselves, are we addressing what they need actually? And also listening to our staff because they spend a lot of time with our patients, so they know well. So listening is very important thing. And the second one, cognitive stimulation therapy with physiotherapy, made it like a structured exercise regime, which is patient-centered, where patient get motivated to participate, which helped for our QI study. And the last thing, when patient comes to us who has diagnosis of dementia, unsettled, lot of behavior issues. Don't come to a default conclusion, oh, he's here or she's here to go care home. There is still that patient can do better in their own home setting. There is a lot of research which says if patient who has cognitively impairment will benefit going to their own homes rather than a care home. I promise this is the last slide now. This is our lovely team who participated in our QI journey. So, frontline staff rethinking traditional care pathways to ensure patient-centered, cost-effective, and outcome-driven care is from us, which is our frontline staff, C-Call therapy team, Milton Keynes. Thank you all.
Thank you. Thank you.
Thank you so much, Dawn and Bhavani. I mean, really, really impressive results again. I mean, 87% discharged to own home. I mean, wow. Yeah, so well done. It's really very good. Okay, so next up, we are moving on to Ada Ribera, who is from the Refit Barcelona Research Group. And she's going to be telling us about implementing an intermediate care hospital at home model for older adults with frailty. So thank you very much.
Thank you. Thank you for the introduction, and thank you to the audience for joining us. I am happy to share with you our experience with the implementation and especially with the evaluation of the hospital at home model we have in Catalonia. That is for frail older adults. So we are talking about intermediate care, and we are talking about an hospital at home model, which is an alternative of intermediate care. So it is person-centered and intended for older adults after an acute episode, surgery, or exacerbation of a chronic condition. With a secondary, they have secondary functional decline, functional loss. We have the two admission pathways, early supported discharge from hospital, from in-hospital patients, the step-down approach, and also from the primary care services, the step-up approach that avoids hospitalization. The principles of the comprehensive geriatric assessment hospital at home are to provide person-centered care. So we have multidisciplinary team, and with integrated care within them. The objective of the service is to provide effective care, so adapted to the patient, the context of the patient and family. Safe care, avoiding hospital-related complications, and efficient care, such reducing occupation of hospital beds. This is our team. It is a multidisciplinary team. We can say that there is a core team with a geriatrician, a nurse, and physical therapists and occupational therapists, and also with a social worker. And then if it's needed, we have also a clinical pharmacist and a speech therapist when it's needed. We are in Parc Sanitari Pere Virgili. Parc Sanitari Pere Virgili is a large institution, is the largest institution in Catalonia providing intermediate care and implementing this model of hospital at home. We have demonstrated effectiveness of the model in several pilot projects. And recently, we also demonstrated the adaptability of the model to the changes in case mix since the COVID pandemic. And now we advocate for further empirical research on this model under the quadruple aim. We want to evaluate health outcomes from the point of view of patients and caregivers. We want to evaluate patients' and caregivers' experience, as well as experience of the professionals, and also the costs of the model. So we started last year project called the COCOA project. This is a wide project with several work packages, and it is intended to construct a kind of a toolkit to perform person-centered quality and outcomes assessment in the setting of hospital at home, of the geriatric hospital at home. As I told you, there are several work packages. In the first one, we analyze regional-wide data on all the hospital at home services we have in Catalonia. We will analyze how has increased the volume of activity and how has changed the case mix. And we also will perform a comparative effectiveness analysis of the geriatric hospital at home model. We also have a work package about experience of professionals, users, and caregivers. We are developing a PREM, a tool to evaluate experience in the context of hospital at home. And we are also identifying the dimensions and the measurement tools that will allow us to evaluate quality and outcomes in this setting. Today, I will give you some results of the first work package. For this, we need to access the data from all the persons that are attended in this model of care. In Catalonia, we have the PADRIS program, and every public research institution in Catalonia can have access to all the data from the healthcare information systems, with the idea of getting the maximum value of this data, so that we can improve healthcare systems, and at the end we go back to the population and improve population health and quality of life. So this data goes to makes this virtuous circle of improvement. So with PLENARY, we have the registry of data from all contacts in the healthcare system of more than 7 million citizens in Catalonia. So for this project, we have access to the complete care trajectories of all individuals older than 65 years old who were admitted to any hospital at home service in Catalonia between 2018 and 2023. So we obtained data from more than 70,000 episodes of acute care hospital at home, provided to older adults, and to more than 2,000 episodes of comprehensive geriatric hospital and home episodes. We can see in this slide how the volume of the episode has increased since 2018, and especially after the pandemic. And particularly, our geriatric model has increased very steeply since then. And both modalities, the step down and the step up approach. And now we have a mean of 40 discharges every month. So let's focus now in the cohort of almost 2,000 episodes you can see in the right, and we will evaluate effectiveness of the service provided to this cohort of patients. So to do that, we will compare the results of the hospital at home process with conventional bed-based intermediate care. So for that, we also obtain data for patients going to intermediate care, to bed-based, conventional bed-based intermediate care. And after excluding repeated episodes and patients with missing data, we could analyze a sample of 1,180 individuals in the hospital at home group and 10,500 individuals in the bed-based care. And we stay in this for a moment, and let's compare. Let's see how is the case mix in both services. You can see here that in the left side, hospital at home, patients attended at the hospital at home are a little bit older, and they are a little more frail than a conventional vet care, and they have a slightly better socioeconomic status. The majority of them are admitted because of fracture, femoral or hip fracture, but also all other diagnostics that are typically admitted in intermediate care also can go to the hospital at home. So now, to compare these two populations, we have seen that they have slightly different case mix. What we did, and I will not go into further technical details, but we performed propensity score matching techniques to obtain a cohort of comparable patients in both groups, in the hospital at home group and in the conventional bed-based group. So we got a matched sample of 961 individuals in each of these groups, and now we can compare outcomes in a fair way. With this slide, you can see how the propensity score matching technique make both groups very similar. You can see here the standardized difference between baseline variables between both groups, and you can see that after matching they approach, the differences approach to zero. That makes us confident that we can compare the groups. And what we see is that we observe a higher percentage of days at home after discharge in the hospital at home group with a lower length of stay, 35 days of mean stay for the hospital at home group. And we have lower proportion of new admissions to residential care after discharge in the hospital at home group. And that is without differences in survival. You can see that survival curves are the same, are identical, and without differences in time until first hospitalization after discharge. So we conclude that when care at home is possible, it offers an effective, safe, and person-centered alternative to traditional inpatient care for older adults. That patients attended in the comprehensive geriatric hospital at home spend more days at home during follow-up and have shorter length of stay. It is still necessary to improve equity, because with lower socioeconomic status, maybe it's difficult to get private social care, and then it's not easy to provide care at home. But comprehensive geriatric assessment hospital at home represents a promising and efficient strategy for improving outcomes for older adults. So just to end, I just show you, this is work in progress. This is from another work package, but I want to show you some of the experiences of the caregivers. During all the project, we realized that the caregiver is a key actor in the process of care, especially if it is at home. So we are making great efforts to evaluate the experience of caregivers. And just let you read the experiences. Most of them are about burden. They need information and training to feel confident with the care of their family members. And that's all. Thank you very much for your attention.
Thank you so much, Ada. I mean, for me, interestingly, your summary, you didn't mention that reduction in admission to care homes. I mean, that's really significant, you know, 20%, 26% reduction in it. That's, yeah. It's actually striking me that if we could combine all of the approaches that we've heard so far, what an impact we would have. There's a new project for you, ladies. Anyway, last up, but by no means least, we have our final two speakers. So we have Camilla Black-Rosen from the Elective Surgery Centre, Silkeborg Regional Hospital in Denmark, and Merete Gregersen from the Department of Geriatrics in Aarhus University Hospital in Denmark. So I'm not going to introduce your presentations. You're going to do that yourself because your titles are too long. But over to you, ladies.
Yeah. Thank you for the opportunity to present our feasibility study. We have chosen to present together as our talk builds on each other and are based on a shared project. I will begin by presenting the background of our study, how we co-develop an intervention focusing on prehabilitation for older orthopedic patients, what the intervention involved, and the qualitative part of our feasibility study. Afterward, Merete will present the quantitative findings and how we adapted the intervention based on what we learned. We hope you are happy with this format and that we can hold questions after both presentations. This project was born directly from clinical practice. In our orthopedic department, healthcare professionals noticed a growing problem. Some older patients were struggling during their surgical pathways, and some were falling through the cracks of standard care. It became clear that we needed a more tailored and proactive support. To address this, we built on an existing concept in our hospital called Supercare. It is a clinical tool used to identify patients who may need extra support to complete their care pathway. From this foundation, we developed Supercare Geriatrics. It is a targeted approach focusing on frail older adults referred to elective orthopedic surgery, aiming to strengthen them beforehand and support a better recovery, as we know that frailty increases the risk of complication, delayed recovery, and longer hospital stays. The good news is that frailty is modifiable. In cancer care, we've seen that prehabilitation, meaning preparing patients through nutrition and physical activities, can improve outcomes. By the same token, comprehensive geriatric assessment, or CGA, has showed promise in supporting recovery in frail surgical patients. Yet, no standardized model exists that combines CGA with physical and nutritional optimization for frail older adults. That's the gap we set out to address. To ensure the intervention truly met the needs of frail older adults, we took a co-design approach. We involved two representatives from the local and regional senior council. They played a key role throughout the project, for example, in shaping the intervention components and selecting meaningful outcomes. They continued to advise us on adjustments that could make the intervention more relevant and acceptable. We also involved a representative from the municipality, a geriatric nurse, a physiotherapist, and a surgical pathway coordinator to ensure the intervention was realistic and clinically applicable. Okay, let me now walk you through what the intervention looked like in practice and how it was delivered. In short, we co-designed a 4-week multi-component prehabilitation and perioperative care intervention. Once the GP referred the patient for surgery, the hospital contacted the patient about a prehabilitation consultation about 1 month before the planned procedures. At this consultation, the patient meets with a geriatric nurse and a physiotherapist. The patient was encouraged to bring a close relative. To make sure the intervention targeted the right group, we used a brief MPI, which is a short frailty assessment that looks at areas such as functional ability, nutrition, medication, comorbidities, and social circumstances. During this consultation with the patient, the physiotherapist and the nurse and a relative, if the patient chose to bring one, an individualized exercise and nutrition plan was developed. The geriatrician does not meet the patient at this stage, but reviews the patient's medication list and sends out any relevant recommendation to the patient's GP. During the following weeks before surgery, the nurse calls the patient weekly. These calls are used to coach and support the patient, focusing on behavior change, goal setting, tracking protein intake, and physical activities. The nurse also calls the days before surgery to answer any questions and offer reassurance. After the surgery, during the hospital stay, the geriatrician is involved in medication management and overall medical follow-up. A discharge summary is sent to the patient's GP. Finally, as a part of standard care, the GP and local home care service follows up with a home visit within 48 hours after discharge. Now that you have heard how the intervention was structured and delivered, I'll shift to focus on how it was experienced. This part of the study explores the perspective of those directly involved, both older adults who participated and the healthcare professionals who delivered the intervention. We conducted qualitative interviews with 5 older adults around 1 to 2 weeks after surgery. We also interviewed the healthcare professionals involved. Because this is a feasibility study, the main goal was not only to explore experiences, but to learn and refine the intervention for future use. For each main theme, I will first share a quote that captures the experience and then briefly reflect on what we learned. One of the strongest aspects of the intervention from the professional's point of view was the ability to tailor support to each patient's specific needs and preferences. As one physiotherapist explained, "I really appreciate taking the time to get to know the patient before intervening. The truths come out and we gain a better understanding of them." What we learned is that early structured assessment are essential for building trust and understanding each patient's situations and needs. Tailoring support based on this knowledge, even with small adjustment, can have a significant effect. From the patient's perspective, what really made a difference was a practical, down-to-earth support they received. As one patient said, "I got a list of protein-rich products and they were all available at the grocery store. I drink more milk than I otherwise would have done, and I've eaten these Yogo-Light products." What we learned is that when guidance is simple and realistic, it builds confidence and leads to a lasting change. Flexibility was also important. For example, some patients preferred to exercise in social settings, while others wanted to do it on their own. Helping patients feel supported and focus on what matters in their daily lives was a key to keep them engaged. The importance of having a support system became very clear during the study, as one patient reflected. It was really good that Eva, which is the nurse, called once a week to ask how I'm doing and if I'm taking the protein I should. But it would have been difficult without my daughter's help. What we learned is that support needs to come from both healthcare professionals and relatives. Personalized contact from healthcare professionals offer reassurance and motivation, but family support was just as essential. We also learned that while patients appreciated the weekly calls, others preferred less frequent contacts. Flexibility was the key. Collaboration across discipline was another major theme in our study. As one physiotherapist said, the collaboration meant that we could adjust care plans in a more integrated way. Working together gave professionals the chance to learn from each other and respond more flexible to the patient's need. What we learned is that interdisciplinary teamwork fosters synergy and enables a more person-centered care.
Yes, and now to the quantitative part of the feasibility study. 46% of the screened patients were assessed as pre-frail or moderately frail, and 4 patients declined participation, and 10 of the 14 included patients completed the intervention and follow-up. And here you can see the baseline characteristics. Most were females and were living alone and were treated with 7 medications or more, and none of the patients were severely frail. Throughout the 4-week intervention period, as Camilla presented, adherence data showed us that exercise measured by exercise adherence rating scale was on average 21 points out of maximum 24 points. The medication review by geriatrician led to a change in 1 drugs for 5 patients with the maximum number of drugs was 12 per person. All patients adhered to the advice of protein-rich diet supplements and consumed primarily protein drinks, skyr, and cheese and milk. And the person achieved on average of 6 of the 8 planned phone calls from the geriatric nurse. Due to the design of the study, we did not test statistical significance, as it is a feasibility sample and it was too small and without any control group. However, we registered that 1 participant was acutely readmitted due to surgical wound infection and constipation. Total hospital days within 90 days, and that included index admission, were 2 days. Also, we measured changes from the patient's first hospital consultation and until 90 days after surgery, and we found that physical function improved by 3 points on the functional recovery score, and it's a scale ranging from 0 to 100. Frailty status remained unchanged, and quality of life improved by 9.5 points on the 100-point EQ5D VAS scale. And no harm or intended consequences were identified during the feasibility study, and none of the patients died. So, before we continue with the stepwise RCT and include hopefully all municipalities in our region in Denmark, we will look into the patient pathway for refinements. So, you have seen this picture before, and in dialogue with the general practitioner, the research team suggests that the GP takes care of the frailty screening of the older persons before their referral to planned surgery. And it will hopefully avoid overseeing patients who may benefit from the intervention. The next issue was raised by the healthcare professionals who suggested that the geriatrician meets the patient physically before surgery to better assess individual needs and not only the medication list based on information from the medical chart. And having the geriatrician as part of the interdisciplinary team already at the initial consultation could be valuable in preventing falls, as 2 patients dropped out of the study due to fall traumas. And we found that all the included patients brought a relative to the first consultation at the hospital. So also there were challenges for non-Danish speaking patients who often relied on family members as interpreters. And this support played an important role in the participants' ability to adhere to the intervention. So therefore, information to relatives is essential. And as the prehabilitation takes place in the patient's home, we also need to involve the physiotherapists in the municipalities in the daily exercise program. During hospitalization, the orthopedic and geriatric interdisciplinary team need to cooperate even more to prevent perioperative complications. And within 48 hours after discharge, a follow-up phone call from the geriatric nurse is planned to check if everything is okay at home and whether a contact to the GP or home care is necessary. The strengths of the feasibility study were the active involvement of patient and healthcare professionals in planning the study. And this collaboration facilitated the development of comprehensive care, and the patient involvement influenced the choice of outcomes, and the co-design improved the intervention by making decisions together. And older patients wanted to participate in the study, and we could include both quantitative with qualitative findings. We also had some limitation, and it was the perspectives from relatives who played a significant role were not included in the co-design. And the participants were included from one municipality only, and there was a limited number of participants and a high dropout rate of 29%. To sum up the results, a multi-component prehabilitation and perioperative care intervention was found feasible for older persons with frailty referred to orthopedic surgery. We could recruit the patient, and patient's adherence to the intervention program was acceptable, and refinements of the program are needed before upscaling the RCT to the whole region. Simultaneously with the RCT, we will conduct an evaluation in order to implement the program and also evaluate the integrated health costs. So thank you for listening, and we are happy to answer your questions.
Great, thank you. So we do have time for some questions, so if anybody would like to ask any of our speakers, thank you, Moretti and Camilla, if you just take your seats. So if you would like to ask a question, you have to do a little bit of gymnastics to get to one of these 2 mics that are there. So if you do, just make your way now and we can take them. And while we're waiting to see if anyone has any, and they're thinking about them, what about our presenters? When you were listening to your colleagues on stage, were there any questions that you wanted to ask anyone? So I'm seeing little nods of heads. Anyone?
Actually, I don't have a question. I'm just reflecting over all the presentation and the complexity of the intervention you built on some of the other nice presentations. So it was just reflecting. I was, yeah. So I were just
nodding and reflecting. Yes, absolutely. I mean, I think particularly with the last one, I'm going to be very interested to see where you take that research. You know, the next steps. I will just ask one on that point. You involved the healthcare professionals, GPs, the physiotherapists, the other professionals, geriatrician, in the co-design process. But, I mean, how did they respond to the kind of new care pathway? Were they quite positive overall, or did they feel that it was going to cause more work, or how did they respond?
I think they reacted positively about they can see the challenges with the frail patients, and we found that in a previous study we found that 1 out of 10 of the 65-year-old patients and older are frail. So they have seen many of these patients and found that there should be some more interventions to improve or to avoid these complications after surgery. As I mentioned, constipations and also infections, wound infections. So I had a good feeling of the cooperation with the GPs and the orthopedic surgeries.
So
also the patients.
Is that because they were seeing that there were things that were avoidable if we addressed those earlier? Yeah, so things that these, you know, patients were suffering from that could have been avoided or improved on easily. Yeah.
Yeah, and there's the prehabilitation intervention is also we are based it on the literature. So we know that for frail elderly people with, for example, cancer, it improved the pathway for the patients.
Great, thank you. Okay, so apologies there, I wasn't keeping my eye on the audience, but if you can just quickly introduce yourself and ask your question, thank you.
Sure. Thanks very much. Great presentations. Jocelyn Charles, I'm a family physician from Toronto. I had a question about the emergency department visits. One of the challenges that I see is where we've had a discussion about a palliative approach to care, and it's almost like a panic, and they go to the emergency department, and how any strategies around that. And my second question is, I also oversee some transitional care units, and we do have a high rate of transfer to long-term care. Our wait times are 4 to 5 years. And some of the families, we get into the discussion about how to get people home, and they're reluctant to participate in the discussion. So I don't know if any of you have any wisdom around these two issues.
Okay, anyone want to take that first question around emergency care? Hands up. Go for it. Sorry, there are a few of us here.
I just want to understand your question. You talked about that the people rush to the emergency department because, and I can say that our study shows that, and earlier studies from others shows that they rush because of some of the points I told in the presentation, because they don't have any other opportunities. There are health problems. It's a good way to release some of the chronic exacerbation, as example, COPD. They don't have the time to wait to the solution. I think maybe it also have to be they have to be affected mentally. They're afraid. They are alone. I think before this section we heard a physician talking about how all the surrounding problems around our health do that we seek emergency departments or doctors, and it's not always because of we have a health problem, but it's also a symptom of the complexity around people. So I try to explain it.
Thank you.
First, yeah.
Just on your second question, I mean, I think we certainly share that same challenge in Scotland. The access to long-term residential care is incredibly challenging. And so that's why I was particularly interested in all of your presentations, because the combined efforts are having that impact on, slowing down that requirement for people to actually make that progression into care. I'm not sure if we really answered that one, but maybe we can catch up about that later.
Not sure we have an answer, but it's good, food for thought.
Thank you. Okay, we've got a couple of more, so we'll just squash them in. So if you can just introduce yourself and your question, that'd be great.
Thank you. Hi, I'm Ole Gunnarsson. I'm from Reykjavik. I have background in geriatric rehab. That's what I work with. And we're very interested in starting a prehab program. So I was wondering, because you didn't really touch on that, the fallouts or the dropouts, the 29% or whatever they were. Do you have any sense of what they were? Were they the ones who had severe COPD, the ones who had severe cardiac disease? I'm assuming they were not dropping out because of their osteoarthritis, because that's probably the reason they were there in the first place, and they were going to surgery. That's the one thing. The other thing is your follow-up between the time of the first appointment till the time of surgery. Do you see any, possibilities in increasing that follow-up with your team or the geriatric team in order to sort of enhance the participation and get people, not to drop out?
Yes, that's a good question. Two good questions. Thank you. I think that the dropouts, it was 4 patients. It was due to complicated surgery. So it was during the perioperative phase there was some complications. Yeah. So yeah, they dropped out. And I don't know how, and that's why I suggest that the orthopedic surgery and the geriatrician should cooperate even more to avoid these dropouts for the such a study. But I think in the real world they could, it could still be a good choice with this collaboration, and not only for a study. And also the question about, what was it?
About your opportunities for follow-up.
Yeah,
we
could cooperate with the municipality even more, because the rehabilitation phase for these patients are structured. The municipality physiotherapist follows the patients after. And that's why we want to include them already at the pre-operative phase. So yeah, it's more integrated.
That's a really, really good idea. Okay, so we're at lunchtime, but we have waited very patiently. So if our speakers don't mind waiting for just one more, we'll just wrap up after this question. Thank you.
Hi, I'm Shane Koja. I'm a physiotherapist, and I've been working on an integrated care technology. My question is that there are so many pieces of research and pilots that sort of exemplify the value of integrated care. How are you thinking about aligning the incentives? Who cares to make the change? Who actually cares in the system and has the power to really help promote change?
I'm going to go to one of our speakers. Yeah, Margaret?
Sure, I can start first. I think that's a wonderful and very big question that probably has multiple answers. And I wonder if this ties to the first question about emergency department as well. But I think one of the strengths that we use to address the challenge is to bring the idea and the ownership to those who are in that care. And we found that approach very helpful because it's not just a one decision of let's do it like this and then trying to get the buy-in. Is in the beginning, how do you set up the environment or the meetings in a way that everyone feels like it is their idea and their ownership. So I think that's one of the big pieces where the change management come in, that everyone either, for example, oftentimes we start with a client story, a patient story, or we raise the question of what are you observing? And then when everyone shared, then even though they come from different background or position, different hierarchy, they will realize, oh, we're experiencing the same things. And then they start to find common ground. And then at this time, when you introduce a bit of a starting point idea, for example, in our case was the frailty pathway, we introduced the CFS and then CGA, but we didn't exactly say how to do it. And then that, in collaboration with the ownership that everyone starts to feel, then it's like, okay, yeah, we can do this together. We want to do something, so then that become a collective decision. So that is, I guess, along with that, of course, there's also the more like structural and organizational funding and where do those money goes to. And we are currently at that phase of showing, these are the voices of the diverse partners, and we need you or whoever, holds the resource to see this, and let's discuss where to go next. So that's one of the way. And the other really helpful way is I think we've been very lucky that the decision makers, for example, the directors or even higher leadership, the managers, they have been in the conversation since the beginning. And I'm sure everyone always starts with a little bit of a question mark, like, should we support this one, or jump to the other meeting? But I think with this continuous conversation, I think we do see a lot more engagement, and they always want to hear what's going on. So I would say it's a cycle of trusting relationship.
Thank you for sharing that. Okay, so I think that's us. We've run out of time, we've run over, but thank you all so much for your attention. And if you can just join me in thanking all of our speakers today. Their presentations will all be available on the IFIC website, so you can pick them up there, and enjoy your lunch.
So different perspectives. It was quite fun, but it's also quite complex to make interview data. Yes. And some of the learnings you have in qualitative interview data is here in this presentation. Yes. So thanks a lot.
Yeah, I was really inspired on how you presented that, the different perspectives, and actually forming the conclusion of that.
no, here, you have to, you have to always use the clicker. I'll make it this, then I'll make this larger for you, okay? Don't worry.
That'd be great. And this is all. Okay. Thank you
Okay.
so much.
Okay.
Thank you.
No, actually, no. I'm delegate as well. I was just wondering.
I think they're in behind stage.
Oh, yeah.
Yes, I'm up for that. Question for the tech. Sorry, I will distract you. Are they in this way? Yes, they're here.
They are?
Okay, because I don't know him.
Yeah.
When we log in, someone could talk with him just to make sure everything's okay.
What time do you want? The session's at 4:45, so I can hear at like 4:15.
In the break between your session and the other one. Yeah.
Okay, perfect.
I'll be here.
I'll come early.
Okay.
Yeah, okay. Thank you.
Thank you.
Yes. Good afternoon, ladies and gentlemen. So we're going to start this session, session 9A, that has as a title, Expanding Access to Integrated Care. So I just want to make sure that all of you are in for this session. We have 4 presentations, and the agreement that I have reached with the speakers presenting this afternoon is that they will have 13 minutes each to present, and then we will have 2 minutes for burden questions. Now, without further ado, I would like to introduce the first speaker. She's Maria O'Brien, and the title of her presentation is Using a Population Health Planning Approach to Provide Timely and Universal Access to Diagnostics for Chronic Disease. So, Maria, it was yours. And I think you all need to press the button.
Thanks, Alberto. Good afternoon, everyone, and I'm delighted to be here today to tell you a bit about the approach I suppose we've been taking to using a population health planning approach to try and promote access to diagnostics for chronic disease as part of our integrated care programme for chronic disease in Ireland. So just by way of background and context, I suppose where the need came for this direct GP access programme, we have a GP contract, which is a structured management of chronic disease programme in Ireland, which is delivered through general practice, which commenced in January 2020. And it provides structured chronic disease management for patients with one of 8 diagnoses, so atrial fibrillation, heart failure, ischemic heart disease, TIA, stroke, type 2 diabetes, COPD and asthma. And in addition to that treatment programme and management programme, we had an opportunistic case finding and prevention programme components have been launched in February 2022. So this was, I suppose, a significant programme that was being delivered through general practice, but we needed to enable the general practitioners to provide that service and deliver the programme by providing timely access to diagnostics, and which I suppose heretofore was a challenge. So the other, I suppose, really important, development in terms of delivering integrated care for chronic disease in Ireland was our enhanced community care programme, where we were establishing 30 community-based chronic disease specialist teams, which were being rolled out across the country to deliver on our integrated model of care for the prevention of management of chronic disease. And I suppose the importance of those teams were that they were in the community, they provided specialist opinion and access to specialist opinion and services to help to support patients to manage their chronic disease, but to also support GPs in delivery of the GP structured management programme for chronic disease, and had a range of services in place. So up to this, few, if any, GPs had any direct access to diagnostic services for chronic disease. And I suppose the specific diagnostic tests we're talking about are NT-proBNP, which obviously is a blood laboratory test, echocardiography, and spirometry plus or minus reversibility, and that's what I'll focus on with you here today. The waiting times for echo were varying depending on where you lived across the country, from 8 weeks to over 12 weeks. And direct GP access was required, as I outlined earlier, to support the rollout of the model of care by providing that direct GP access to spirometry, echo specifically, and also to NT-proBNP. So again, just by a little bit of background and context, this is our model of care for the prevention of management of chronic disease in Ireland. And I won't go into the detail here on this slide, but I suppose it's describing care at 5 different levels. Level 1 there is the general practice, and that's where a chronic disease management programme is. The green level number 2 is where our community specialist teams are. And then obviously we have the traditional acute specialist care at the levels above that. But I suppose what we were trying to do, and I suppose the reason I'm showing you the model here is that what we were trying to do with the Direct GP Access programme was focusing on increasing access across the population to diagnostics and moving it from the tip of the pyramid down through the bottom layers of the pyramid. So up until now, if you were a GP and wanted to refer a patient for NT-pro, BNP, echocardiography, or spirometry, the patient would present to the GP. The GP would deem that the diagnostic test was necessary, and he would send a referral for the test or send a sample to the local laboratory for NT-pro, BNP testing. GP referral, I suppose, once it was received, would be reviewed by the specialist, which would be the consultant in the acute hospital. The patient would be sent an appointment for an outpatient clinic for echo or spirometry, and the patient would wait. And there were significant waiting times of months, in some cases reaching into years, for echo and spirometry testing for diagnostic purposes for chronic disease across Ireland. The diagnostic test, once it did happen to be scheduled, would be done in an acute hospital, and the test may or may not be done prior to an outpatient appointment. So oftentimes patients would turn up for an OPD appointment, but they wouldn't have had their diagnostic test, would have to then be scheduled for a diagnostic test and come back again. So it really wasn't patient-centred in the approach. The patient was reviewed with the results once the diagnostic and the test came back. And the patient would then be discharged back to the GP and reviewed after a period of time. But that whole process could take anything up to 12 to 18 months, depending on what the level of service availability was in your locality. By introducing the direct GP access referral pathways for chronic disease diagnostics, what we've done is changed, I suppose, the processes in the following way. So for a patient presenting to the GP and the GP deeming that a diagnostic test is necessary, the GP can now directly send the blood sample to the local laboratory themselves for NT-pro testing, and the laboratory will return the result directly to the GP themselves. And this could happen and have a turnaround time in a matter of 2 to 3 weeks, which is a significant improvement on the wait times that patients would have had heretofore in terms of waiting for a result of NT-pro BNP, usually for a diagnosis or suspected diagnosis of heart failure. In terms of the echo and the spirometry piece then, the GP refers, I suppose, the patient to the community specialist team. The GP, I suppose, referral is then reviewed and triaged by the specialist team to see how urgent it actually is. So does it need to be seen within 2 weeks, or can it be seen within 6 weeks? And the patient is sent an outpatient appointment. The patient waits, but the test is actually done in the hospital setting, or it can actually be done prior to that. It can be done in the hub by the physiologist. So then the GP will, I suppose, having referred, will have had access within the space of a couple of weeks. The patient will be sent the appointment for the diagnostic test. The test will be performed within the community specialist team, so the patient won't actually have to attend their local hospital. And the results will be again reviewed and a diagnosis sent back to the GP very, very quickly, and potentially the patient discharged back to the GP again within a very short period of time, usually up to a period of about 8 weeks. So again, I suppose it's bringing this care back to the community, supporting the GP to help the patient to be cared for in the right care, in the right place, at the right time, and to be cared for as near to home as possible. And I suppose there also is the opportunity that when the GP is sending in a referral for echo or spirometry that they deem that the patient might actually need referral to an integrated care consultant, which is a new post that we have in Irish chronic disease management, that they can be referred to that for that specialist opinion as well into the community specialist team, which is providing a completely alternative to the OPD pathway. So as I said, timely diagnosis, closer to home, improved continuity of care, and really patient-centred. So that, I suppose, is the service that we've now been implementing over the last 12 to 18 months. And I suppose how we actually designed and determined, I suppose, what the level of demand would be and resourcing would be for that service was to actually look to take a population approach to it. And we had to look at the estimates for the demand for the tests arising from primary care, looking at populations across the country and the different regions. And I suppose what we're trying to do is focus on supporting equitable and timely access, because before we started this programme of work, as I said, it was a little bit of a lottery depending on where you lived within the country, depending on what the capacity within your laboratory was and what the access to services was within your local acute hospital. So based on the population of the region and based on incidence rates of chronic disease, we were able to determine what the potential demand for NT-proBNP and for echocardiography and spirometry would be across the population in the different regions. And based on that, we were able to resource and calculate the resourcing that would be required into the local laboratories to meet the increased demand for NT-proBNP, and also to increase the number of cardiac and respiratory physiologists who would be available to deliver those services within the community specialist team. So we put together a significant business case which went to senior management within the HSE, and we were successful in securing 21.5 whole-time equivalents across the country in our laboratories to specifically deliver on the NT-proBNP testing, and 80 senior physiologists divided between cardiac and respiratory across the country to deliver echo and spirometry, which was a hugely significant investment in those services across the country, probably heretofore not seen to that level. So how has it been working, and what are the challenges that we've come across? So I suppose in terms of NT-proBNP testing, we've had to do, I suppose, a significant amount of work just trying to make sure that we had calculated the demand right and that we had, I suppose, demand management strategies in place to make sure that the test was being used appropriately by general practice. So as part of this work that we've been doing, there was an audit via chart review was conducted across 10 general practitioners to look over a period of 6 months at the NT-proBNP test that they'd ordered. The audit returns on 192 tests for patients over 65 years were received, and I suppose the findings were that less than 20% of those tests led to a referral to hospital services. More than 80% of the test results that were received as a positive NT-proBNP result were managed by general practice and never had to be referred into the hospital to be managed. And 36 or 19% of patients were referred to secondary care, which suggests that GPs were appropriately managing the majority of patients, but with abnormal NT-pro results in general practice, or where it was particularly high, being referred for specialist support to the community. What was a really important finding for us was that 82% of the tests were being ordered within the clinical guidelines or the criteria that were set out for GPs in terms of ordering, which I suppose was important in terms of managing the demand. And again, I suppose our NT-proBNP availability has actually, reduced. Referrals to the diagnostic outpatient community teams for patients have been reduced by 51%, which is significant. And our AMAU referrals for those patients have also been reduced by 76%. So by introducing a direct GP access to a diagnostic within the community, what we've managed to do is actually decrease the footfall into the acute hospital, which has been very, very important and significant. In terms of the echo and spirometry, this has been a little bit slower to get up off the ground. So we had 42 cardiac and 38 respiratory physiologists funded. And I suppose we have had significant challenges in recruitment of physiologists because they're actually in short supply. So we haven't managed to recruit our full complement of 80 across the country. But where we have actually recruited those posts into the teams, there's been significant work cleared by those physiologists in terms of clearing the long waiters from the wait lists. And a reduction in the waiting times where direct GP access service is operational, which again is a real improvement in service for patients. Here is just some of the results, I suppose, that were delivered over a 12-month period from January to December 2024. And as you can see, as the service was being stood up, we had increased numbers of services, increased number of tests across the year. And again, looking at, I suppose, the numbers of tests that were being delivered was really in line with what we had predicted the target numbers to be. And again, similarly in terms of echo. So I suppose just our main challenges in terms of implementing this direct GP access. As I said, heretofore, this was a new way of delivering access to diagnostics within Ireland, and it's, I suppose, worked with 3 particular diagnostic tests with the view to maybe using this approach for others. But I suppose our challenges have been initially from the get-go, having poor data to inform the estimates, population estimates, and to support our options appraisal was actually quite difficult. And again, I suppose our options were, do we directly employ people in our services or do we outsource to private providers? Again, it was challenging with the data that we had available to us to be able to make those decisions at the beginning. Lack of IT, like we have a serious challenge in Irish Health Service in that we don't have an electronic health record, so the sharing of information and integration across community and acute is actually quite challenging. So for people who have had echocardiography in acute hospitals, the sharing of scans across hospitals can be quite difficult. Now there is a programme of work happening to try and set up that integration, but it's just happening quite slowly. Workforce development, I think we've heard a number of different presentations over today and yesterday highlighting the problems and challenges with limitations of workforce, and again shortage of medical scientists and cardiac and respiratory physiologists has been a challenge for us in terms of standing up this diagnostic piece, but there has been national workforce development work is ongoing to try and increase the actual throughput through universities of the number of physiologists coming through to actually meet the demand. And again, I suppose the direct GP access, it's a new way of working for both GPs and services, so there was a lot of engagement required with GPs in terms of, I suppose, communicating the service, how to actually use it, but also making sure that the service was used appropriately, that it wasn't over-flooded, and that we would end up, I suppose, collapsing the service as we were trying to build it. But that has been really, I suppose, positive engagement and really positive feedback from patients in terms of the work that the benefits that they've seen in terms of timely and actually a more immediate access to diagnostics. And one of the big things I suppose that's just happening now is that we're actually starting to introduce electronic ordering of NT-Pro testing and other laboratory tests through our GP systems, which will be rolling out over the next couple of years, which will be a significant improvement, I think, in terms of managing and delivering the direct GP access services across the country. Thank you.
Any short and burning question for Maria, if it is the case? Otherwise, we will move to our next presenter. None? So, thank you, Maria. So, our next presenter, actually there are two presenters. The title of the paper is Rapid Access to Youth Mental Health Support for Primary Care Providers, the Scope Kids Model in North Toronto. And it will be jointly presented by Kitty Pang and Dr. Karen Wang from Canada. So the floor is yours.
This is too forward? Okay, thank you. Hi, everyone. Thanks for the opportunity to share our local experience from Ontario, Toronto, Canada. I'm here on behalf of the North Toronto Ontario Health Team, a local collaboration working to improve care integration in one of Canada's largest urban centers. Ontario Health Teams are part of a province-wide transformation launch in 2019 with the goal of creating a more connected, patient-centered, and sustainable healthcare system. Each OHT is geographically defined work of health and social care providers accountable for full continuum of care for the population at maturity. At NTOHT, our vision is a seamless and equitable system where care is coordinated, responsive, and centered on what matters to patients and caregivers. We serve a population of approximately 200,000 people, including diverse and vulnerable communities, and are anchored by strong primary care leadership, acute care partners, and community-based agencies. So why support primary care? Primary care is the front door to the healthcare system. It is where patients build lasting relationship, where prevention happens, and where care is coordinated. It is also increasingly recognized as the cornerstone of authentic integrated care health systems. Without strong and accessible primary care, integrated care cannot succeed. But primary care is under enormous pressure. According to Ontario College of Family Physicians, 1 in 5 Ontarians may be without a family doctor within the next 3 years. Many of those patients live right here in Toronto. In North Toronto, we're also seeing rapid population growth. increasing complexity in patient needs, and a shrinking family medicine workforce. Older physicians are retiring, and fewer medical students are choosing family medicine. It's a perfect storm. When patients don't have access to primary care, they fall through the cracks. We see more ER visits, delayed diagnosis, fragmented follow-up, and worse health outcomes. But it's not just about the patients. Primary care physicians themselves are burning out. Rising operational costs, growing administrative burden, and unmanageable workloads are pushing many to leave practice early. To address this, the North Toronto Ontario Health Team has developed a multi-pronged primary care strategy that is grounded in collaboration, innovation, and a deep commitment to listening to the needs of frontline providers. SCOPE is just one example of how we're turning that vision into reality, building practical solutions to real challenges, and making North Toronto a place where family physicians feel supported and where new providers are eager to work. SCOPE stands for Seamless Care Optimizing Patient Experience that connects primary care providers directly to hospital and community-based services like specialists, nurse navigators, and diagnostics through one single point of access. It helps reduce unnecessary referrals, avoid ED avoidance, and ensure timely care. But most importantly, it helps primary care providers feel supported. Primary care scope continue to grow, building on a foundation of proven success and strong uptick from primary care providers. Scope has become a valued and trusted resource for many PCPs across North Toronto, and now with the support of Sunnybrook Psychiatry, we're expanding Scope to meet one of the most pressing needs identified providers, youth mental health. This new pathway will provide easier access to youth mental health resources for PCPs, their patients, and families. So Scope Kit was developed in direct response to what we're hearing from both educators and primary care providers about the growing mental health needs of children and youth in our community. The Toronto District School Board did a survey in 2022, painted a really troubling picture about the struggles of students with struggling with self-managing anxiety and worry, and they're also reporting that they're less happy and more stressed compared to previous years. At the same time, our local primary care providers share mounting challenges they're facing in their practice. Difficulties assessing urgent consultations, long wait times for psychiatric services, and a noticeable rise in mental health concerns among younger children and preteens, especially post-COVID. Parents who are overwhelmed and also struggling to cope, and there's a lack of complex case management and support while waiting for the services. And increasingly, PCPs having to send youth to the emergency department because of other supports are not available. So there's definitely a system gap for timely, coordinated, and community-based mental health support for youth and families. So this is Scope. Right now, our North Toronto Scope is supporting over 250 PCPs, and we've launched Scope Kits in an iterative phase approach, and each of these waves are served as a PDSA cycle. And to share more about the development of Scope Kits and its impact, I'll now turn it over to Dr. Karen Wang.
Thanks, Kitty. So our goal for this project was to provide rapid and low barrier mental health support to PCPs, in particular for children ages 8 all the way up to 18. And we envisioned that there would be 4 main services that we're offering. So resource or system navigation that would be provided through a social worker or mental health navigator, psychiatric assessments provided by myself and 2 other child and adolescent psychiatrists, social work assessments, as well as MD to MD consultation. And we constructed our clinical team to also include not only the frontline clinicians, but also our North Toronto Ontario Health Team project managers and director. We also hired external consultants who are very familiar with the children's mental health landscape in order to really help us expedite servicing for these particular patients and families. We also met regularly to review clinical cases and identify areas where we need to increase the efficiency or effectiveness of our program, and so utilizing a sort of a healthcare for improvement model with the PDSA approach, we continue to refine our process. In terms of the types of services that people could experience, so as you can see here, there were indirect services, as I mentioned earlier, through resource navigation. There's also direct patient contact. And our hope was that we would be able to provide really timely psychiatric services for these families and patients in need. Given the fact that we were a fairly small team when we initially launched, we had to be very mindful of what scope of practice we could actually work within. And we identified that there were certain sort of psychiatric diagnoses that we felt most comfortable assessing and treating. We sent this information early out to the primary care providers so that they were fully aware of what kinds of patients would be suitable for this pathway. In terms of the types of services that we saw were requested the most, in fact, many PCPs were asking for psychiatric care. About 20% of them were also looking for social work consultation, 20% wanted both social work and psychiatric consultation, and then a much smaller percentage actually just wanted resources. So for the most part, what we really saw from the primary care physicians is that they wanted us to actually assess their patients and also provide ongoing follow-up care. This slide shows that even though there was a high number of requests for psychiatric consultations, once we received those referrals, what we noted was that, in fact, some of these cases did not require psychiatric assessments. They could actually be managed either through resource and system navigation or, for example, an MD to MD consultation. So only about 50% of the referrals that came in actually needed a child psychiatrist to see. We wanted to create a very efficient pathway, and so we tracked the time in which a referral came in and how quickly the patient could then actually see a psychiatrist or meet with a social worker. Our target was that at minimum 70% of referrals to psychiatry would be seen within 1 month. Now, this is a fairly extraordinary feat because in Ontario, the average wait time to see a child and adolescent psychiatrist ranges from 6 months to 9 months. And so we were able to get these kids in early and quickly, and we will show you later on that the satisfaction from the PCPs is really high because we were able to meet their needs. In terms of the types of consultation diagnoses that we saw, a lot of these cases pertain to anxiety, which is not surprising. As Kitty mentioned earlier, even in a very large survey that was done across Toronto, many children are reporting post-COVID higher rates of anxiety and self-reported depression. We also saw lots of concerns around attention and learning issues, some mood issues, and then also neurodevelopmental concerns such as autism or learning disabilities. In order to understand the types of cases that were being referred, we also created a marker of complexity to see whether or not these cases were actually fairly simple and straightforward, or in fact required multiple prong approaches, multiple levels of servicing. And what we found was that the vast majority of these cases were in the moderate to high complexity range. In other words, we think that this was an appropriate referral that was coming through from the primary care physicians, and that we had heard actually subsequently in our qualitative interviews with them that were it not for scope kids, they would have sent these patients to the emergency department. When we tracked also subsequently how many follow-up sessions post-consultation, what we found interesting was that in fact most times they did not require extensive follow-up. We are allowing for a more naturalistic approach to find out how many follow-up sessions are needed. What we have seen just anecdotally is that for many of the cases that require 3 to 5 follow-up sessions post-consultation, typically these children have either an attentional issue, a learning issue, or a neurodevelopmental concern. So this may highlight for us that there needs to be more work done in this area to support these kinds of children. What's interesting is that in implementing the use of patient-reported outcome measures, such as the GAD-7, the PHQ-9, and other depression and anxiety scores, we found that patients who went through the Scope Kids pathway and received 1 or 2 follow-up sessions, that their symptoms actually improved over time. We've also been collecting some equity data as well to understand where patients are situated within our sort of local geographic region. What is their sort of socioeconomic strata? Is there sort of a higher proportion of females versus males? And so this is ongoing work. We want to make sure that we address if there are any sort of signs of inequity, that we meet those needs appropriately as well. Interestingly, one of the comments that had come through our interviews with the PCPs was that they were using the Scope Kids pathway in order to avoid sending their patients to the emergency department. And so what we wanted to do was to track what was happening in our local emerge to see whether or not the number of referrals coming through for acute psychiatric consults were going down. Again, this is not causational data that we're presenting. It's more correlational findings where we have noticed that since the implementation of Scope Kids, there has been a significant drop. In the year prior, there were over 280 visits to the emergency department for kids under the age of 20. And in this in this previous year, it dropped to 184. Keeping in mind, it's not just about the numbers. We've also heard from the patients directly that having this urgent pathway has been really helpful, because in the past, when they've gone to the emergency department instead, oftentimes they would be sent home with limited resources, with no further psychoeducation. They actually don't even understand what their diagnosis means. Instead, what we're offering is a much more longitudinal follow-up process. We're also communicating directly with family doctors as well after the consultation to ensure that they understand the next steps. These are just some of the quotes from our primary care interviews, and we're continuing to build on these interviews as well. We will eventually be interviewing youth and family who have gone through this process. So in conclusion, Scope Kids is a comprehensive, accessible, and acceptable service that has demonstrated short wait times for resource navigation and or psychiatric consultation. We've been presenting this model to the provincial Scope network. We hope to secure further funding for sustainability and eventually partner with other hospitals in replicating this model in order to champion further spread and scale and continue to work towards increasing effective and efficient care for kids. Thank you.
So congratulations. It's really a nice example about how you can actually improve in a very specific area the connection with primary care. Now, are there any questions from the audience? No? Perhaps could you perhaps elaborate a little bit on the relationship between the work that you have to do in the team in the Scope and then the primary care itself, the primary care teams?
So we've worked closely with the primary care providers through the advisory group that Scope has already instituted. And through that process, we get ongoing feedback around what are some of the logistic barriers, if there are particular cases that are problematic. We also hear about that directly through Kitty, who's the program manager. And so there's an ongoing dialogue and relationship that we have with the PCPs. I've also frequently been on the phone talking to the PCPs directly as well when I'm providing sort of handover information around the case that has been seen. And so we understand that this is a longitudinal relationship. We hope to construct a model of care that's really helpful and meaningful to all the stakeholders involved.
Thanks a lot, and best wishes for moving forward, right? Okay, thank you. So we are going to change the topic now. We are going to focus on the role of pharmacist involvement in multidisciplinary collaboration, and that's a topic that will be presented by Ms. Blerta Hasha from Kosovo, right? So, Blerta, the floor is yours.
Thank you. Well, hello, everybody. It's a great pleasure and honor to be here with you at ICIC25, among so many inspiring professionals committed to advancing integrated care globally. Well, my name is, as I was presented, Blerta Hasha Mahmoutai. I'm a pharmacist engaged as a health expert in the Accessible Quality Healthcare Project, which is a project funded by Swiss government. I have over 20 years of experience in health sector, particularly in strengthening primary health care and chronic disease management. This presentation actually was developed together with the dedicated nurses and social workers from the municipality of Fush Kosovo and Lipjan, who are leading the implementation of integrated care in their communities. What I share with you today actually reflects their tireless work, their belief in integrated care system, people-centered care, and their commitment to the most vulnerable. We chose this presentation actually because of during our ongoing policy discussion and strategic developments, we have frequently encountered challenges caused by system fragmentation, poor collaboration, and notably the absence of pharmacists into the care teams. So today I'll walk you through Kosovo's journey with integrated care, what we've learned, and why pharmacist involvement and multidisciplinary collaboration are critical for creating an effective and equitable system. I'll give you some glance to Kosovo. Kosovo actually is the youngest country in southeastern Europe with a population of around 1.6 million, living in an area of around 11,000 square meters. The median age in Kosovo is approximately 34 years, making it the lowest among European and steadily improving life expectancy to 80 years, actually 77 for males and 82 for females. Kosovo's youth is very dynamic and ambitious. It is home country of globally recognized artists such as Rita Ora, Dua Lipa, sports like Majlinda Kelmendi, famous football players like Granit Xhaka, Xherdan Shaqiri, and a wide diaspora of scientists and healthcare professionals making contributions across the world. However, Kosovo faces serious public health challenges. Non-communicable diseases are particularly cardiovascular disease, diabetes, and cancer are the leading causes of mortality. The World Health Organization identifies Kosovo as having some of the weakest healthcare indicators in the region. Currently, Kosovo has 38 municipalities which function as the basic units of local self-government. Health system or provision of care is or operates at 3 levels. Decentralized primary health care, meaning that municipalities are responsible for planning, funding through grants, staffing, and delivering primary healthcare services. Services which are included or provided in primary healthcare are family medicine, maternal and child care, immunization, NCD prevention, and basic diagnostics. Secondary and tertiary care are centralized and managed by the Ministry of Health through Hospital and University Clinical Center of Kosovo. Despite significant reforms and donor-based projects, the system is burdened by underinvestment, by high out-of-pocket expenditures, especially for medicine and medical devices, workforce shortages, weak infrastructure, fragmented health and social services. Strategic health planning is further hampered by poor data system and non-standardized records. Over the past decades, the SDC, actually the Swiss government through the agency of SDC and the Swiss Tropical and Public Health Institute have made important contributions to the strengthening of the health sector in Kosovo. 2 flagship initiatives are the AQH project, or Accessible Quality Healthcare Project, now spanning phase 3, focused on primary healthcare reform through NCD management, health literacy, and people-centered services. Integrated health services, piloted is the other project of SDC, which is piloted in 2 major hospitals, Peja and Jakova, to improve integration between care levels. AQH actually has been instrumental in introducing an integrated care model in primary health care of Kosovo. The initiative aimed to enhance the quality of care for elderly patients, particularly those over 65 years old diagnosed with type 2 diabetes, by fostering collaboration between health and social sector through home visits, individualized care planning, and multidisciplinary team. It all started actually in one of the municipalities of Kosovo in 2017, in Fush Kosovo, where a multi-sectorial working group was established. This working group included representatives from health services, social services, local NGOs, the Patients' Rights Association, and the Association of the Retirees. An international expert supported this working group, ensuring that the model was both feasible and sustainable within local context. Wagner Chronic Care Model and WHO People-Centered Care Framework were foundation to AQH approach. The development process involved conducting a rapid review of international literature on integrated diabetes care for older adults, creating a municipality profile to assess the local context and feasibility, introducing a geriatric assessment tool to evaluate patients' health and social status, organizing workshops to train healthcare providers on integrated care principles, and the use of the geriatric tool. Key features were the notable innovation was the joint assessment conducted by nurses and social workers in patients' homes, leading to the development of individualized care plans by multidisciplinary team, comprising, as I told you, by family medicine doctors, nurses, and social workers. Additionally, physical activity sessions were introduced to help patients maintain functional status and manage their condition effectively. Following the pilot success, the integrated care models was disseminated to another municipality, this time in Lipian, where similar workshops and training sessions were held. The AQH project's third phase, running from January 2024 to 2027, aims to collaborate with municipalities in Kosovo, working closely with national institutions to ensure quality of primary healthcare services. If we check the whole pathway of the integrated care model, what was first introduced was the identification of the patients, which was the entry point to the integrated care and was done initially through public awareness campaigns. These initiatives involve posters, community outreach, media engagement to raise awareness among older adults and their families about the risk of diabetes and the availability of the integrated services. Then we had the invitation and informed consent, where when these individuals agreed to participate in this program voluntarily and based on the informed consent. Another novelty was the functionalization of the health resource centers, which emerged as effective coordination unit linking healthcare and social care together. Nurses took a lead role in case management, contributing to continuity of care. Then we have the second stage, which was the initial assessment. This stage involves comprehensive joint assessment to understand both health and social care. Home visits by multidisciplinary team, usually nurses and social workers, jointly visited the patient's home, and this enabled actually contextual understanding of the patient's living conditions, identification of barriers to care, or self-management. And then we have development of the individual care plans, jointly created by family doctor, nurses, and social workers. Outlines health goals, social support actions, referral needs, and follow-up schedule. But we don't have any pharmacists yet involved here. And then we have management based on care plans. Care delivery is structured around needs identified in the individual care plans and emphasize continuity and coordination. We have patient education during this section, which were tailored on diabetes type 2 complications and medication adherence, delivered through counseling, leaflets, and group sessions. Then we have self-management support, coaching at home, and in health centers, empowering patients to monitor their blood sugar, adhere to diets, and report complications. Then we have support for caregivers, training on how to assess with diabetes care and daily living, emotional and respite support. And then we have the lifestyle consulting, physical activity sessions, which were group exercises for elderly, nutritional guidance adapted to cultural habits and economic means. And we have clinical monitoring, scheduled follow-ups for HbA1c, blood pressure, weight, and medication adjustments, and coordination between health and social services for ongoing issues. These are actually the results measured in Fus Kosovo, one of the primary municipalities that conducted or implemented the primary health care. During the 2017 to 2024, around 292 geriatric assessments were done, and after the support of the SDC, they continue with another 67 geriatric assessment through the 2024 and 2025, and is continuing. As you can see also in the chart, we have the reassessments, and we have the individual care plans. So the continuity, even after the donor support, is ongoing. These are the figures for other municipalities that was implemented the integrated care. You can see also here that the sustainability goes further to donor support. We have the evaluation evidence. An independent evaluation conducted in 2013 by Dr. Zahorka confirmed the positive impact of integrated care component of the accessible quality healthcare project. The findings highlighted both success and areas of improvement in implementation of the integrated care model. We have a positive patient's impact, HRC effectiveness, professional impact, data, but still we have some barriers. We have data limitations, absence of integrated data systems, and repeated outcome measures hindered long-term evaluation of impact, and communication still relies heavily on patients. So we have actually weak digital interoperability, reliance on verbal communications, and limited linkage to secondary care. So we have here the missing link. A critical gap in the integrated care model is also the absence of pharmacists in the care team. In Kosovo, we have currently around 1,500 licensed pharmacists. Just fewer than 40 are in the public sector. As we know, consequences are poor medication adherence, under-coordinated polypharmacy, and adverse drug events. Scientific evidence shows that pharmacist involvement reduces actually the hospitalizations, improves safety adherence, and lightens GP workload. Among the growing body of evidence supporting multidisciplinary approach to chronic disease management is the work of one of our diaspora professors, Professor Hoti, that stands out in emphasizing the critical role of pharmacists in primary health care, specifically in the management of type 2 diabetes. His research underlines the pharmacist's contribution to improving therapeutic outcomes through medication management, patient education, and self-management. In conclusion, Kosovo's experience proves that integrated care works even in resources-constrained environment, but to scale up and sustain it, we must integrate pharmacists in integrated care teams, institutionalize integrated care in the NCD strategy, expand health resource centers so to have the outreach of patients, strengthening digital health infrastructure, and standardized outcome tracking. With those two municipalities, integrated care beyond donor support, the model has strong potential for national scale-up. And this is the quote that I found very convenient, that when local teams are empowered and services are person-centered, integrated care becomes not only possible, but also transformative. Thank you.
That was interesting also, and it's so clear that funding actually makes also the needed seed in order to start the movement for change. Any questions regarding this presentation? No? Well, perhaps a question with a short answer, if possible, is why pharmacists were not actually involved? Because actually I understood the figures, but there must be another reason behind that, right?
Yeah. Well, actually, we actually have some regulatory and structural changes. The existing healthcare do not clearly define the role of pharmacists into the health system. This lacks the formal recognition, limits the integration of pharmacists into critical care teams. And also we have also some constraints in regards to education and trainings. Pharmacy education is clearly focused on pharmaceutical science and on community pharmacy practice, so there's a need to enhance clinical training, to provide special education in the medication management, the adherence, the medication review, polypharmacy, and so on. And we have also the lack of awareness and advocacy. I mean, we have maybe to bring awareness to administrators and policymakers about the value of pharmacists into the healthcare system.
Thanks again. So we will move to our next presenter, the last one, who is Leandro Luis. And Leandro is going to tell us about the Nasher and Crescer Clinic. I'm not sure whether I'm pronouncing that correctly, but it's basically about enhancing access, quality, and continuity in maternal and child health care for underserved population. I have 15 minutes.
Thank you very much. Good afternoon to everyone. I hope you are enjoying Lisbon. I'm from Portugal, and so Nascer e Crescer, it's kind of born and grow in English. So why did we started this project? Well, I will try to explain briefly. I will not take too many time. Just for you to understand, we in Portugal have NHS, so a National Health Service. This National Health Service is mainly based, or trying to be mainly based on the primary care, has the first point of entering in the system. But we don't have enough resources at this time to get through all our patients. So here in Lisbon, we have several problems, one of which in my local health unit, which is something new here, because before we had the primary care and the hospital care separated, but one and a half year ago, we connected. So it was a political reform defined that we should be connected, working in the same management. So for 1.5 years, we are working as a local health unit. This local health unit, where I am responsible with my colleagues for the primary care department, I identified that we had almost 100,000 patients without family doctors. So this was a problem that I know several other countries have, which was we don't have the proper surveillance through all our patients. So we have to make choices. So if we want to get some response to our patients, to their major needs, we need to identify where do we have the most of the problems. So Nascer e Crescer was kind of an answer for this. We identified that we had a lot of pregnant women and a lot of children without the proper surveillance. So this was getting to us because we identified that our maternities were receiving the pregnant woman with complex diseases, with complex situations that were not properly studied. So this was getting to a derangement of our indicators, and the most important thing, to allow things that should not happen in terms of the evolution of the children, of the newborn, starting to be happen. And we have we in Portugal have some of the best indicators in terms of newborn mortality in the world. So for us, this is truly important. So what did we thought? Well, let's work to create a clinic, to create a solution to this segment of the population, to these pregnant women and little children that don't have any kind of response. We started to look at our geographical area, and we understood that most of the places that where we didn't have any kind of response of family doctor was where we had the most dangerous places, let's say like this, the places where most of them don't want to go work. So we thought, well, if we cannot get there and take them there, well, let's take the patients near us to a place where they feel secure and where we can get the proper care. So we created the Born and Grow clinic, or initiative share, focusing on trying to improve our response to this kind of patients. Our goals, as you may imagine, was to have a proper follow-up in the maternal health and child during the two main ages, let's say, so to the 0 until the 2 years old, because we didn't have resources for more. So, being continued, we started to look at our population, and instead that we had almost 741 pregnant women without surveillance that we needed to get some kind of response. We have a program in Portugal that we try to follow up, which defines that we should have at least 6 surveillance appointments with our doctors or nurses to guarantee that they have the proper follow-up. So we defined this and we started to think how could we do it and where could we do it. We defined as key indicators surveillance with a medical appointment the first trimester, or in the first, second, and third, with ultrasound performed, and the laboratory tests during these 3 trimesters too. For the children, we identified that, well, what are the main ages that we needed to focus on? We understood that the first 2 years of living is the main years in terms of identifying some kind of disturbances that we should have any kind of response. So we looked to be divided for each grade of years, and we tried to understand how many appointments we would need to do this. And we created scenarios. So we thought, we looked at our resources, at our people, and we thought, where can we go? Where can we reach? And we identified that for the beginning, the scenario 1 was the most attainable. So we started to focus on guarantee the surveillance of all our pregnant women without family doctor, and our children from the 0 to the 2 years old. For this, we calculated the needed consultations for a year and the needed family doctors we should have in our unit. And then we started. We started by defining our service portfolio, defining that we should give the maternal health consultations, the child health consultations until the 2 years old, and the family planning, the childbirth review from the mothers. And we started to integrate it with our special consultations in our hospitals, with gynecology, obstetrics, and pediatrics. And the first thing we thought was we need to connect them. We need to get our family doctors working with our gynecologists and with our pediatricians, because they don't speak a lot. They don't know each other. We just started as a local health unit 1 year ago, so let's make them speak. And we started with it. And with that, and this unit was the main focus for this, and now is allowing us to start them to speak with each other for the rest of our local health unit, because I'm speaking about the population of 100,000 people, but we have 440,000 patients in our local health unit, in our geographical area of influence. So we have a lot of patients and we have a lot of doctors, but we need to make them work together. So we start to do this with our clinic. In terms of results, we were expecting to have in the beginning, in the first year, 700 pregnant women, 1,500 to 2,000 children. Well, just in the first 6 months, we are almost there. And we have to adapt. So we are extending our approach, we are extending our resources, but for being honest, we are still only in a half of our territory. So we identified that one of the places where we didn't have any kind of response, they have a lot more patients needing of this support that we had the data to calculate it. So we started to understand that this is much bigger than we thought it would be. So we adapt. As you may see, 57% are children that are followed on our clinic, and 42% are a pregnant woman. In terms of our referrals, so I have an error there. In our referrals, we understood that in the beginning, we started to have a boom of referrals. After 3 to 4 months, finally it's kind of stabilizing, and finally we are being able to expand our structure. In terms of some of our results, as I was saying, we wanted to get to offer more and more response to our pregnant women, and we can see in our data that since the beginning was in final September, so it started for being honest, in October. We started to have an increase on the importance of our clinic in the total pregnant women that were being followed in our local health unit. We had also, in terms of ultrasounds, a major increase because we didn't have this connection between our maternity and our primary care before, and we get them together, and the Nasheed and Kashir clinic started to be one of the most referral units to this ultrasound, obstetric ultrasound that we needed to do. And this is some of the key indicators for us to understand if there's any problem with the children. In terms of the referrals, identifying earlier the problems allow us to get to the specialties earlier too. So with the start of Nasheed Kashir, Nasheed is starting to be one of the main units of referral of our local health unit to our maternity. So these patients that before got to the maternity without any kind of study before are now getting earlier to the maternity, are properly being followed, and in the end, this is turning to less complications in terms of the newborn children in our unit. In terms of child health, also our unit is increasing their consultations, and that is at this moment they have almost 25% of all the consultations we have in the local health units. And I'm almost finishing. To finish, we wanted to see how this impacts in our indicators for the patients without family doctor. So it's not only the patients in our clinic, but for all the patients we have being followed. And as you may see, in almost 4 months, we are improving all our indicators in terms of women's health programs, so in terms of surveillance, in terms of ultrasounds, but also in terms of child and youth health. We are increasing in all our indicators. So we are getting a better service to our population, which was one of the most important, which was the main purpose of this project. And I just wanted to share this and to show how sometimes we can tackle a problem, focusing on segments, until we have, in the future, the capability to give a family doctor to all our patients, which is our final purpose. So thank you. I hope you enjoyed it.
Thank Thank you, Leandro. That was very interesting. Any really burden question that should be kept very short? Yeah.
It's a long way up. Thank you for a wonderful presentation. Can you tell me the complications that you were seeing more of that led to the consultations? Was it the metabolic complications of pregnancy, like diabetes, hypertension?
Preeclampsia, yeah. Those were some of the cases that were not being properly identified. Before our unit, some of our territory was getting referral to another hospital. And this hospital had some problems with some news of, for example, death fetus. And this for us is not, it's something that we cannot accept. So we had to deal with it. But yeah, it was preeclampsias, it was metabolic questions that could have some kind of complex situations that got to the maternity where the pregnant woman were almost to deliver the child.
Thank you. Another question: have you implemented anything in the postpartum period for those people at risk for looking at prevention of chronic disease?
The project had that scenario, which was the third. I didn't explain because at this moment is not being applied in the clinic. Usually that kind of situations are followed for now in the maternity.
Thank you.
Welcome.
So thank you, Leandro. With this, we will close this session. May I just ask you to join me in a final applause to all the speakers? Thank you.
Okay.
We can introduce ourselves, can't we? And then, yeah, and then but when Aisha comes on to the panel session, I'll go and sit over there.
Okay.
So we need to get we need to get the microphones, don't we? So let's see.
Okay, welcome. Thank you. Thank you for coming.
No, you're welcome.
I'm going to tell them that you're here for a microphone.
Okay.
This is Karine. She's going to be one of the first speakers. She's the first speaker. Is there somebody who introduces us? Yes, there is. So we have Robin and Kerry. They'll come up and they'll say a few words, and then you and the other two speakers will be sitting here, and then one at a time come up to your presentation, sit down. And then there's a lady from Portugal. She's a former Minister for Health. She's going to respond to what you have all said from a Portuguese perspective, and then a conversation. Okay. Is that okay? Yeah. Good. So, bring you the microphone. And maybe do you want to check your slides? Yes. Yeah. Okay. Yeah. Hi, Alfonso. How are you? Nice to meet you. I'm sure we've met before. Yeah, definitely over the years. Good. So you need to get a microphone as well. Sure. And then, so everybody will be up here at the beginning. So I think actually it would be better. I don't want to say too loud. I think it would be better. We'll see if there's minutes to you go first. Because otherwise we have a Spanish, very thick Spanish accent, and then the Portuguese lady might be a lot to listen to. So Karine, we'll see you and then finish with you because it will be pretty good. Is that okay? I don't know. Is that all right? I think it just will be more, just for the people in the audience. Just fun like laughing. But you want
I mean, I think it depends on the content. That's what I was trying to tell them. Likely it's more around an international. So
just taking your speakers.
Yes. I was just explaining that I put Lucio in the middle.
We've got the order, haven't we? So
I have put Lucio in the middle. Is that okay, or should I move it back? What do you think?
Well, I think we want Alfonso before Peru.
Yeah, so I have.
I mean, I'm happy either way.
Yeah, because you're doing broad European work.
Well, the others are doing more very specific. Now, for example, she's going to talk about the new care ministry in Flanders.
Yeah,
That's what she's going to speak
so it
about.
makes sense to the European first. Then. No, I agree. No, let's move on forward.
I'm
it's not a disaster either.
I'm happy either way. I mean, I can really
yeah, so that's what we're going
so
for.
you are going to call me first? Or
no, so you're not first. You're second.
And we go there, or how?
Yeah, we sit up on the stage. Once your mic's up, we'll sit on the stage here, and you can come up here and present, and then come
so
back.
I can stand from here?
Yeah, you
yes,
could
exactly. You sit there, come here.
You can also walk around.
TED Talk style.
Sounds good. So they want us to mic it up.
Yeah, that's right.
Maria Del Rocio sends Madrigal.
I think so, yeah.
I'll just do my best.
So, Karina, are we okay to sit up here on the stage?
Yes.
That'd be great. Thank you.
Portugal is a very aging country. It's the foremost aging country in Europe. And so we have many, many frail patients in the emergency department, and it's a hostile environment for them. So we are trying to create less hostile and maybe do something for the literacy in health for the nursing homes and try to avoid that the elderly patients come to the emergency department. We started by doing a questionnaire to everyone who works in the emergency department to see what they thought we were doing well or not so well in the emergency department. And what we found out is that everyone thought we were not treating the elderly patients as we should. So everyone was motivated to this issue. What we are trying to do is that the nursing homes and the primary care units call us before they send someone to the emergency department and try to avoid the episode in the emergency department and adjust the situation outside the hospital. This is what we are trying to do. For now, we are not really reaching that point. This is our hope for the future, and explain, so have more literacy, not sending everyone just because it's a frail patient, not send everyone to the hospital. And I think this will be the biggest impact. The thing in the emergency department is that the professionals that work here are oriented to emergency treatments, and frailty patients need conservative treatment, needs social workup. They need much more than just emergency treatment. So it's quite culture changing here, and I think that's our biggest challenge, is to change the culture and to be more individualized. We always call the nursing home when the patient arrives. Even if we speak with the family, we always call the nursing home to see what happened and to get some clinical history. And then we call the nursing home again when we dismiss the patient, so they know what to expect and try to end with some myths about the elderly and the end-of-life care especially. The problem here in the nursing homes, we don't always have a nurse or a doctor. So at night sometimes the persons who are with the patients are not prepared to deal with some symptoms, so they always send the patients here. And the biggest purpose of this project is to teach everyone what they can do instead of sending a frail patient to the emergency department and end of life in the hospital. Because it's a very hostile environment.
Hello, everyone, and welcome to the afternoon plenary. My name is Carrie Koleski, and I'm a researcher in Canada. I'm co-chairing the session with Robin Miller. We have a treat for you today. We'll be talking about a key theme that has come up a number of times in this conference, and it's about inclusive healthcare and reducing inequality. And I have to say, I have been attending this conference for many, many years, and it's outstanding to see how the conversation and the work has truly evolved over the years. In the early days, when we talked about inequality, equity, we would focus on better access to care specifically. So we talk about, okay, we need to move beyond getting medical-oriented care and then bridging the gap to socially oriented care. And then we evolved further to talk about meaningful access. So it's not enough just to provide populations with access to health and social care. It has to be meaningful. We have to focus on health literacy, language, connection. And now we've evolved into a place where we're talking really about cultural humility, thinking about relationships, how we show up for others, and also how our own knowledge as individuals is truly limited. We need to recognize what we know, what we don't know, connect with others, learn with others, value the culture, the customs, the values of all populations, and take a pause together and really build relationships. It's community-centered and building collectively from community as opposed to building from a medical model outwards. And so kudos to IFIC for creating the space to have these conversations, to make these connections, and to really as a group see the evolution of the space of when we talk about inclusivity and inequality in care. And so I'm very pleased to introduce our panelists. They will be speaking about 10 to 12 minutes per presentation. We'll have a response followed by a panel discussion. So I'm very excited to introduce our first speaker, Dr. Maria Del Rocio Sanz Madrigal, former Minister for Health and Director of IFIC Latin America. Thank you.
Good afternoon. First of all, I want to say thank you for the people who invite me to be here and has the opportunity to share with you some of our knowledge, but also our feelings and our journeys from Latin America. Oops. I will talk a little bit for 4 topics, especially the key conceptual elements for integrated care, systemic vision for understanding the health system complexities, and the practical understanding of the complexity of the health services, and the experience of the Sirocco study in Latin America, and key points for the reduction of the health inequities. The conceptual elements that I want to bring today has to be what we are feeling about the comprehensive care, integrated care, when we are talking about the person-centered care, and we are here in the main conference with this topic, integrate person, family, and community-centered care, and the inclusive and sustainable health system. I don't want to go deeper on that, but I think it's very important to really mention that when we are talking about the comprehensive care, we are talking about the health beyond the biological factor. And for that, we are talking about how to approach but the systemic view. Also, when we are talking about the integrated care, we are looking or seeking for overcome the fragmentation of the healthcare services. And I think during the different conference, this is one of the coming processes and challenge that the different countries we have to confront. Of course, the person-centered care has to be to understand the people and the participants in the health system. It's not only the person or the people of the population or the citizenship, it's also us as a professional for health. And also, when we are talking about the integrated person, family, and community-centered care, we are talking about the family, the context, and the history, and what is the beliefs that the people has in their own countries and their own context, and the local community. And also is not only to look the people like they are receiving the services, they are part of the services, and when we are talking there are part of the services is because they have the possibility to know and to take decision for their own health, how to build their own health for the person, for the family, and also for the communities and for the whole country, and I hope for the world. And also, when we are talking about the inclusive, sustainable health system, we are talking about the empower the individuals, their community, and the collaborative to improve their health, as I mentioned before. In that sense, we are working in this complex figure that I try to explain a little bit in this presentation. But the idea to bring this figure is to try in one page put together all the different contexts and different concepts that they are around. We are talking about the health system, services, integrated care, person, and the care for the population. You can see at the out of the figure the macro determinants of health. We are talking here about the economical and environmental determinants, not only the social, economic, and environmental determinants, but also the historical and cultural change of the institutional model. That normally we don't approach that. We are talking about the history of the population, but not about the institutional model in each context. And also about the demographic and epidemiological change. This key dimension to transforming the health system for a systemic and adaptive approach. This is the idea to really put in the center the health equity and sustainability. When we find or try to look or reach the word for equity, most of the time is related with the access. Access is one of the areas, but is not sufficient to really talk about the equity. If we are talking about the health equity and sustainability, we must have a systemic approach, and our proposal is this. One of the parts of this systemic approach is how we can transform the leadership, and also how we can build the participatory governance. We are talking about the transformation leadership. We can review what is the population access, as I mentioned before. It's important, but it's not enough. It's one of these circles in this figure. And we can look the different contexts between and within the countries if there are a universalistic approach or they are segmented. Sometimes in the same countries, we have a different evaluation of that. The second is, what is the social participation? If there is active or there are passive. What is the quality and timeless of the care? Is high or is low? And also, what is the control of the resources? They are transparent or it's a big opacity. These four, we integrate in this transformational leadership. And we feel that really in the next years, we need to build in this kind of leadership in our health system and in our communities. And when we're talking about the leadership, we are not talking about the system leadership. We are talking about the population and the patient leadership, how they can build the capacities and the abilities to really participate, but also what is the space that they really have to do it. And for sure, that is related with the participatory governance that it has to be. What is the kind of system we have? There is a systemic system or it is a fragmented. We have integrality in the provision or is a basic package or minimum or poor help for poor that some people mention, that I against that, of course. or there is a comprehensive approach. What is the financing? The financing of the system is really progressive or is regressive? What is the amount of the out-of-pocket of the people? What is the really importance? We are looking for really saving the money of the population on health, or we are selling health. And the other thing is, what is the productivity of the health system? It is efficiency or optimizable. And others, you can add others values and other dimension of this evaluation. For sure, in this proposal, we feel the continuous research and training is needed through all of those possibilities of dimension, to look really for the health equity and sustainability, and what is the macro determinants of health for the population. You will find in blue two specific circles, the quality and timeless of care and the integrality of the provision. They are in blue because we feel sometimes we put a lot of effort in those. And also to recognize if we are working on this, on one of those, on all of those, this is the ideal for the future, but it's important to recognize where are our niche, when we are a provider, where are our niche. If we are a research, we are a policymaker. If we are a patient, where am I? Where are me? Where are you as a researcher, as a person who are working here? And with those in mind, I would like to mention that the practical understanding of the complexity of health services is that they will try to bring with the Sirocco in Latin America. With this experience, we try to look for the health system condition for scaling integrated care in context of Bolivia, Chile, Colombia, Costa Rica, and Mexico, and analyze the base of scaling integrated care in this context with this tool. Our specific objective is to analyze the condition of the organizational maturity in health services for progress toward integrated and person, family, and community-centered care in this context that I mentioned. Our specific objective is to analyze the condition of organizational maturity in health services for progress toward integrated and person, family, and community-centered care. To identify the divergences and the coincidences of the conditions of the organizational maturity in health services for progress towards integral care in a study context, and to propose strategies for moving towards to integrate care center and individuals, family, and communities. With my previous presentation, we are working with the different groups of research in those countries. And the beginning, each team provide and share what is the view they have on their own context and how they will approach the Sirocco. Some of them select to working in the communities, to the local, some of the regional, and some country national. And we try to put this approach really in place with this research. And in this process, the practical understanding of the complexity of the health services, I have here two quotes. What is one of the researchers say about the equity center and transformational leadership? Teams are constructed through collective thinking and the ability to make decisions together guides the pathway. This is the idea behind of that. and also the participatory management for the exercise of democratic power, equity-centered leadership integrates traditional leadership skills with contemporary equity, diversity, and inclusion skills, grouped into personal, interpersonal, organizational, community, and system domains. This is my presentation. Thank you again for inviting me.
Thank you so much, Dr. Maria. To see a wonderful maturity framework for advancing equity-informed integrated care is fantastic, and I encourage you to look at her publications as well, which outlines the framework in more detail. And so I'd like to introduce our next speaker, Alfonso Lara Montero, Chief Executive of the European Social Network. Welcome.
Good afternoon. Thank you very much for the organizers for the invitation, and thank you very much all of you for being here this afternoon. Taking into account we have a lovely afternoon in the beautiful city of Lisbon, the fact that you are here, that shows that you have an interest in what we are discussing, which is, I hope I can bring some of the social aspects of integrated care within the conversation. So just very briefly, I represent the European Social Network, which is the network for public authorities with responsibility for social services, with close to 200 member organizations across the whole of Europe, including authorities across all levels of government, research, applied research, inspection, and workforce regulation agencies, gathering millions of senior civil servants working to improve the lives of people in the community. Starting, I thought it was important to look at what we mean by integrating care, particularly when we are looking at integrating care across different sectors, not just in healthcare, but across sectors. And I think it is particularly important for us, our way and how we look at this is about working in partnership. It's about having multiple disciplines, multiple professionals from different sectors working together. Why? To improve the lives of people in the communities. This is the first reason as to why we would do it. To promote a more preventative approach. We saw it earlier on in the video that introduced this section. To try to address some of the key financial challenges that some of those in directorship positions in local authorities across the whole of Europe are having to address in relation to how public services, particularly public social services, are now being funded. And obviously, to look at what people want, which is to stay in their home and in their communities for as long as possible. Hopefully, we will be able, by doing this, to reduce some of the fragmentation and address some of the key gaps in service delivery. Yet, we are facing an important care conundrum. In this session, we said that social services play a pivotal role when it comes to integration of care. The truth is that, in the first place, many people cannot access, or takes a long time for them to access, the care and support that they need. I wonder, I don't know if anyone in the room would know how many days of waiting time someone who has been assessed as needing long-term care may take for them to access that care in Portugal. I don't know if anyone knows. But I can tell you that in the country I was born, Spain, the waiting time for those who have been assessed as actually having needs for long-term care has gone up from 328 days to 338 days. Of course, this is the general number. There are many differences within the regions, but this shows the difficulties to access in the first place the care and support that people need. And when they do, we are looking at a system that is not just fragmented, but actually increasingly fragmented. There are a number of questions we should ask ourselves. Who is responsible for care? Are we looking at the national, regional, local levels? Are we looking at public, non-public? Who is delivering those services? We have an increasing range of for-profit organizations delivering care across the whole of Europe as well. How is this care being financed? Is it financed by national budgets, transferred to the regional and local authorities? Is it financed by insurance companies? Is it co-financed and co-paid by people themselves? And how does this impact the person's life plan with all the different supports that they should access? How can we guarantee that the system is of quality, particularly when we look at quality frameworks? Those frameworks have been defined to address quality in residential care. But when we are looking at an increasing number of people staying in their own homes, how can we guarantee that the care that they receive is of quality? And how can we do this when we are having less and less people interested in working in the long-term care sector, which is one of the key sectors when we are looking at integrating care? Well, there's also, in addition to questions, some key data and some key answers. And the first one is that social care has always and continues to be the poor cousin of healthcare. And this is a real issue because by 2070, the number of people requiring long-term care in Europe in the population over 50 is foreseen to be 21% higher than today. And who's going to be taking care of them? Well, the long-term care workforce right now is 90-10 female-male split. And the average age in the workforce is rising. And right now it's in the range of 45 to 55. In a situation in which we need more and more innovation because what we are seeing is that there is an increase in numbers of people with disability who are growing older and living longer, which is amazing, but also we are seeing the development of new dementias as well and how we are going to be able to address them, particularly from a social point of view. And let's not forget the millions of unpaid carers without whom the system wouldn't be able to sustain itself. The estimate is around 12 million in the EU. So when we look at integrated care, of course, this is understood in different ways across the whole of Europe. We might be looking at limited cooperation between different agencies working on specific projects to coordinate together, for example, moving into certain processes like shared assessments, shared care plans, shared information across different registers or within one integrated registers, which would move more towards the third level of integrated processes, where there are certain merged organizational procedures and also decision-making, particularly around new professional roles like care navigators or coordinators that are helping people who access care navigate the system or refer them to the right type of service. And then we've got integrated organizations. In some countries, there has been a long history of this, like in Northern Ireland or over the past 8 years in Scotland. And now some Spanish regions are also moving to the idea of a single integrated care agency. But that's by no means the case in most European countries. How do we look at integrated care across Europe? Let's have a look at a couple of examples before I conclude with some thoughts. This is an example of integrated care center in the UK. This is about collocating different services and having multiple professionals coming from different sectors, particularly from health and social care, working together in one place under the slogan of Home First principles. It's about bringing specialist care provision as close as possible to people's homes so that we can reduce duplication, we can integrate care records, reduce emergency admissions to hospital, and particularly promote joint understanding and share learning between those professionals involved based on the different roles and responsibilities. The idea is that we focus on early help, on prevention, and proactive interventions. Second example is from Riga in Latvia, and is expanded home care. Basically, it's an intermediate approach between traditional home care and traditional residential care. The idea is that social workers from the municipality visit regularly the person and put together a plan with them which combines home care with daycare center, transport to the daycare center, and a range of welfare technologies. It's interesting that, unlike usual home care, there is no restriction in the number of hours of home care that these persons can have. And the assessment of the needs of the person is done in their own homes. So it includes the actual environment where they spend most of their time. A range of welfare technologies are offered, such as automatic lights, smart monitoring, remotely, obviously, as well as a number of sensors to look at water consumption, to look at movements, and also to assess fall prevention. And it's a new and different way of working for the municipality, which is usually working either providing residential care or home care. Now, you have a range of providers across different sectors coming together, which have to be coordinated somehow by the municipality and also through an integrated care plan with the persons themselves. And the final one is the joint up mental health teams in Denmark. And this is for one of the most vulnerable population groups in our societies, those who have a diagnosis of psychiatric disease and drug abuse problems. A joined-up team which brings together professionals from health, social services, but also from employment services, work together to develop a joint action plan with the person and are coordinated by a case manager. The idea is to have a secure contact point and a set of measures that everybody is aware of so that there can be a more stable life for the person to prevent hospitalizations and relapse, and to foster a common understanding and ownership across all of those professionals involved in the care and support of that person. So what are some of the barriers and facilitators to integration? Well, you probably know them all. Financial and human resources are key to implementing integrating care, but let's not forget technology is not going to solve the issue. Also, see many programs using technology to keep people in their own homes thinking that this is going to address the workforce issue. But indeed, the role of technology in integrated care records, in data management, as we saw during the COVID-19 crisis, and welfare technology for independent living certainly can have a big difference. We need to focus on human resources, not only in frontline workers, but also in effective managers and leaders. And particularly, I would like to emphasize that, and I see this also in the sector I work in social services, there is just a lack of strong collaborative leaders who really believe in collaborative leadership across sectors. And this is probably also because many of them are so engulfed in their day-to-day and so busy trying to actually solve some of the key issues around financing and management that makes it actually very difficult to move beyond that. There has to be clarity around the distinct roles and responsibilities and what each individual and what each professional brings onto the table, because this is actually clearly not understood across different sectors. And it is about engagement, but also commitment. And this commitment needs to come from all the stakeholders involved, including people with whom care should be developed. Care is not developed for them, is developed with them. And unfortunately, this is not something that happens across the board. We do have examples of good practice here and there, but it's not structural. So bringing it all together, some of the key enablers. First of all, I would say that we need to address the structural challenges in social care, particularly related to chronic underfunding. We need to have systems on an equal footing if we really want to promote effective coordination with a shared vision and goals. For this, we have to have the right governance framework, which secures effective management and leadership, that makes sure that all professionals are on board, supported by the human, finance, and technology resources that we need, and can foster the trusted relationships that can guarantee effective, integrated care. And I'd like to thank you very much for your attention.
Thank you so much, Alfonso, for the really great practical examples and really outlining the structural and the relational pieces that need to be in place to really pull together health and social care and how it's actually happening in different parts of the world. So thank you for that. Now I'm going to welcome Corrine Moykens to the stage, Secretary General of Care Department for the Government of Flanders. So welcome, Corrine.
A very good afternoon to all of you, ladies and gentlemen. And dear host, thank you for giving me the opportunity to speak on this very important topic. And dear colleagues, let me start by reflecting on the past before I come to what is at heart here, giving a fair chance to all. Many decades ago, the term and concept of integrated care was introduced. Thanks to the international community and its organizations like ICIC, many of our countries are working on internal system reforms in health and social care. Often in the past, the organization of health and social care sector has been much fragmented. This, of course, to the detriment of people, and people with care need particularly. Flanders is no exception. For those who do not know where we are in Europe, the Flanders region is part of Belgium. We live in a country with a high healthcare quality, but of course, there is always room for improvement. And as anywhere in the world, the Flemish government felt the need to improve care for persons with a high care need. We started our journey in 2010, improving and promoting collaboration amongst health and social care actors, using the policy resources that we have. It is a challenging, but also a rewarding transition that was endorsed in 2017 with the primary care reform. And since then, it has further evolved into initiatives that concern people in their living environment, such as a local social policy and the project we call Caring Neighborhoods. I come back to you with some more examples from both the primary care reform and the Caring Neighborhoods. The vision of Flanders Department of Care is that not only the health and care delivery system should be reformed, we also believe that the policy level needs to take up responsibility and has to show that they work in an integrated way. We need to lead by example, walk our talk, practice what we preach, and turn our words into deeds. In June 2023, this resulted into the creation of a newly formed Department of Care, which I have the honor of leading. And this Department of Care is a merger between the former Agency of Care and Health and the former Department of Wellbeing, Public Health and Family. I should also stress that since the reform, the term care now encompasses both the health and social care sectors. Our strategic framework builds on 14 key objectives that shape how we want to build a healthy and caring society in Flanders. And these goals are grouped under 4 core ambitions. First, we want to empower people to stay as healthy and resilient as possible, physically and mentally. Second, we promote a caring society in which everyone is included and supported, regardless of age, income, or background. And third, we aim to provide high quality, accessible, and affordable care by supporting care professionals and strengthening collaboration across sectors. And finally, our department strives to be a caring and data-driven public administration, prepared for crisis and accountable to our citizens and partners. And these ambitions, they serve as a compass in all our efforts to bring more coherence, integration, and person-centeredness into policy and practice. There have been, and there still are, many challenges to face and obstacles to overcome, especially in a politically and policy complex country as Belgium. A factor that complicates our policy making is the financial distribution from the federal, the national level to the regions. Also the way different powers are split between the federal and regional level causes difficulties, especially when it comes to healthcare. But however complicated, we have to work with the resources we have, and always in service of our citizens. Having said this, we, as a regional government, we can create a reform, we can provide the best instruments, we can have the best intentions, but the reform still needs to be implemented. And to better understand this implementation process, we need to take a closer look at our population. We do not want an integrated care system that only serves those who can navigate their way to the right services, government agencies, and assistance. Flanders has always adhered to and will continue to follow the principles of proportional universalism. This approach, as you know, ensures that while everyone should have access to essential services, those with greater needs receive more support. The implementation of the primary care reform starting in 2017 demonstrates this concern. We tasked to 60 primary care zones, each serving up to about 100,000 people, with identifying and addressing the needs of the population. These zones are overseen by a primary care board, which is composed of a multidisciplinary team of relevant health and care professionals, including representatives from anti-poverty organizations, low-threshold well-being organizations, organizations for persons with a disability, and local authorities. These initiatives all reflect the desire to pilot those who risk to be left behind, as is mentioned by WHO Europe. It's a difficult and a challenging part of our regional policy making. The more vulnerable population is very diverse, and the one-fits-all solution does not apply to them. And that is why I am particularly pleased with this session to emphasize that we cannot forget this population in all our efforts to create solid structures. And let me give you some examples. The primary care boards kicked off their work in 2020, a year we all will remember, full COVID period. The preparation for organizing the care boards had started, but soon we realized that we needed to accelerate and get them in an operating modus to support our vaccination campaign. 5 years, of which the initial period was atypical due to COVID. 5 years is relatively short to show concrete results, so I will mostly illustrate their methods of working there. Decision-making within the care boards is not only carried out by health and well-being actors and local authorities. Also, citizens have their crucial voice in the care board. They are central to the objectives that care boards aim to achieve. Many, if not all, care boards are very focused on this. For example, they organize sounding board groups, where considerable effort is made to reach a large diversity of citizens. Many care boards also focus on detecting certain signals, capturing and bundling needs and problems, and they deliver those signal bundles to local authorities and other actors in their region. The boards are supported by the Flemish Institute for Primary Care, VIVEL, and VIVEL is tasked to facilitate exchange of good initiatives. In case the problems require a broader regional policy, they need to scale up to the Department of Care. I'd like to illustrate this with a few examples of specific local initiatives. The Care Board of Southeast Limburg is dedicated to establishing a coordinated approach to tackling substance abuse. The Care Board brings municipalities together to develop a harmonized approach, and links to prevention campaigns are established, and experts from outpatient centers for mental health and other medical actors are involved to explore how quickly accessible and low-threshold help can be provided. Connections to well-being actors, such as the Centers for General Well-being, are made to explore outreach possibilities and referral to existing services. Special attention is given to young people, involving schools and the Student Guidance Center, and also to vulnerable families. The Care Board Brussels from Brussels aims to improve access to care, specifically for people who do not find their way to primary care. For example, persons without a fixed home address or undocumented persons. On the one hand, Brussels facilitates outreach programs and connects the various actors to implement them. On the other hand, Brussels focuses on informing and training healthcare and well-being professionals on very low-level key questions. What should you practically do in terms of billing if an undocumented person comes to your practice? How do you talk about sensitive topics? To whom can you refer them? How do you refer? With a standard note? Or is it better to make the call yourself? The Care Board from Leuven actively addresses digital barriers. In collaboration with the University of Leuven, a DG van drives around the primary care zone, particularly in more vulnerable neighborhoods, to ask people about the digital challenges they face. This can be done through interviews, but there is also an anonymous option by filling in cards to provide input. Signals are collected and discussed within the Care Board, such as, are there issues within our sphere of influence that we can address ourselves? Which other institutions should we contact? The second example from my department I would like to highlight is the Caring Neighborhoods Initiative, and that started in 2022. The project groups 129 neighborhoods in Flanders and Brussels. It fits in the COVID aftermath and the Flanders Major Recovery Plan called the Flemish Resilience. The plan is intended to strengthen the Flemish prosperity and well-being and focuses on community building. In a caring neighborhood, people live comfortably in their homes or familiar surroundings. It is a neighborhood where young and old know and help each other. In a caring neighborhood, quality of life is central, and facilities and services are accessible to everyone, regardless of their support needs. The initial project ran until February 2025, and my department is now paving the way to structurally embed the caring neighborhoods in the whole Flemish local social policy development and in the integrated care programs. I will give you two illustrations of caring neighborhood initiatives. Zandvoorde is a small village in the Flemish countryside in the municipality of Zonnebeke. It has no formal caregivers, no basic facilities. Since it is far from Zonnebeke, it has no public transport. The municipality of Zonnebeke started from the needs and opportunities to support this village. And the village created a community house as a meeting place, including a shop with products of local farmers. The shop is kept by people with disabilities. And the result is that many elderly people now come out of their houses to meet for a cup of coffee. The municipality of Sonnebeke itself uses the shop for outreach work. Under the name Coffee and Forms, people can come by with any question. In this way, the municipality wants to combat underprotection. A second example is one from an urban context, namely a caring neighborhood in Ostend. And Ostend is a city by the sea. And this neighborhood, called the West Quarter, has a very diverse and a very young population. 25% of residents are under 18. There are 5 places where people already come together in the neighborhood: a social grocery, 2 youth organizations, community health center, a home for the elderly, and an organization specialized in diversity. And thanks to the caring neighborhood, these groups of people, as well as these organizations, they meet and they work together. Something they did not do previously. And this example makes clear that connection is the key word for caring neighborhoods. In conclusion, small initiatives are extremely important to achieve great results. But a strong governance and legal framework is essential to help bottom-up initiatives to excel. A higher level, such as the government of Flanders, can help to increase the impact by spreading good practices over a wider range, and finally, embed them in recurrent policies. Ladies and gentlemen, we are all humans. Let us, by any way, stay humane. Thank you very much.
Thank you very much, Karine, for really highlighting the importance of both the structural factors and determinants of integrated care, but the power of communities and the focus on social determinants of health. So now we're going to have a response from Maria de Bellem-Rosera, who's going to reflect on all of the presentations that you just heard. She'll spend about 5 minutes reflecting, and then Robin Miller will engage the panel in a panel discussion.
Because I knew it was going to come into an end of the first stage. So that was really good to hear. It's going to carry on.
Hello, everybody. Special greetings from Lisbon and Portugal. Greetings for you also. I didn't bring a presentation because I have only a few minutes to tell you something about my experience as former Minister of Health in the late 90s. And of course, I always worked around in health services, social security services, rehabilitation, and so on. And I knew that the main problem in the health system in Portugal was the fact of not having integrated care. When someone needs the support of healthcare, they don't have the ability of looking for service. I think that service shall look for people and take care of people. So I decided to put in practice some pilot experiences, different one from the other, in order to be able to make an evaluation of what was better, what had the best results. And so I decided to create special teams in primary health care with a different form of payment in order to decide the gains according to the outcomes, the health outcomes of people. I decided to avoid the very heavy bureaucracy in Portugal concerning hospitals, and I created a special autonomy for hospitals working already with primary health care of their zone of influence, and I created local healthcare unit with a board for integrating the primary health care and hospital care. And this last one proved so well that 2 years ago, the government decided to organize all the hospitals and healthcare centers in local healthcare units. I don't know if it is a good idea, because I think that we need the adequate size of these kind of institutions, and when we are talking about university hospitals and things like that, this kind of organization, it's much more difficult to be good. Anyway, we are evaluating this, and perhaps afterwards we'll change. But this local healthcare unit, she was created in the north of Portugal, and it had an evolution to local health system and not unit all. And so what this kind of organization gave us, it was the satisfaction of professionals and satisfaction of people served by them. Because in the first phase, we had only the integration of services, but now they have been developing during these 20-25 years, always a very, very inspired energy to create specific solutions for the problems of the people they served. And one of them is precisely something that was already talked this afternoon here. It's how people uses emergency services when they are known in the hospitals because they have several chronic complex diseases. And they create a solution. This kind of people doesn't go for emergency rooms. They go directly to the service that are the most adequate to treat their specific condition. Of course, today, they work very closely with the municipality, with all the NGOs in the field, with all the enterprises in the field, with the schools, with all the public services that are needed in order to treat people as having a specific identity and not being a group in what one size fits all, because we know that one size doesn't fit all in health and in healthcare. Anyway, just to tell you that first I defined from bottom up a strategic plan, the goals to attain in health gains, of course, and then we defined all the organization with integrated care as being the most interesting answer to give to people with a lot of difficulties in their life. And we decided also to apply a concept that that Corinne told us about, proportionate universalism, a concept created by Sir Michael Marmot, always a very, very important person when we talk about health determinants. And we work according to this principle because we know that ethical principles in medicine put equity in the top. And so I think that in these times we live, with the longevity and the elderly people pressing healthcare services, we have to be very imaginative, and I would like to underline the need of plasticity of the solutions according to the population they serve, and the importance of teamwork, because to fight against disease is a battle that requires a military organization and the definition of the function of each one, and the work together as a team, and a team that respects each other. I'd like to underline that nowadays, of course, we need to prioritize health promotion and disease prevention. We have to make a shift from hospital-centered care to health-centered care, integrated, of course, but first, the primary health care is the base, but we need to develop, according to the laws and the European laws of European health data space, all the digital transformation in order to put and to make things happen with informed and consent data, health data, but also with social data that can underline us the determinants of people in order to treat them in a personalized way. I would like to underline also a very interesting report published by OECD with a question, does healthcare deliver? And they are trying to adapt in order to promote the models of value-based healthcare. The program is called PARS, and they say, and they underline the importance of the 3 T's for people. Time, shorter waiting times, tailored care, no one-size-fits-all, for people, mainly for people with complex chronic diseases, trouble-free and safe care, no harming healthcare. So I think that from concept we have to go to reality, and reality in Portugal says it is good. Thank you very much for your attention.
So, can I get, oh great. Well, thank you to all our speakers for such a rich and insightful set of presentations. And we've got about 20 minutes now for a panel discussion. And it is a discussion, so do feel free to disagree, to have a different point of view. We'll make sure there's not too strong arguments on the stage, but it's good to hear different perspectives. So, we're going to start off with this one. Social services arguably have much more experience and insights into tackling inequalities than health services. But healthcare often dominates integrated care initiatives. If social services were in charge, what would be different? I'm going to put that to Alfonso to start.
Thank you, Robin. I thought that when you referred to the term social services, I thought that question might be for me, but so I thought I was anticipating. Well, the thing here is that, of course, I need to be careful because I'm here an outsider, I guess, so I'm going to be mindful in what I say. But the truth of the matter is that if, as a policymaker who's been working in the area of social services now for like 17 years, I was responsible for this. The first thing I would do is to get an assessment done in relation to, when it comes particularly to integrated long-term care, what is being done by healthcare and what is being done by social care, because right now there is actually just lack of understanding as to how this is happening. So I would do that in the first place. And I would do an objective assessment of actually how would it be better done. Is it better done in health, or is it better done in social care. And after that, what I would try to do is to make sure that there is some sort of transfer of resources to the place where it is better done. Because what we know, I've been also visiting services for many years, and I was astonished visiting, for example, and there is institutional care still in many countries, but visiting institutions of 500, 600 people in a number of European countries, and seeing people there who didn't need to be there at all because they could be at home with the right type of support, I was astonished to see situations like this. So indeed, what we need is to have in place proper objective assessment of where things are done better. And after that, what we need to do is to foster a proper understanding across all of those involved to make sure that there is a clear shared understanding with a shared vision and with shared goals. That, I would say, would be for me some of the key things to look at. And particularly, and with this I conclude, putting in place a non-stigmatizing way to deal and to work with people themselves. I hear the word patients all over. We are people, we are patients. Sometime I went to the doctor 2 weeks ago and she called me a patient. I said, no, you don't call me a patient. I have a name, I'm speaking with you. So we can use a non-stigmatizing language. There is no need to do that because I may be a patient 2 weeks ago, but I'm not a patient now, am I? Hence, I think those type of things are very, very important, and we need to address this, as I said, based on a common assessment, common shared understanding that leads us to a shared vision and goals.
Thank you, Alfonso. And Corinne, I'll put the same question to you. And do you agree that healthcare often dominates, and if social services were in charge, it would change?
More or less, but I think it's not the issue. Is healthcare more important or better, or is social care more important or better? We need them both. And it's especially the integration of both that makes it better. If we as a society will want to deal with all the challenges we are facing, we need to start from a person-centered and a goal-oriented integrated care. And if we do so, let's look at that person and let's see what quality of life and which life goals does that person still needs to realize, wants to realize. And when we start from there, then you have the cure and the care goals to achieve those life goals. And if we do so, we all know that we need social care and health care. And I think that is exactly what I was trying to explain with our caring neighborhoods. Because there, we start from that situation. We have developed tools. It's a tool called Alivia. You hear the word life in it, Alivia. We are very proud about it because we also had already 3 awards in Belgium. But it's a tool that helps people. You start really from the people and from the life goals the people have. And then you say, okay, and to achieve now those goals, what do we need to provide from care and from cure? And bringing that together, everybody has goals at every moment in their lives. Even if you are palliative, at that moment, you still want to go out to make a trip or to make a walk at the beach. I live at the coast. You understand why I say that. And when you bring all that together, that's the huge importance of social care and healthcare in an integrated way.
Fantastic, thank you. So we've got time for one more question. Community organisations can be key to engaging with marginalised people and achieving a more equitable health and care system. But traditionally, integrated care has perhaps focused more on health and care professionals. What can be done to bring community organisations to the table as equal partners and leaders of care? Maria Del Rocchio, I wonder if you'd like to respond to that one.
Yes, thank you. I would like to say something for the first question, because when I was a Minister of Health in Costa Rica, also I was a coordinator for the social cabinet. And I learned in that moment the importance that you are mentioning. Exactly. The people need both, and the both has to work well and efficiency. But the most important is really to put the people at the center. What is the needs? And then came the organization to bring the better. Social or health services. In the last years, I saw some trends to talk about this dichotomy. The idea sometimes are coming from the budget, from the social services to go to the health services, or coming from the health services to go to the social services, and the people who lost. And the thinking on that. This is only my first idea. And the second, how to bring together. I think we as health workers, we are persons also. We carry out our own history and our ideology and our values and our history and heritage. We are not only a machine. And when we are talking about how to build together, I think the most important is to really, we as health workers, be parts of the society, not only be parts of the health services. To really have engaged with our own community or our mapping of the different resources we have in the community. If we can put this together, we can build, the next step, working as a person who view the person, are working with the person, but also are with the person.
Fantastic. Thank you very much. We're very pressed for time. So, Maria de Belém, would you mind responding to the question about how do we give community organizations equal power and leadership opportunity?
Well, leadership is one thing. Who runs the organization is another one. So I think that during decades we discussed power among professionals. That discussion doesn't interest me. The only discussion I want to have is the mission of the organization and to find the adequate team for that organization to serve the mission they have. And I think that acting like that, I can have different teams to lead the organization because it depends on the locality of where the services are delivered and the kind of work I have to make in that region or in that town or village or what else. In Portugal, we have our own culture, and our own culture was built, of course, with our history. And we have some interesting institutions that are called mercies, misericordias, from the 15th century, and they had as mission to deliver the 7 corporate and spiritual needs of people, to satisfy it. So this is the integration of care.
Okay.
This is the philosophy, because, of course, we need to treat someone in illness, but we have to feed someone if they are hungry. So we have always things that need ones from the others to achieve a good result. So I think that important is not to discuss who is going to be the boss, who is more important. I think that in an organization of healthcare in Portugal, we always had social workers. Of course, they integrate the teams, but there is an orientation mainly in specialized care from doctors because they know what is the most complex problem someone is suffering when they are looking for health care.
Thank you, Maria. Unfortunately, time is against us, so we'll have to pull things to an end there. But please put your hands together for our panels and for Kerry, my co-chair. And I think there's a lot more debates to be had from this topic, but we look forward to carrying that on in the coffee break that proceeds now. So thank you very much for your time, and have a good evening, whatever you do. Thank you. Thank you very much.
Oh, wow, that's really good. Good afternoon, everyone. Hi, thank you so much for joining us this afternoon on the end of day 2 and the last session of today. Really appreciate you guys coming and joining us for this really important discussion on people-centered care. My name is Samantha Laxton. I'm a program manager with Health Standards Organization and Accreditation Canada, and I am joined here today by a panel, a phenomenal panel who are experiential researchers that really dive deep into our shared understanding and how we improve people-centered care in our country, but also around the world. We have our panel joining both virtually as well as in person. So Carrie Kaluski and Ross Baker joining here. I'll invite them to introduce themselves when you hear their presentations today. And then joining virtually, we have Vincent Dumais, who's a patient partner and board member at Health Standards Organization and Accreditation Canada. And hello to those folks who are live streaming in and joining us virtually. Welcome. So when we got together for this discussion, we knew that we wanted to have a really deep and meaningful discussion around what is, not just what is people-centered care, but what does that actually look like today? What do we need in order to advance it? And what does that look like in the context of advancing integrated care? And so really the intention of today's session is to start answering that question on how do we move people-centered care and the reality of people-centered care from policy into practice, and how do we understand where we're at on that journey and what we need to actually realize this vision of integrated care and people-centered care. So we've started to see this global movement around the world to systems that are identifying people-centered care as a priority. We're starting to see it in various different policy documents and standards development. And so today we're really going to unpack where our strengths around the world, where is it working well, what's the latest evidence related to people-centered care, but where can we improve and what are the resources that we need to improve. But before we start that, we kind of want to get a sense of who's in the room and who's joining us today. So it will be an interactive session, so if you could grab your phones and scan that QR code, and we'd like to know where you're joining from today. If you're online joining, if you actually type in slido.com with the number 2922156, you can also participate in the interactive Slido throughout today's session as well. So I'll give you a few moments to start typing. Canada, so I don't think I shared, I live in Canada, I'm from Ottawa, Ontario, Singapore, New Zealand, Switzerland, Norway, Belgium. Quite a diverse group, thank you so much. We'll give maybe one more minute to see where folks are joining from. Taiwan, welcome. Australia, fantastic. There's another question we'd like to know, maybe diving a little bit deeper, not just where you're from, but really what is the primary perspective that you're bringing today? So what is your role in integrated care? And I think we are recognizing more and more that often in the conversations of integrated care, we have many various different perspectives, but in the context of people-centered care and integrated care, what might be your primary perspective that you're bringing? We're seeing researcher, family physician, educator, community nurse, case manager. I'm seeing Canada, which we'll include on the first slide. Leadership and governance, evaluator. Oh, wow, many different perspectives. System planner, patient, caregiver, partner, family physician, emergency physicians. So again, quite a diverse group. That's fantastic. Thank you so much for submitting that. So before we jump into hearing from the experts related to people-centered care, we actually wanted to hear from you and start with a question and really hear where you're at and related to people-centered care. So we're going to ask that you take 2 to 3 minutes with your neighbor or on your own, ruminate on this question related to partnerships. So what would or what does successful partnership look like or mean like to you? So think about that. We'll give you 2 to 3 minutes to discuss that with your fellow neighbor. And then if you could summarize that discussion with 1 or 2 words that reflect kind of what does partnership mean to you. Alrighty, we're seeing some words come up. So we're seeing collaboration, sustainable, productive, giving and taking. That's that idea of reciprocal relationships, which we heard Jodine Goldhar speak about. Shared mental models, giving and taking, equitable, designing together. Like we heard this morning around caring together, which was a fantastic presentation as well. Accessibility to care. I had this great conversation with someone around accessibility, that sometimes we equate accessibility to availability, and there's more to accessibility beyond availability. So I think that's a really interesting point. Some really fantastic answers. Thank you so much for participating in that. I think when we think about what does or what could successful partnership look like, that's very much a foresight or future thinking position of what could it look like. And so really to understand how might we get there, we have to understand what is the starting point. And I think that starting point really does matter. And so in that spirit, the final question for this opening session for you, we'd really like to understand in your current environment, in your current context, if you're part of an organization and that includes being a partner, patient partner within an organization, how would you rate your organization's level of partnership with people and communities? And we have the scale from 1 being siloed and 5 being integrated. Okay, we're seeing an average score of 3 right now. Okay, so 3, actually a good percentage of 4 and is moving up, actually. That's fantastic to see. We are still seeing some higher numbers in the level 1, and that's just increased as I said that. So that's really interesting, and I think with the opportunity of maybe meeting after this conference, we'd love to really unpack why did you say 1 or why did you say 3, and there's even some in the 5, which is fantastic. So I think unpacking these numbers would be really interesting. But I think that activity, and we did it very simply here around what could successful partnership look like and where do we want to go and where are we starting from, really helps us understand what could that roadmap or journey look like to get to where we want to go and what resources might we need to help support us to do that. So on that note, I'm going to take a couple minutes to introduce who Health Standards Organization and Accreditation Canada are, and really with the spirit of in the conversation of people-centered care, we develop standards, and standards can be recognized as a form of policy, and really the conversation today is how do we move from policy into practice. So Health Standards Organization and Accreditation Canada are 2 organizations, and we're united by our shared vision around safer care and a healthier world. And we advance towards or progress towards that vision by enabling and empowering people around the world to continuously improve the quality of care. The 2 organizations, Health Standards Organizations and Accreditation Canada, kind of have this beautiful relationship where Health Standards Organization leads and co-designs quality standards across the health ecosystem, from primary health care to acute care services and also within community care. And then those standards get implemented through the accreditation program and evaluated at health and social service organizations within Canada and around the world. And so currently, when we say co-design standards, we work with over 1,000 subject matter experts, which include people with lived experience, providers, policymakers, and researchers. And we deliver these standards and evaluate these standards in over 40 countries in over 14,000 locations using our assessment programs. So in summary, we do have 4 key levers of change. I've already talked about the standards that we develop in the assessment programs in which we deliver those standards, but we also do integrate in capability building to support that learning opportunity. And then we also really invest in leadership and partnership opportunities to really enhance our reach and spread and impact. And I think a good example of that is the partnership that we have with ICIC and being able to support the advancement of integrated care and understand our role in being a partner within that quality improvement journey. So again, with the theme of moving from policy to practice and where are you on that journey, HSO developed the world's first standard on integrated people-centered health systems. So this can be seen as the policy related to advancing integrated care. Some really interesting things about this standard is that it operates at the system level. So it's really intended for that macro-meso level integration and more than one organization who serves a common population to understand where are they at in meeting the standards within this global standard. There's 10 design principles. You may have received an information sheet coming into the call today, and on that information sheet, it summarizes what those 10 design principles are. And one of the very intentional things we did with the technical committee that designed this standard is that you actually won't see partner with people in communities as a specific design principle, because what we did is we embedded it in all of the 10 design principles as fundamental to everything that you do to advance integrated care. I think the other thing that we did that was different than our other standards with this standards is it's intentionally aspirational. So when you open it, it is really gives the sense of if you were operating in a system that was people-centered and integrated, these are the things that you would expect. So when we published this standard, we definitely heard a very positive review around we needed something like this to help guide us in different system transformation efforts. But naturally came the question around, well, how do I actually get there? How are we actually going to achieve this, and where am I at in achieving this? And kind of what does that system improvement journey look like? Significantly around the partnership with people and communities component, I think that's really where we're going to focus the conversation today is, yes, within integrated care, there are structural processes that need to be developed. There's organizational partnerships that need to be developed. But how do we continue to advance improvement in people-centered care and that partnership with people and communities to advance integrated care? So with that, we're going to start hearing from our panel. So the way the agenda will go today is each panel member will present on their topic area for 10 minutes. I'll do a quick transition in between, and then we'll do more Slido interactive discussion at the end where we'll pose a question, we'll look at the results, and then we'll have a discussion with the panel members. But I'm so happy to be joined from Vincent Dumais, who's a patient partner and board of director member at Health Standards Organization Accreditation Canada. And he'll really be presenting on his latest research related to partnership with people. We'll then also hear from Carrie Kaluski, who's the Dr. Matthias Geisler Research Chair in Patient and Family-Centered Care, and she'll be speaking to family and caregiver engagement. And then we'll hear from Ross Baker and really hear around the leading evidence related to building capable environments related to partnership. And so with that, I'm so pleased to pass it over to Vincent Dumais. So he will start our panel today. He brings deep expertise in shaping systems and practices that truly reflect what matters to patients. So through his work, he's really championed the integration of the patient voice into care design, delivery, and improvement. So please join me in welcoming virtually Vincent Dumais, and he'll share his insights from the work that's really on the screen. Thank you.
Thank you, Samantha. I hope you're hearing me well.
Yes.
Yes, perfect. I don't know if you see me, but at least you hear me, so it's great. So my name is Vincent Dumais. I'm very happy to be here. I'm sorry not being here physically. It was a little bit difficult for me. So like Samantha said, I'm first of all a very experienced patient. I'm a severe hemophiliac. I was blood contaminated by HIV and hepatitis C in the early 80s, like many of my peers. So patient knowledge, the subjects I'm going to talk about is at the heart of my journey. And I had the chance in 2010 to co-found the patient partnership program at the Faculty of Medicine of University of Montreal. That is also known as the Montreal model. So next slide, please. I'm here first of all to talk to you about a subject that is very, very close to my heart, and at the heart of, I guess, I'm sure actually of integrated care, the patient knowledge. It's an expertise that I've been developing for decades now, as a very active patient, but also as an intellectual. In fact, many issues we're having today in healthcare are a call to action for mobilizing a lot more citizen intelligence in health. Problems of prevention and non-adherence, it's a call to reinforce the capacity of people to take care of themselves. Democratization of health information, it's a call to help patients to manage their own health information. Growth of chronic diseases, it's a call to mobilize knowledge that patients and caregivers already have to manage their daily lives. Hospital at the limit of their capacity, and we know how much it's an issue right now. It's a call to leverage knowledge to optimize the use of the system. socioeconomic burden on patients and families. It's a call to recognize that behind the burden, there is a need for knowledge. And finally, the loss of public credibility of expertise that has, grew a lot during the COVID crisis. It's a call to accelerate the translation of evidence-based information. So again, knowledge today, patient knowledge is at the center of partnership and a necessary change of perspective. Next slide, please. Or you can deploy it totally, it's going to be easier. Thank you. We can't think about healthcare system today without including patient knowledge. Focusing on patient knowledge means also a paradigmatic change in care, a major cultural shift between a paternalistic approach and a partnership approach. It's a major shift because by recognizing the patient knowledge, we at the same time recognize the patient as an actor of care. And when I said the patient, I include the family members also. We recognize the patient as an efficient decision maker, as an empowered, competent person, and as a full member of the care team. And I want to underline the action of Accreditation Canada, which was the first and I think the only yet accreditation body who changed its definition of care team and included the patient and the family as a full member of the care team. And it's a very, very important change in the way we see this kind of standards and norms. The patient knowledge is always underestimated by healthcare professionals. That's an issue. Next slide, please. And one of the reasons why it's like that, it's because patient knowledge it's not actually a new idea, but it has suffered epistemic oppression. Much has been discussed about patient knowledge for decades, but little has been studied and published until recently. So I invite you to read our paper on that of me and my colleague Audrey L'Espérance. So I'm going to just take a few times to go through this, the different type of knowledge we identified in this article. So first of all, as patients, as an hemophiliac, as an HIV positive guy, but I can extend that to every patient, even to people who have experienced different kind of healthcare conditions. We have medical knowledge. We have the knowledge of, usually we have the knowledge of the causes and physical mechanism of the disease, symptoms, options and types of treatment. We know a lot about side effects, the benefits of treatment and so on. So this is one of the knowledge that is the most underestimated by healthcare professionals. When I'm an hemophiliac, I'm getting into emergency of Friday night. The Friday night, it means that I have a big problem. I'm a very experienced patient. And when I have someone in front of me who underestimates my medical knowledge, I know I'm in danger. So the first and I think the more crucial one is one of the more crucial knowledge, because it's again underestimated, is medical knowledge. We have also navigation knowledge. So those two knowledge are what we call system knowledge. So navigation knowledge is very easy. The knowledge we develop by navigating into the system, into the processes in relation with the system. It's what we could have called it also the access knowledge. It's a very important knowledge for quality improvement. That's when we engage patients in quality improvements, they are so efficient because we have this kind of with this kind of knowledge. And I like to say that more systems are dysfunctional, more of this knowledge is developed by patients. So it's a big added value when it comes again to quality improvement. Then we have the knowledge related to ourselves. So monitoring knowledge. So this knowledge is increased today with the capacity we have to be connected to ourselves with digital items, digital technology. But it's a knowledge concerning the physical, emotional, cognitive, and behavioral signs related to our own condition. We are autodiagnostic ourselves on a regular basis. It's true for patients, but it's also true for the big part of the population today, especially since COVID. We are in the autodiagnostic process almost every week. This monitoring knowledge is very important. It's the one that helps us to identify what we have and then trigger the choice of doing such action or such action to manage an emerging condition. There is also, and I'm going to pass very quickly on that. It's called what we call embodied knowledge. There is a lot of literature on that. It's a monitoring knowledge, but a lot more interior. It's a sensory knowledge that is rooted in physical. For instance, for hemophiliac, we know that we are able to identify that we are bleeding before even feeling a pain. There is studies on asthma people, people living with asthma or diabetes, or people living with diabetes on that. It's a very personal kind of knowledge that is also very useful. If I shift to what we call community knowledge, we have obviously a relational knowledge. So it's the knowledge that we develop with our caregivers when we are in relation. We usually forget that we develop communication capacity and collaboration capacity and even ethic capacity at the same pace as our healthcare professional, because we develop them in relation with them. So for instance, when we engage patients in the training of medical students, we love engaging them for the training of communication and collaboration skills, because they are usually very competent in this kind of teaching. And finally, we have cultural knowledge. As we know, obviously, but we sometimes forget, health is determined by culture. So each one of us, as patients, as family members, we have a knowledge about our relation to health conditioned by our culture, values, symbols, norms, and so on. And it's a very important knowledge when it comes to be taken in charge by the system. So again, it's one of the first description of patient knowledge published at that time. It's a start, but it gives, I guess, an idea of how much those knowledge are important. Next slide, please. Those knowledge are important for citizens as experts in their own care, but also for patient expert in system experience. So it's useful in the perspective of having more and more patients and families engaged and efficient in their own care. But it's also the same knowledge that they mobilized when we engage patient partners in transformation. Can be at the clinical level, it can be at in education, in research, at the governance level. So that's why those, when we talk about next frontiers of people-centered care, the mobilization, the development, the consideration of those knowledge is very, very crucial to make sure that we're going to be able to deploy on a larger scale in partnership with patients and families. Thank you very much.
Thank you so much, Vincent. When this article was released, for our organization, it was genuinely a game changer. We have been partnering with patients and people with lived experience and caregivers for a number of years now. We have established a patient partnership office, But this publication really gave us a tool to really understand and better partner with those that we work with across the ecosystem of people that we work with in terms of really meaningful engagement and how people's lived experience can contribute throughout our organization. So we really embed everything that we do in this philosophy of people-centered care. From our standards development work, we have a balanced technical committee that includes people with lived experience. We have a patient partnership office, which supports internal and external learning opportunities around people-centered care. And we also, through our Accreditation Canada side, have patient surveyors who actually go in with our peer surveyors and evaluate and assess organizations based on the standards from a person with lived experience lens. The reality is, though, when we look at what we have in our standards, and when we look at some of the data related to partnership and people-centered care, we saw in March 10th in 2025, ECRI posted the top 10 patient safety concerns in 2025. And surprisingly, the year's #1 topic wasn't related to misdiagnosis or delayed treatment, but the risk of dismissing patient, family, and caregiver concerns as the top safety risk. Safety being one component of many components of quality, including access, efficiency, effectiveness, et cetera. But this reality between what we have in policy versus what we see in practice is really what that bridge is that we want to get, that bridge that we want to close. On that note, in that statistic was related to caregiver engagement as well. And I'm so pleased to welcome Carrie Kaluski to the stage, who's going to share some of her research that she's looked at related to transforming caregiver support.
Thank you so much, Sam, and thank you, Vincent, for kicking us off. And wonderful to be here, and thank you for still being here. I know it's been a long day. Everyone has taken in lots and lots of great insights and information. But I'm curious, in the room right now, how many people are caregivers? So providing unpaid support to family or friends. Hands up. Wow, exactly. And every time we ask that question, almost the entire room puts their hands up. And it's something that we typically do because we're a partner, a spouse, a daughter, a son, a mom, a dad, etc. And we don't necessarily know that we're caregivers until we get to a point where we realize, oh wow, this is actually impacting my life, my anxiety, my stress, my ability to show up for others aside from the person I'm caring for, my ability to go to work, to do and undergo my hobbies that I love. And it's at that point that we realize that the system is not necessarily in place to support any of us as caregivers. And so it's really important to consider caregivers as essential members of the care team. And I really like this quote by Beverly Johnson, who is a former CEO of the Institute for Patient and Family-Centered Care. And she said, "We have mistakenly labeled families as visitors when they are really allies for quality and safety." And this became very clear during the pandemic in many places across the world, if not everywhere, particularly in Canada. Very, very strict policies keeping families out of the healthcare system. And it became very clear, if it wasn't already known, just how important families are as an essential part of the care team, providing tons of support with activities of daily living, instrumental activities of daily living, advocacy, mobilization, emotional support, and that's both inside the walls of the hospital and other health settings, as well as in the community. And everybody felt it. Care providers felt it, patients felt it, managers, leaders, we all felt the huge impact when families were not included as part of the team. So the question becomes, and this is a question that I'm digging into as part of a large team funded by the Israeli Foundation in partnership with the Canadian Centre for Caregiving Excellence, is how do we best identify caregivers and include them on the healthcare team? Oftentimes, caregivers are saying that they feel that they're outside of the care team. They're fighting to get information. They don't necessarily understand what's going on with the person that they're caring for. And sometimes, depending on the care team, some families do feel more included, but it's a bit scattershot. Sometimes it works, sometimes people feel part of the team, and oftentimes they don't. But also, how can caregiver experiences be a catalyst for system change? So we'll be using visual participatory methods like photo voice and digital storytelling to really unpack the experiences of diverse caregivers across Peel region in Ontario, Canada, which is a very diverse region that we work in, to really amplify and showcase and share the impacts and the experiences of caregivers so we could use that as a tool for system change. So in looking at the literature that has been done, there are frameworks that look at how we can more effectively include caregivers as part of the team. And admittedly, this is within sort of our current healthcare structure, so there's a bit of a medical model flavor to this. But many have continued to say, and the framework here speaks to, the importance of identifying the caregiver in the health record. Something that seems very simple. We do it for patients when they come into the healthcare system, but we don't necessarily know who the family caregivers, plural, are. It's not necessarily just one person. Because when you identify them, then you have an opportunity to follow up, to check in, include them as part of the care team, and also assess the needs that they might have as they navigate the system with their loved ones. Also, because a lot of providers will say, of course, I would love to spend more time with the family or integrate them into bedside huddles or work more collaboratively, but when you're stressed out, burnt out, you don't have the time and you're running from one thing to the next, we have to look at how do we incentivize providers? How do we provide the time and the space within their days and schedules to really connect with caregivers? In addition to that, we need to invest in programs to provide support for caregivers. So things like respite care exist in many settings, but far and few between. Sometimes there's, 2 or 3 spots available within an organization to admit, say, a patient that might have complex care needs into a respite bed, so 1 or 2 overnight stays, so the caregiver can have a break. And there's very little capacity to provide that. Expanding access to funding for care coordinators to support caregivers and connect them to clinical information. So there's new tools like MyChart, where caregivers and patients could log into their chart to look at their medical information and have conversations with the care team, so expanding access to that. Also implementing training programs for providers and caregivers to facilitate improved communication. So training for everyone. It's about how do we work together differently? How do we ask different questions so we can get to know each other and honor the different types of knowledge that we have and that we bring to the table. And also develop, test, and improve caregiver access to technologies that foster provider-caregiver information sharing. So just making it easier to dialogue on a day-to-day basis. But there's also considerations when integrating caregivers on the team. It sounds good, like of course, there's a family member available, we want to, have them as part of the circle of care. But there's a number of things that we have to consider, and the first one is caregiver engagement. So do we actually value the perspectives that people that are typically on the outside of the care team, do we actually legitimize their experience as essential knowledge as part of the care team? And do we give them the space and the power to truly articulate what they need and feel comfortable to dialogue as part of the care team? There's also power dynamics, and we've talked a lot about in this conference power sharing and what that looks like. It can be very intimidating to be part of a circle of care where you're the only caregiver, the only family member. You have the doctor, the nurse, the other allied health professionals, maybe volunteers as well, but you're outnumbered. So how do you create that space where it's comfortable and you feel valued to open up and share as a caregiver? And also the role of professional identity and status. And so a lot of the ways that professions have been trained, we have a strong professional identity. As a researcher, I have a strong research identity. But how do we feel about experiential knowledge and tacit knowledge, sort of that in-between nuanced information that's required to truly understand a person? It's less recognized and less valued. We're not really trained to unpack that. And the boundaries between formal and informal work. So every situation where we're thinking about integrating caregivers as part of the team could look different. How do we include a caregiver without passing the burden onto a family caregiver? How do we acknowledge that people are at different stages of their journey and maybe more or less able or willing to be part of that care team? So ongoing conversations and finding that balance of what does it look like to truly have a feeling of team and really understanding what everyone on the team is going through and what they're capable of at that time. So one quick example, I was at the Institute for Healthcare Improvement conference a couple of years ago, and there is a session focusing on how caregivers are identified and included on the care team, and this is from Rush University Medical Center in the US. They were doing a 6-site implementation study, and what they did is they actually did, in the health record, identify who the caregiver was. They then were able to assess the needs of both the person that was receiving care, so the patient, but also the needs of the caregiver at the same time. So there was an assessment for both of them. Then they all worked as a group to customize a care plan. They continued to meet to look at what kinds of skills were needed for the patient, the caregiver, and the care team to deliver on a good experience. And they continue to connect on a regular basis. A key enabler is the CARE Act, which requires by policy that US hospitals identify the caregiver and also include them in conversations, particularly around the discharge planning piece. So there's policy that is then enabling hospitals to move ahead and implement this type of program. Whether or not they're doing it fully is another question, and given the climate, which I won't get into, I don't know how sustainable this will be, but they figured out a way to connect the dots and make this work. And the emerging findings at the time of the conference, at 1, 3, and 6 months, they showed that by doing these things, there is a reduction in stress and anxiety of the caregiver, a reduction in hospital stays and emergency department visits of the patient. And so a really great example of what it looks like when you have an enabling policy infrastructure and an organization that is able to work through to identify, connect with, care for, and work together with the caregiver and see the impact on stress and anxiety and utilization of healthcare. And so very quickly before I wrap up, and I just want to shout out to, I don't know if Liv Mendelson and James Gennaro are here right now from the Canadian Centre for Caregiving Excellence. They are doing incredible work in Canada by launching a national caregiving strategy, which we just elected a new government in Canada, and this is part of their platform. And there's 5 pillars. And here, I just wanted to recognize this because it shows that caregiver support is not just within an organization. The best practices that I just shared were a bit admittedly hospital focused, but this is showing that we can provide support across the ecosystem for caregivers. These are the pillars that the Canadian Centre is looking to advance as part of a strategy. So pillar 1 is about supports, programs, and services for caregivers specifically. Also, supports for caregivers in work and education is pillar 2. Financial supports for care recipients. Also looking at how to build a sustainable workforce, so including personal support workers, disability support workers, so people that are providing a lot of care, including family members, but are under-recognized and undervalued. How do we amplify and support their role? And also ongoing leadership and recognition on the importance of caregivers. So these types of supports and programs are really across health and social care, enabling people to stay in the workforce while they're providing care and not having as many financial disadvantages because they're in the caregiving role. So definitely keep an eye on this strategy. There's a link here that we can provide access to after, which lays out all of these pillars in much more detail. But really just wanted to wrap up to say, recognizing caregivers are so key. They're so essential to our health and social care system, but we do need to recognize and support them to really truly work with them as part of the team. So I'll leave it there. Thank you.
Thank you so much, Carrie. So in this recognition of partnering with people and with patients and families, in 2015-2016, Accreditation Canada took this very essential shift in language within our standards, and we went from doing for and to doing with. So when organizations are evaluated against our standards, when we talk about the care team, as Vincent mentioned, that is inclusive of the client and family. And B, it will always do something in partnership with client and family as part of that care team. It's been about 10 years since that, and we really have seen shifts in the way that our organizations who use our standards talk about partnering with clients and families. So we knew we needed to push the bar and be a little bit more bold. At Accreditation Canada, every organization who participates in our program, which again is over 14,000 organizations around the world, have to adhere to what we call our required safety practices. There are 25 required safety practices, and they focus on a very important safety imperative where the evidence demonstrates that if you do not focus in this particular area, it will be a high risk of safety and quality within that organization. This year, we released a required safety practice specifically on partnering with clients and families. When we did this, again, we heard such phenomenal feedback, this is what we need to do, but we also heard that our clients need support to actually do this in a sustainable way. So we structured our required safety practice to support not just what is it that needs to be done, but what's the continuous learning that's involved, what's the measuring and monitoring that's involved, how might you internally and externally benchmark to what you're doing, and how do you embed this as part of a continuous quality improvement program aligned with the outcomes as well. And so this really intended to create, through standards, an enabling environment to support partnering with clients and families. But there's more that can be done to really support this improvement process. Oh, sorry, I'll move through these questions. And what we see, and again, related to a patient's safety in terms of what's happening in reality, recognizing that there's many dimensions to quality and partnering with patients and family is essential to all of them. Engaging patients to reduce hospital harm. So we're still seeing that the data shows 1 in every 17 hospital stays in Canada involve patient harm, and that rate of harm is staying the same over time, and it's not decreasing. And this research concluded that effective communication and engaging patients and caregivers are key to providing safe, high-quality health care. And so there's this need and recognition that enabling the conditions and the environment within organizations, so organization leaders and the workforce within those environments can adequately and appropriately partner with patients and families as necessary. And so we're going to hear from Ross Baker around the work that he's led over a number of years around enabling patient and caregiver impact and engagement in capable environments. Over to you, Ross.
Thank you, Sam, and I want to extend my welcome and regards to everybody who's with us at this late hour in the day. So I want to build on the work that we've heard already. Vincent Dumez, who's really been instrumental in bringing the patient involvement into focus in Quebec and across Canada, and has worked as a board member of some very important organizations in Canada. And Carrie's work, I think, also stands as an important step forward in our understanding of how to engage patients and caregivers in the broader healthcare system. I'm going to talk a little bit about work that I've done over the last 15 years in this area. I started focusing on quality improvement and then turned to patient safety. And then I realized, and I wasn't the first one to do this, so maybe I was a little slow catching up, that none of this was going to really be possible in a sustainable way unless we involved patients, their families, and other caregivers in doing this. And that was the big barrier that was holding us back. We value clinical insight. We value that work going forward. But to complete the picture, we need to involve patients and families. I love this quote that comes from a report from the U.S. National Academy of Medicine a few years ago that kind of focuses on the critical activities and focuses on the reasons for why we want to do this moving forward. And just to say a little bit about why I got involved in this, it was very clear when I started to work in this in 2010 actually, that there were some exemplary organizations that had figured out some of the things to do. But as a system, we weren't doing a very good job of engaging patients and families and putting them into the conversation, not only about their own care, but about the organization of care in the various clinical environments in which they were involved. So we had a lot of important reports and talks and some research about what happened when you did involve patients and families. But despite that, and despite some requirements to do it, a lot of the activity was kind of superficial, and there wasn't a real impact by that, and there were sort of token patient engagement efforts across the board. And we had to ask the question, so what does it look like to have true patient engagement? How can we help organizations and broader systems of care, because of course people move across the system, and you might be well engaged in one environment but not engaged at all in the next environment. So that's a real challenge. How do we make the system more focused on the critical insights and steps necessary to engage patients, engage their families and caregivers, and overcome the current limitations moving forward? So in 2010, we were funded, a team of us were funded by the Canadian Foundation for Healthcare Improvement on what was called then patient engagement projects, and it was project level work, and teams from across Canada came into meetings to learn about engagement strategies and to share their experiences and their results in this work. And then we realized that we were working at a project level, but a lot of the projects really depended on the support from the organizations or systems that they were working in. And we needed to take a broader lens on this to understand what that foundational activity was. So we went out and identified key organizations and systems in the US, Canada, and England who were doing an exemplary job of patient engagement, to ask them, so what works for you and how could we spread this elsewhere? We published a book of those case studies and then work in a new organization that built on the earlier Canadian Foundation, Healthcare Excellence Canada, took this work and really helped to develop a series of tools and case studies moving forward, including the work that Carrie mentioned about the post-COVID assessment of what it took to maintain patient engagement during the COVID pandemic. In the earlier work we did, we went back and did a scoping review. This is kind of academic necessity to say what do we already know and then where do we go from that? And it was a very challenging review because the literature was enormous, but the actual lessons learned were rather thin. But Yvonne Bombard, who really led this team and provided a highly cited article on this, made some very critical sort of findings here. And I just want to, they're here on the slide, just to say that the level of patient engagement had an impact in terms of the contributions that patients could make, right? That's a very important piece, right? And I think we haven't paid enough attention to this. If we truly involve patients in co-design and not just consult them on decisions that have already been made, we can make remarkable changes. And there's evidence, as I said, from a variety of different settings doing that. And the literature supports that at a higher level. And then the bottom line here is that we're not just talking about developing a programmatic approach to involving patients. We're talking about a culture change in how things happen within healthcare systems. And so I think we've captured that a bit in the second, but the idea was to think about this in terms of the context in which this work goes on, and to really not say this is just an organizational environment, because as we move more and more into the integrated care space, we have to be conscious of and really work with this idea of building similar kinds of opportunities for patients, caregivers, and families to be involved in care across the continuum, so it doesn't look good in one setting and not so good in others. So the elements of this are fairly straightforward. We started out thinking about what are the critical components of a highly capable environment to involve patients, families, and caregivers. The first element is that we need to, and this is very obvious at one level, but not always fully fulfilled in many organizations, to build supports for patients, caregivers, and families so that they can participate in a meaningful way in the care of their loved ones and also participate in providing insight into the organizational changes that happen in those environments. So that first component is really saying let's build supports for patients to be a meaningful part of these teams. The second piece on this, which isn't so obvious, is that one of the real barriers to improving patient engagement is that, I'll say hesitation, right? The reluctance of some staff who feel that it will slow down their work if they have to wait and engage patients, right? And we have to realize that that's a critical issue here. We need for staff to understand what the contribution of patients can be and what the outcomes can be if we do this successfully. So the problem of having experience with tokenistic patient engagement is that you don't give any evidence to staff that this is something that could actually fulfill and surpass their expectations in terms of what could happen in terms of outcomes, experience, and frankly, reduce costs for the environments in which they're working. So let's think about this, the second piece around the team, and then the third piece, this only happens in environments where you have leadership committed to the idea that patients are important to involve in everything. And just as an example of how leaders can make a difference, one of the things that has driven the work of Health Service Organization and Accreditation Canada is the leadership of Leslie Thompson, who's the CEO of both of those organizations, who prior to that new position was the CEO of Kingston General Hospital. And when she took over that hospital, they were in a financial crisis. And she said to them, including the board, who were really worried about how were they going to get rescued from this financial crisis, the key to the future is to really focus on involving patients in everything that we do. And I think it would be fair to say that the board wasn't fully supportive of that idea, but they knew that this was a very capable person that they hired, so they went along with it. And the answer to their concern was, yes, this was a route forward. And so that experience and other experiences, which we documented some of this across Canada, have led to this idea of creating leadership as one of the critical pillars to create engagement-capable environments. Then a few years later, in a presentation that I was part of in the US, we talked about this idea of these three pillars, and Anna Humphreys, who was a patient partner, said, I think we need to expand this because really the piece that holds this all together are the relationships that are developed within the organizations between patients, families, staff, other patients, and senior leaders. And so this piece about relationships is in the center. And when you have that all together, it starts to reinforce this philosophy of person-centered care and partnership that I think is really critical to developing a culture that makes a difference. So Terry mentioned this. I was part of some of the work that was done in the post-COVID evaluation of the pandemic involvement of patients and the factors that were really critical for those organizations that were able to go past the idea that we had to simply deal with infection control issues and keep families out, when families really contribute in a meaningful way to the recovery from the pandemic and to the ability of patients to do well in clinical environments. So these are some of the factors there. We did a case study of one particular organization, Holland Bloorview Rehab Center, Kids Rehab Center in Toronto, which had a long history of culture. And for them, although they had some initial glitches in their involvement with patients, both the staff and the patients quickly realized that it would be a mistake to change the direction in which they were going. And so they quickly corrected that moving forward. And it was the leadership from both the patient and family side, as well as the leadership of the hospital, that made that happen. So what's the bottom line here? The bottom line is this is a very important initiative, but it still faces real challenges across many different environments. There's an investment that's necessary to really create the resources to make sure that patients, families, and caregivers are a meaningful part of the work that happens for individual patients and for the organization and the environment in which it works. And we think that an effective patient engagement really results from creating these supportive structures to make sure that patients have an opportunity to participate this on an individual level and on an organizational level to make a difference. And we need to continue to educate senior leaders and line leadership that this is an important initiative as well, so that we can end up with a system that now sees this as a natural part of the work that they do to improve care and make sure that the patient experience is maximized. At the end of the day, we need to change the culture across the board, across these systems. That's a long journey, but I think if we show the way and we highlight the exemplars that are emerging in countries across the world, that we'll be able to do this in order to provide an environment that really respects and honors the role of patients, caregivers, and families. Thanks very much.
Thank you so much, Ross. Alrighty, so we're gonna pull out our phones again and we're gonna hear from you a little bit. So today we've had the opportunity to hear from Vincent Dumais on patient knowledge, Carrie Kaluski on caregiver engagement, and Ross Baker on engagement-capable environments. And I think when we think about the integrated care standard that I showcased at the beginning of this talk, it really got us thinking around, well, as a system or at a system level, how do we start to measure, monitor, and manage the improvement journey so we can understand where do we want to go, where are we starting from, and if we implement an intervention, is it actually going to bring us down the right path that we intend? And how, if not, how do we understand that? And how do we adapt and learn so that we continuously improve so that we do see the goals that we aim to see in terms of partnership and engagement? And so we really want to hear that from you in terms of what might that look like, what might that journey look like from you, and what may you need. Just to start, in terms of what HSO and Accreditation Canada has done since publishing that standard and supporting and being partners in a quality improvement journey towards integrated care, we recognized that our assessment program needed to change in order to actually support the improvement towards this. So we expanded those who would contribute into the assessment to across the health ecosystem. So the assessment against this integrated care standard would include policymakers, system partners, and the team, which would be inclusive of people and community members. And we also changed how we assess. So typically our assessment program against quality standards at an organizational level, it looks at a kind of binary approach around have you met this standard or have you not? We know that advancing integrated care and people-centered care is a journey, and so we've co-designed over the last 5 years a maturity framework that would help looking at where are you on that journey to meet these standards. So that's just some insights, and at the end of the presentation, I will give a plug to a session tomorrow that dives deeper into maturity frameworks. But we want to hear from you, so pull out your phones, and we have about 3 discussion questions, and once we get the results, we'll pass it over to the panel to get their reflections and insights to that. So the first one, and I'll give you time to pull out your phone, is really understanding where you are and where some of your barriers or challenges might be. So to what extent do your organizational leaders understand and act to address the challenges they face in building partnerships with people and communities? And those online, again, if you go to slido.com, it's number 2922156. All right, we're seeing to a great extent. That's wonderful. To a moderate extent. Oh, moderate's increasing. To a small extent is at the bottom. That's very interesting. Oh, moderate and great are now balancing out. Ross, maybe I'll pass this one over to you from your conversation that you just had around organizational leadership. Really would love to hear from you, one, on the results that you're seeing, but secondly, around what might this information indicate and how might this data actually help support kind of advancing in people-centered care in an organization? Did you want to speak? Yeah. Is it on?
I think it's really important that we think about this data in the context of what do people want to achieve and what are they able to achieve. Because as I said before, I think a large part of the systems that we work in are paying attention to this because it's a requirement, but they're not maximizing the capabilities to really engage patients, families, and caregivers. And so we need to be a little more explicit about what's the benefit and can you measure that? And so as they're being accredited, I think they need to be very open about what the barriers are, but also
very open about what they can achieve. And I think about one of the case studies we did was at Whittington Hospital, which is in central London. And we looked at a team of clinicians that were working with COPD patients. And if you've ever known somebody with advanced COPD, it's a really tragic disease, right? And some of it's contributed to, health habits that people have. But you have to feel sorry for people who are so crippled by this. So we're quite moved to see these patients. And then in the discussion with clinicians, they said, well, none of these patients want to be in the hospital. They're here because they have these regular episodes and they require the care that we can give them. But our job is to get them back into the community. And we really struggled with that because we didn't have good connections. And so they spent time building a network with the GPs in the area and then working with them in terms of the health pathway for these patients moving forward. What were they capable of doing in order to help to maintain some level of health and to stay out of the hospital? And they were surprised that some of the GPs didn't have an understanding of what was possible to do, even with advanced COPD. And so part of this was education and bringing these people into a circle of care that enabled them to provide more care, better care, safer care for the clinical experience of these patients. So that's just a small model of what's possible. And when we get into this integrated care environment, we have to ask the question, so how do we now plan care across the environment? How do we create pathways that are going to be recognizable and use the knowledge, both the institutional knowledge in acute care, but also the community-based knowledge about what kinds of resources are available. How do we build around patients the kinds of activities and supports that they need to move forward?
And is that Jocelyn Charles I see in the audience? I just wanted to give a quick shout out. I attended one of your presentations, I think it was in Calgary, where you had primary care working within supportive housing and truly building supports where people are living in their day-to-day life. And it's that kind of model where you see the shifting of power from, please come to my clinic when it works for me, to setting up in communities to be there for them, to support them in their day-to-day. So as I saw you in the audience, I just wanted to shout you out.
Thanks a lot. I just want to share that work because it has been completely transformational in my thinking around patient engagement. We went into these housing buildings for seniors, these are low-income seniors, to try to bring them primary care and wrap care around these buildings. I have learned more from them than they have learned from me. We've had to slow down, we've had to listen, we've had to be completely flexible and reimagine the model. The model is their model. They're telling me what they need from me. And one of the most important things has been trust. I need to be there on a regular basis. And some of them just check in that I'm actually there. But I've learned so much that we need to, how flexible we need to be and how long it takes to build the trust and that relationship so that you have to really listen. So I've learned a heck of a lot this way.
Thank you so much. Vincent, I'm going to pass the next question over to you. So a similar question to the audience, but at a different level. So to what extent do your teams understand and act to address the challenge they face in partnering with clients and families? Okay, we're starting to see kind of similar data related to an organizational leader level and partnering with people and communities, but when we come down to the level of the team delivery and partnering with clients and families, we're seeing a bit of an increase in the moderate extent, but still seeing some around a great extent, although that's decreasing, and moderate extent is really significant at 60%. Vincent, maybe I'll have you comment. What I think is really interesting about this question is that we have both understand and act in this. So maybe I'll ask if you want to react to the data that you're seeing on the screen and what that might mean, but perhaps also speaking to what resources or tools or approaches that you've seen effective around both understanding and also acting to address these challenges. No? Vincent, are you able to hear me? Are you online? If not, maybe I'll pass it over to you, Carrie.
Thank you. Yeah, as I've been reflecting through all of these talks and thinking about like some of the challenges that teams continue to have, and I have a wonderful doctoral student, Emily Cordeau, who's doing an ethnography on a clinical unit in a hospital, and she's starting to see the dynamics that play out between patients and families and teams, and she's starting to challenge her notion of person-centered care. And some of the challenges that care teams have, is that they're under huge stress, they're very busy, they're trying really hard to make it work, and they're trying to partner with patients and families, maybe they're in a very high stress situation. And sometimes the compassion is not shared with each other, from patients and families to providers, and then to providers to patients and families. And what you see is a very tricky web, a very tricky dynamic, and an illumination of how important it is for all of us, regardless of our role, to be compassionate to each other, to recognize how hard it is for all of us to deliver the best care. And that's really hard to do. And as someone who, in my title, is patient and family-centered care, to say to do that, we can't just focus on patients and families, we need to focus on everyone and all of the struggles and the goals that people have and how they want to show up for each other. And I think sometimes from teams, we see a bit of this, because they're getting a lot of negativity thrown at them, and they're exhausted. And it causes people sometimes to disengage. So how do we honor that, but also honor the needs of patients and families, and create some space for all of us to take a deep breath and start to truly work together, but acknowledge with each other how hard it is. And so I just wanted to bring that part out of it, because I think it's very relational in multiple directions, but that could cause some people to disengage from that care process.
Thank you. All right, last question. Oh no, sorry, second last question, penultimate. So this is another maturity question, just like we had at the beginning, and kind of coming back to that. How does your organization, sorry, it's not another maturity question, sorry, this is about resources. So how does your organization currently understand or assess where it stands on its journey to improve partnership? So what might some of the methodologies be to do that? And I apologize, on the screen you can't see all the answers, but you should be able to see them on your phone. We have a none of the above. Oh, here we go. Self-assessment's coming up on top currently around a method to really understand. Oh, and then up jumped feedback from partners. That's fantastic. So we're seeing really that there's a multiple ways people are understanding kind of their level of partnership within their organization, but really self-assessment and feedback being primary. Did you both maybe want to speak to your experience or what you've seen in the field around or how organizations assess and understand where they're at on their journey to improve partnership?
So I think the important thing is to have multiple methods to do this. And organizations can't get a full picture if they only ask staff. They have to ask patients and families, caregivers, about their experiences and the ways in which they've benefited from, and maybe sometimes been constrained by the work of staff. But I think it's also important, there's a lot of feedback given to care environments that hasn't been well used, right? So complaints data, surveys of patients, and all of this, it has to be triangulated, right? So there isn't a single source,
but multiple sources start to point towards issues that might be important. And we have to do this with an improvement mindset, which is to say, you can't blame people for performance that isn't very high, because it's a very tough time in healthcare. It's tough for patients and families. It's also tough for staff. And so we have to work in creating some supports for patients and families, but we also have to make it easier for staff to be patient-focused and to see that as an important responsibility. You know, the reality is at the end of the day, everybody wants to go home and have dinner or breakfast with their family, right? And so we have to really work on this not from a point of view of pointing the finger at somebody or some group, but at building a system that is going to build in the opportunity to continue to move up that maturity matrix.
And also asking yourself, like if you work within an organization, are you tracking partnership within the organization, or are you tracking it within a broader ecosystem? And what does that look like when you step outside the walls of your organization? In addition to looking at all the different degrees of engagement from, you know, we see examples of like consultation and surveys, then you also move along the continuum to more co-design and leadership. And they're all good, but they have to be, as Carol Fancott always says, they have to be fit for purpose. So if you're initially trying to get a sense of how are people feeling, what are some of their priorities, surveys are totally fine. But if you're going to, you know, redesign a clinic, if you're not using co-design with people that are impacted by, you know, say if it's a COPD clinic, to use that example again, if you're not including people that have that particular condition, as well as providers that treat that condition, and people that have the power to implement a new model, then you're not going to get very far. So surveys wouldn't do the job, but co-design would. So it's about looking at, are you kind of matching your goals with the right method of engagement?
Thank you so much. All right, we're going to close with a word cloud. So really, we want to hear from you today, reflecting on your discussion. How could you, or how might you start to better understand your partnership journey? What are some of the methods you might use, or some of the new tactics that you might apply in your situation? We're seeing different forms of communication in terms of listening, dialogue, building relationships, discussions. I like ongoing evaluation, enable team discussion. Yeah, there's a lot there around just having the conversation and listening. Did you both maybe want to respond and final thoughts related to this conversation, and then we'll close?
So I think that's very important. I think that's a critical insight. So how do we create an environment where it's possible for people to have the time, opportunity, and interest in listening and to having dialogue on these issues, right? You know, we're in a very, very tough time in healthcare systems around the globe, and we have to build in more supports, build in innovative ways to allow us to accomplish some of these things moving forward, and not just be satisfied with this kind of superficial efforts to engage, communicate, link to patients, families, and caregivers.
And, you know, it's so great to see all of these relational pieces and listening being, you know, first and foremost as the kind of the biggest thing that we're seeing on the screen. But really giving ourselves permission every day to take that pause and to reflect. So we're in a good position to listen and engage with others, taking the time to do that. Because we're gonna hop on the plane, go back to our day-to-day work, and it's gonna feel like a giant game of whack-a-mole again, where we're just trying to get through the day, and we're like, this sounds good, but I'll do it later because I just don't have time. And so really making the space for it, because we will get so much further by taking that pause, reaching out to our partners, and figuring out how we could do things just a little bit better than we're currently doing them.
Thank you so much. If you can all join me in a warm round of applause for our panel and for Vincent online. Thank you so much for your conversation today. Thank you all for joining and making it to the end of the day with us. Hi, Vincent. Thank you so much. I'm going to, I'll put up a slide on the screen. I was going to put in a plug for my session tomorrow related to the maturity framework. So if you're interested in maturity assessments related to partnership with people, I'll leave a QR code that you can register on the screen. Thank you to everyone. Have a lovely evening, and happy to chat further on any of these pieces. Have a great night.
Um, dois, três, são seis. Tira lá duas, vá.
mesquita, leite de amêndoa.